دكتور سمير صباح الخير. Samir, you are muted. Dr. Samir, you are muted.
Bismillah ar-Rahman ar-Rahim. It's my great pleasure to start day 3 of the Debates of Oncology Annual Conference. Today we'll start with the lecture of Dr. Ahmed Saadeddin. This lecture was scheduled yesterday but postponed to today due to some technical reason. So it's my great pleasure to introduce Dr. Ahmed Saadeddin. He's beyond any introduction, a well-known figure of medical oncology in Saudi Arabia. Dr. Ahmed Saadeddin is a consultant of medical oncology in National Guard Hospital, Riyadh. In the coming 20 minutes or so, Dr. Ahmed will give a talk about the role of PARP inhibitors in early breast cancer and what's new in this context. Please, Dr. Ahmed.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Sharif, for this kind introduction and for the invitation. And congratulations for the success of the meeting. Can I share my screen now? Is my screen shared? Can I hear you?
We can see your screen, Dr.
Okay. Dr. Samir, صباح الخير. I wanted just to say hello. You were muted.
صباح النور يا دكتور أحمد.
الله يسلمك ويخليك. So I was given the task. Sorry for
حضرتك سعادة.
الله يسلمك دكتور. It's always good to see you and hear you.
Thank you.
PARP
Thank you.
Early breast cancer, what's new? I thought it's going to be an easy topic, but you know, when you dig into it, it's a lot of issues actually creeping to the platform. So that's my disclosure slide. I'll try to be very quick. I love this slide in all my presentations. In this one, I want to, to just sort of reassure that molecular diagnosis is becoming an essential armamentary we need to have in order to really give good service to our patients. These are the topics which we are going to fly through in the coming 20 minutes. Some concepts, what happened in the metastatic and then adjuvant, neoadjuvant, and where are we heading, and the conclusion. We all know that about 5% of breast cancer actually carry the germline mutations, whether 1 or 2. And when we take hereditary breast cancer, that percentage becomes about 30%. It's really almost 1/3. And those patients have a high risk of having disease during their life, up to 70%. And the main reason is actually having the repair process of DNA being damaged. Double-strand breaks is the most important one, and this is what is being referred to as genetic or genomic instability. The PARP is a protein, is a family of proteins. Her main job actually is to repair the DNA single-strand breaks. So you can imagine if you inhibit this family members, you might end up with accumulation of single-strand breaks and eventually double-strand breaks, which what we refer to as synthetic lethality. Very simple. So if you compare, combine this with any medications which affect DNA as well, you might expect synergism. And this is where the issue of platinum with PARP inhibition play a role. And this, a summary of the major PARP inhibitors in the market. Olaparib, most of us know about it. We use it a lot. Talazoparib is being studied, and Vivasusuma actually is being also studied in many trials. The rest are there. Rucaparib is having more and more popularity in the recent trials, but it's not yet in the market. The story started with the metastatic breast cancer with Olaparib in the Olympiad trial. I'm sure you all hear about it, and embraced the Talazoparib, and recently the Brocade 3, the Vivasusuma drug. So what happened? I think the logic behind using PARP inhibition have been mentioned. I don't want to repeat it. And the Olympiad compared the benefit and safety of olaparib monotherapy versus standard of care chemotherapy in patients with luminal breast cancer who had HER2 negative, basically, who had germline mutations in BRCA. This is a famous study, has been around for more than 5 years now. So 300 milligram of olaparib twice daily orally compared to chemotherapy in metastatic setting in a patient who had at least one line of previous chemotherapy. These are the data briefly. Almost doubling of median PFS with statistical significance, and the PFS2 as well was significantly improved with olaparib compared to chemotherapy. So here you have a drug which can give you a better outcome than chemotherapy, of course, with less toxicity. Unfortunately, the overall survival was not reached. It was not the primary endpoint of such study, and that is something we would love to see, but unfortunately, it didn't happen. So we know that olaparib does not improve survival yet in the metastatic setting. This is a recent, again, evaluation of, I think this is the most recent curve for the survival. Numerically, the survival started to show some difference. As you can see, 2 months difference, but statistically was not significant. And that's an interesting subgroup analysis when they have compared patients who never had chemotherapy to patients who had prior chemotherapy. You can see the difference is quite astonishing. 22.6 months versus 14.7 months with statistical significance. This is a subset analysis, yes, but I think it's something which we need to keep in mind. So maybe first line use of olaparib might be the way forward. What about, ER and PR status? We always thought that triple negative is, the patients where PARP inhibition might play a role, but as you can see, actually there was no, a sort of clear difference between the two, whether it's triple negative or ER and PR positive. The results were almost the same in survival. So we cannot, the only way where survival has been different was in the, as I've mentioned, in the exposure to chemotherapy. Very interesting. Nothing unusual about the side effects, but we have learned from this trial that nausea, anemia, vomiting, fatigue, neutropenia, and thrombocytopenia is something which we need to care of. And anemia was the outstanding one with neutropenia. So I think we all learned about the side effects and how to manage it as time went by. So that the conclusion, yes, it has a significantly prolonged PFS compared to chemotherapy with fewer rates of side effect, of course. And survival was not improved. We know that. The other drug, talazoparib, versus chemotherapy in almost the same setting. That is the curve. So again, the PFS was in favor of the talazoparib with hazard ratio of 0.54 with statistical significance. So the same message has been sort of confirmed with the two medications almost, around the same year. This study was actually presented later in 1 year after the first one. In 2019, the olaparib, which is, it's somehow a weaker PARP inhibitor compared to the other two, and that was the reason why people thought that even if you add it to chemotherapy, in this case, not actually comparing it to chemo, patients, can't tolerate because the anemia and thrombocytopenia and neutropenia was not as potent as in the other two medications. And as you can see, it was in favor of the combination. So this is the first time where in metastatic setting, the chemotherapy has been combined with PARP inhibitor with a good outcome. Again, nothing unusual. You might expect that when you add talazoparib to chemotherapy, you will get more anemia, more neutropenia, and more thrombocytopenia, of course. Now, that was, sort of a brief in the metastatic setting. And of course, like everything in breast cancer, can we move forward? So the drug was tried in the adjuvant setting. And this is the famous Olympia trial, which has been very recently updated in the conference. And this is the background to the study. I think it's self-explanatory. You know why olaparib has been used in the adjuvant setting or thought to be important to be used. And this is the study. So patients with germline mutations with high-risk disease. And I don't want to go into a lot of detail. They did not actually specify what did they mean by high risk. They have left it to the physicians to decide on that, who had completed 6 cycles of neoadjuvant or adjuvant chemotherapy, and this should contain anthracyclines and taxanes. They were actually divided in 2 subgroups, triple negative in one subgroup, and luminal breast cancer in other subgroup, and stratified by that, and by the prior chemotherapy given, and then randomized to receive olaparib for 1 year, 300 milligram twice daily versus placebo, to see whether this will have an impact on and this is, I don't want to dwell through that. As you might expect, most of the patients had BRCA1 and some had BRCA2, and almost half of them have adjuvant and the other half have neoadjuvant, and anthracyclines and taxanes were in the majority of patients. Premenopausal in this study were actually the majority compared to postmenopausal. This is the and I think the most interesting curve in this study. And this is the PFS, or invasive disease-free survival, which was the primary endpoint. As you can see, the hazard ratio is 0.58, indicating 42% improvement with statistical significance clearly shown. In favor, of course, of using the olaparib adjuvant setting. And it's difficult to see a subgroup of patients who did not benefit in that endpoint, invasive disease-free survival. Distant disease-free survival was not very far from that, with almost similar hazard ratio and statistical significance. So we are talking about a drug which improved invasive and distant disease-free survival. The overall survival was not statistically significant. Numerically, it is in favor of the adjuvant olaparib, but statistical significance was not reached. And remember, this was not the primary endpoint. But as you can see, after you stop the medications, there's a carryover effect, and the curves started to separate. Are we going to see this translating into statistical significance in future? I think we need to still wait and see. This is just to show it to you, but it's nothing unusual about the side effects. Of course, you expect more side effects with a full year of olaparib. Never mind the financial toxicity as well. It's really something we need to think about. So that is the conclusion of this study, which is, to me, the most important study in this presentation, that yes, the invasive disease-free survival and distant disease-free survival were reached, but the overall survival yet to be seen in that one. So whether we take this as a sufficient endpoint to change our practice, or we have to wait for overall survival, I think we can take it into discussion. But to me, I don't think we are yet ready to include olaparib routinely in the adjuvant platform yet. Maybe we can talk about it later. Again, as a lot of things which happened in breast, things in the adjuvant have been moved to the neoadjuvant setting. where the tumor is there. So if we add chemotherapy, if we add PARP inhibitor to chemotherapy, why? Synergism is something which, as I've mentioned, especially with platinum, need to think of, but we have to be aware of the hematological toxicity. And as I've mentioned, the Velaparib is the weakest, which is somehow is an advantage because you can combine it with chemo. This is a list of the trials which is being either carried out or still in the conduct in the neoadjuvant setting, and namely, part of ISPY2, Brightness, and Chipara-Ola, and partner also, the medications listed and so on. That's a good summary for you to go back to. So in the ISPY2, as you can see clearly, patients who had HER2 negative, hormonal positive, stage 2 or 3, measurable disease, phase 2, they are randomized either to receive, what most of us would use, paclitaxel 12 weekly, or, Pacli plus Veli, and to be followed by the usual AC chemotherapy. And then they will have surgery. And the primary endpoint is actually the PCR. Can we, as we always aim to have a better PCR? What happened? PCR was 33% in the, Velaparib arm compared to 22% in 44 patients treated with the control. And it seems that the benefit was restricted to the triple negative patients, but on the cost of more hematological toxicity. 71% neutropenia versus only 2% in the arm which has no Veli. Thrombocytopenia, again, much more, and anemia. So carboplatin, as we all know, is an easy drug to give, but when you give it with the weakest PARP inhibitor, you actually face significant toxicity. Brightness is the other randomized phase 3 trial this time, good number of patients. They were randomized either to Veli plus Carbo plus Pacli, or Carbo plus Pacli alone, or Carbo or Paclitaxel alone. And this has been followed. That is the characteristic of patients, nothing I think we need to stop in. And this is what happened. Patients who had breast conservative surgery, the PCR rate in the arm which received everything was 55.3%. In the patients not candidate for breast conservative surgery, the PCR rate was 32%, which is not bad at all. And the data on, again, who were planned for breast conserving surgery was 49%, and who were not planned was 36%. So the good percentage of patients actually have been moved from non-conservative into conservative. So with germline mutations, the PCR rate was 57% in the combination arm, 50% in placebo, and 41% in control paclitaxel arm alone. So there is some differences, but it's not really, if you compare, Carbo Pacli versus Carbo Pacli plus additional Vili, the difference is minimal. And that difference was not statistically significant, okay? Although the trial was not powered to detect statistical significance between the subgroups, and the survival data is not yet available, and the hematological and digestive toxicity were, of course, more frequent in the carbo-treated patients. And the main advantage was the rate of progression. We all are sometimes afraid that patients on the adjuvant might progress. The rate of progression in the combination arm was 4.8 in the Veli and 5% in placebo Carbo, and 12% in the double placebo arm. So maybe, it is important to see that the rate of progression is somehow less with the Veli. But again, I think this needs to be looked into more carefully. This is another trial where olaparib was associated with 3 weekly carbo and weekly Bacli, 4 cycles standard tetracyclines, a triple negative with basal phenotype or germline mutations, of course, non-metastatic. And they have done it in 2 stages. Stage 1, where 150 BD, day 2 to 10, and the other cohort was day 3 to 14. And they have included around 159 patients. As you might expect, neutropenia, anemia, thrombocytopenia was significant, but febrile neutropenia were uncommon. And fatigue and diarrhea has been observed. That was a recent preliminary report. We are still waiting for the efficacy data on that one. What about using PARP as a single agent? So we have a cohort of patients who did not have surgery yet, and they have been given terazoparib per day for 6 cycles, each cycle 20, so 6 months actually, and then they go for surgery. And this is the PCR or the RCP scoring system. We are still waiting for the data of that one. So in conclusion, in the neoadjuvant setting, this is not yet a standard of care, and hematological toxicity, it's not easy to ignore. And we need additional data actually to consider this as a standard platform for treatments. But the data is interesting. Where are we heading? There is a nice window of opportunity trials in which biopsies are obtained, and pre and post surgery, and to compare the molecular biology profile. And many trials are being conducted, whether olaparib alone or in combination with anti-PD-L1, namely durvalumab, and we are still waiting for that. Another strategy is actually using this with the radiation therapy, especially in inflammatory breast cancer. Very interesting data, and I think this is an important cohort of patients where we need to do much for them. I don't think we are really gaining significant in inflammatory breast cancer, and maybe this is a window for improvement. Immunotherapy with olaparib, again, many studies are being taking place. This is a DORA study with maintenance of immuno plus olaparib in platinum-treated metastatic triple-negative breast cancer. We are still waiting. This is another study in metastatic breast where, again, a combination of both until disease progression is being tested. So, it's going to be expensive therapy, immuno plus olaparib, for maybe a long time if there is a good response, and financial toxicity is important. Another study which we are waiting for, where cisplatin has been used with the classical AC, both for 4 cycles before surgery. There was no difference in actually PCR for cisplatin in this population. And these results suggest that actually using platinum in the neoadjuvant regimen might not be the optimal comparator to PARP inhibition, at least in the neoadjuvant setting. Very interesting thoughts on that one, and I'll come back to that. What are the challenges we are facing? I think clearly we know, we need to really know who is going to benefit from PARP inhibitor alone or in combination with chemo. We need some protection. We missed that big time. What about the practice population? Those are really, especially in our society, I think we have quite large number of practice, which we don't know what to deal with. You send the patient, they tell you it's BRCA negative, and she had bilateral breast cancer, ovarian cancer. Now I have 2 patients like this, and you keep doing BRCA and it's negative. So those patients, I think, have practice, and we need to know what to do with them. Does PARP inhibitor help in these patients or not? I think data has to be clearly shown. And the tolerance profile, whether alone or in combination with chemo, is actually something which we need to learn about. So in conclusion, yes, there is anti-tumor activity as a single agent. When compared with non-platinum chemotherapy, olaparib, and talazoparib, improved response rates, PFS, and quality of life, no doubt, in the metastatic setting. And when combined with platinum-based chemotherapy, olaparib, yes, increased PFS, but remember the toxicity was significant. Yet, no overall survival has been proven. And the olaparib did not improve BCR. That's, as I said, it's a weak PARP inhibitor in the neoadjuvant setting, so it should not be considered. Talazoparib as monotherapy, I think it has the most impressive single agent. The potential incorporation of immunocheckpoint inhibitors in the neoadjuvant setting or in the adjuvant setting is being actually tested. The Keynote 522 is running. Please don't forget financial toxicity, especially if you are comparing it with immunotherapy. The future of PARP inhibition early setting could be an alternative, potentially less toxic but highly effective chemo-free regimen, as illustrated in Tara neoadjuvant study. I think that is maybe one way to think of using monotherapy PARP inhibition without chemo early in the disease course, and maybe this will leave room for maybe adjuvant later on, and the timing would be the best to use it. I think we need still to learn, but thoughts for future. Mechanism of resistance. We need to know what's happening. We need to know what are the predictive markers, and we need to really to see what's happening to other subgroups of breast cancer patients, not only germline mutations, as I said, BRCA, maybe the others as well, luminant with no BRCA or BRCA mutations. So the platform is actually rich, and there's a lot to learn, and there's a lot of data which we need to observe. And I think PARP inhibition is here to stay in germline mutated breast cancer, but we need to learn to whom and how to use it. Thank you very much. I cannot hear anything. Dr. Samir?
Dr. Ahmed, can you hear me?
I can hear you now, yes.
Okay. So, Dr. Ahmed, I think we have just a few minutes for discussion before moving to the GI session. Till we have Dr. Shadia. Okay.
Dr. Ahmed, can I ask you?
Yes, of course.
We have a question from Dr. Shadia, then we'll move to your question, please.
Dr. Ahmed, صباح الخير.
No, Shadia.
Just a quick things about the adjuvant treatment now, with this new data that comes on the patient who would benefit from adding the PARP inhibitors in high-risk patients. We know, when we treated these patients, in ovarian cancer, the progression-free survival was only what we have been getting, yet delaying progression in, platinum-sensitive ovarian cancer was a good indicator, to be used for this medication. So what would make a difference in your practice? When do you think, we have one study now, it's positive. When would you change your practice to include the PARP inhibitors as a part of adjuvant treatment in early triple-negative breast cancer?
Thank you, Dr. Shadi. Very, very interesting. And the most, I think, important point which needs to be illustrated clearly. I don't believe we are yet at a practice-changing data. Remember, the study has been carried out for many years now, and the way we deal with breast cancer is different. In that study, there was no neoadjuvant treatment given. Remember, they all actually adjuvant setting. In the cases which were included in that study, most of them now we give them neoadjuvant. So Now, in the neoadjuvant setting, if you have triple negative, you know that you need to give, capecitabine. We have data on capecitabine post-neoadjuvant. And there's no comparison between that strategy and using PARP inhibition, as adjuvant setting. So I think, unfortunately, the data is a little bit late in the platform. We know exactly how to deal with the triple negative, for example, germline mutations, but it's interesting to keep it in mind, maybe for some very high-risk patients, not everybody. So I'll be very selective in a patient whom I'm going to use adjuvant olaparib for. I think there are going to be few patients, not really as you might expect.
I guess we have a question from Dr. Samir Shahata. Dr. Samir, please.
Dr. Ahmed, thank you for excellent presentation. Phase 1 trial showed that talazoparib is more potent than olaparib by 200 times. So which is better to start with? Talazoparib or olaparib, especially the profile toxicity is the same.
Yeah, thank you again, Dr. Samir. I think we have at least 3 medications now. If you are going to use with chemo, Veli is the drug which you need to think of. If you are going to use it to compare it to chemotherapy alone, I think Tali is more potent and equal, But the most important, if you are going to use monotherapy without chemotherapy, I think Tali will win the race eventually. We have no comparative data on efficacy, but I think Tali is here to stay because of that. Now, does this potency will translate into maybe more toxicity when we reach phase 4, data? We are still yet to see. But yes, I fully agree with you that Tali seems more sort of impressive compared to olaparib. But as you all know, olaparib, we know it very well. We know how to deal with it, and we need to learn more about talazoparib in future. But you are absolutely right. It's a drug which is impressive for monotherapy. At least I think in the neoadjuvant setting, if one would like to use one, maybe Tali would be the one future study will concentrate on. Thank you, Samir, for this.
Thank you, Dr.
Thank you very much, Dr. Ahmed. And actually, as you said, the Olympia trial is a very important trial. Yes, we may need for some longer follow-up. However, it's quite impressive to have this improvement in hazard ratio 0.56 in the early interim analysis with the short follow-up. This is unusual in the adjuvant setting, actually. However, we'll wait for more data. And of course, it will raise more questions how to position, for example, capecitabine, what to do after if you use neoadjuvant talazoparib or other PARP inhibitor as you presented, if this is approved later on, what to use in the adjuvant setting. A lot of questions will come in the near future, inshallah. Okay, I think it's time now to conclude this talk, and thank you very much, Dr. Ahmed Saaddin, once again for a very comprehensive session and discussion. And now I will invite Dr. Shadi, Dr. Hani Taani, and other colleagues to chair the next session of the GI cancer.
Recording.
Good morning, Dr. Sharif. We are unable to hear or see what's happening.
Dr. Kanan, we're just having a technical fixing right now, and hopefully you can hear. Can you?
Yes, we can hear you, Shadi.
Okay. طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء سيدنا محمد وصحبه أجمعين. So we're starting now the GI session, and before starting, I'd like to thank my colleagues in King Abdullah Medical City and specifically Dr. Sharif for their success on conducting this event now in a third year in a row. This is a very nice event where I get an updates about all types of malignancy, and it's my honor to be among the panel this this morning. So for this GI session, I'll be chairing the session with my colleague Dr. Hani Ta'ani who was previously with us, and until now he's with us. He's back to Jordan, who's joining us today, coming from Jordan. Dr. Kanan al-Shammari, also our consultant medical oncology from National Guard in Riyadh. And Dr. Walid al-Salawi, our consultant medical oncology from King Fahd Specialist Hospital. I'll start with introducing the first speaker. So our first speaker is Dr. Ashwaq al-Ulayani. Dr. Ashwaq is a consultant medical oncology in King Abdulaziz Medical City National Guard Ministry. She is a well-known medical oncologist treating GI cancers, and she's the head of the NCCN MENA region. Dr. Ashwaq will be talking about the role of circulating DNA in early colorectal cancer from prognostic and predictive value. So the mic is yours, Dr. Ashwaq. We can see your screen right now, so you can start.
Assalamu alaikum and good morning, everyone. I would like to thank Dr. Sharif for conducting that meeting and all the chairperson and panelists. And I have to apologize that I have to leave right away after this because I have a plane to catch. I'm so sorry for that. So I was giving the task of talking about liquid biopsy in early rectal cancer. And if you think about the circulating tumor, it's an old concept since the 18th century, so it's not something new. How we can get these liquid, we can get it from different parts of the body, blood, serum, plasma, urine, CSF, and saliva. And looking what exactly we're looking when we're looking at the circulating DNA or circulating tumor cells, we're looking for the RNA, exons, and DNA, and we're looking exactly to amino acid change, nucleotide changes, and the frequency of that changing to make a conclusion about the disease and diagnosis. So why there is an advantage of the liquid biopsy over the tissue? It is non-invasive. It can check within the tumor heterogeneity, and it's dynamic and real-time analysis. So it can give us a good look within the same patient, because if we are doing a tissue biopsy, you're going to take one piece of tissue from one part of the tumor, and we're going to leave the rest of the tumor that maybe there is a different clone in cells that we're going to miss. And at the same time, if we have the same disease in different patients, the biology of the disease are different from patient to patient, and definitely the mutation within these patients will be different, and that will impact the diagnosis, treatment options, and even the relapse and prognosis. So if we look at what is the clinical application of the liquid biopsy, it can be as good an early detection. We know the concept of having the liquid biopsy in developing resistance, especially for RAS patient, and looking for new mutation and more targeted therapy will develop in metastatic disease. But yet this concept will prove itself also on the diagnosis, prognosis, and early detection of either residual disease or early recurrence. So we'll focus on this part, which is early diagnosis, prognosis, and minimal residual disease. As we said, the diagnosis that it can be quick, it can give you a direct to what kind of investigation, prognostic information, what we can get an early phase of the disease about the molecular subtype. Sometimes we'll direct to therapy, yet we are not on the adjuvant setting looking for molecular subtype to direct therapy in patient with colorectal cancer, but probably this is the future as we see in all disease subtype on oncology. So there is too many kind of circulating tumor DNA, and we have a lot of many companies are doing that. Most of us we're doing foundation one, whether either liquid or tissue. So that's probably a repetition to what I've said. And now we're going to the early disease, how much we can get an information on that. General principle on all oncology patients that circulated tumor cells and early disease, usually less than 1%. Specifically in colorectal cancer, the data show that the tumor volume or the shed of the cells within the blood stream can be from 50 to 90. 50 in a patient probably with early disease and 90 in a patient with metastatic disease. And detection on early, like as a stage 2, it can be ranged from 10 to 15%. So on patient with resectable, and we have a diagnosis, and if the patient is not resectable, we can also, after resection, we can help on post-operative assessment of these patients on monitoring an early recurrence. And unresectable disease, it can give you hint about therapeutic implication and also about response and early resistance. So monitoring a patient who had an early colorectal cancer, like stage 1 to 3, around 30 to 50% of these patients, definitely they will have a recurrence at one stage. And with our conventional method that we do, we use like colonoscopy, conventional imaging, and sometimes we become very fancy and use PET scan and the serum CEA. These can delay the diagnosis because sometimes detection of an early disease will be hard. That's when we have to look for something different, like looking for the circulating DNA, which can get an early assessment for a disease, for a relapse. So it can identify recurrence as early between 2 to 15 months, so average of 10 months. So it might be a breakthrough that we can do circulating DNA on a patient who have treatment, even adjuvant treatment after surgery, and we can detect who are the high-risk patient and who are the patient that might have a recurrence. Probably the assessment by CT scan instead of doing a yearly CT scan can be, the length can be shortening. So in terms of prediction, there is data from prospective study of around 500 patients that the 3 years relapse-free survival correlate with the circulating DNA. So when we have the mutation allele fraction high, the 3 years relapse survival can be 9%, and it can be as high as 33% when we have the mutation allele fraction low. And a patient who receive adjuvant chemotherapy, these 3 years relapse-free survival increase, but still it is low when the patient have a high mutation allele fraction. The survival will be 25% compared to 70% of a patient with a low allele mutation when they receive an adjuvant therapy. So it can stratify and can identify a high-risk patient. We use the usual way of identifying high-risk patient, but this is probably adding a more accurate tools for these patients with a high risk. So this is a pool analysis of a cohort of patients post-surgery and looking for circulating DNA in early colorectal cancer. I know it's a busy slide. If you focus on the graph on the middle, the blue line is indicated there is no detectable DNA, and probably this is red or probably pink. They have detectable DNA tumor cells. They have worse overall survival. So also in ESMO in 2019, they look in the ideal French trial, which is stratifying the patient as adjuvant for 3 and 6 months. Everybody knows that, and we know the low-risk patient with T3N1, they're considered as low-risk patient. They add having positive circulating DNA after surgery to identify which patient will be stratified for 3 or 6 months based on circulating DNA. This is another clinical trial showing you that it does affect the disease-free survival when you have positive versus negative circulating DNA. Looking more before even applying surgery in the neoadjuvant setting and locally advanced rectal cancer. And this clinical trial, they did the liquid biopsy 5 times 4 times during the chemoradiation and 1 time after surgery, after radical surgery. And if you look at the first graph, they're looking at the patient with pathological complete response and none, and this is coming without, definitely we know that patient with pathological response, they have better overall progression-free survival, recurrent-free survival, I'm sorry. And in the graph down there, when they detect 15 driver mutation, and you can see that these patients with detectable mutation, they have even worse term of recurrence-free survival. And this graph, the P1, they look at the pathological complete response and also high-risk feature they identify by lymphovascular invasion, preneural invasion, and patient with lymph node, and also patient with having TB53 mutation. And when you look at the patient who have complete response with negative high-risk feature, they did well. Similar to the patient with high-risk feature, they do well, even if they don't present with good complete pathological response. So if you look at exactly the red line, these patients having no PCR, no pathological response, but they don't have high-risk features, so still they do have a better survival than the patient with a high-risk feature plus no pathological response. And these also the same graph with a patient with detectable mutation and high-risk feature. So you see the green line, these patients with detectable mutation plus high-risk feature, they have worse prognosis. So we have to know that we know that it impacts the recurrent-free survival, and again, it also impacts the overall survival regardless to the tumor size, location, marker, and also the size of the tumor. There's analysis more than 100 patients that confirm that baseline circulating DNA definitely correlate with overall survival, and also that's been studied in the correct trial and the patient who received placebo plus regorafenib. There is 166 patients who received placebo and more than 300 patients received regorafenib. When they detect the circulating DNA, they did have worse overall survival and progression-free survival, regardless to therapy, whether placebo or regorafenib. And they found also the progression-free survival was worsening on the patient with the KRAS mutation. So this is the graph, and if you see here the wild type, and this is the mutant, whether they receive placebo or regorafenib, patient with the RAS mutant, the RAS wild type, they have better overall survival than the mutant one. In terms of progression-free survival, I can see there is the difference was modest among them. That's more a bigger graph, and it shows you clearly that the patient with low DNA burden, they have a better overall survival, and again, better progression-free survival. So the circulating DNA can help in diagnosis and determine the tumor profile. And if the patient go to surgery and after curative surgery, it can identify for you the high-risk patient that probably they need either longer adjuvant therapy or strict follow-up because this patient has high risk of recurrence. And also it can help in systemic therapy on monitoring the patient following response and assess for early resistance. This is to show you how much sensitive the circulating DNA and predict response to therapy. In the gray shade, you can see this is the tumor burden as it's getting lower. And you can see that in the black line, this is the circulating DNA as it's getting lower. It's correlate with the tumor burden even faster than the blue line, which is the CA. And everyone knows that the concordance between tissue and plasma is more than 90%. So the accuracy, we have no doubt about the accuracy of the circulating DNA. So in 2019, we have more than 270 abstracts looking at liquid biopsy, 2 different types of tumor. And I know this is probably we're here in the present, but the future probably will be more of a liquid biopsy. It might replace the tissue We don't know, but it is sensitive. Why it's important that we have to adapt this and to educate people and to get more people trained on that, because we can repeat the the liquid biopsy more than once. It's rapid, cost effective, and you can see that how much we can get from the tissue biopsy as good and even better than the tissue biopsy. And now we know that the circulating DNA, probably most of the early clinical trial that adopt circulating DNA and embedded with each clinical trial, especially when we look for specifically for targeted therapy. And by this, I will end. Thank you very much.
Thank you, Dr. Ashwaq, for this nice talk. We'll leave the question till the end of the session. I'll leave the mic now with Dr. Kanaan to introduce the next speaker. Please, Dr. Kanaan.
Thank you, Dr. Shadi. And I also thank Dr. Sharif for organizing such a successful event. So I have the pleasure now to introduce our dear colleague, Dr. Shawqi Bazarbashi, who's a senior consultant at King Faisal Specialist Hospital and Research Center in Riyadh. He will talk to us and hopefully clarify a lot of confusion about which immunotherapeutic agents are best at which or what types of esophageal cancers. So Dr. Shawqi.
Thank you, Dr. Kanaan and dear chairman, and thanks to the organizers for allowing me actually to contribute in this prestigious symposium, as well as to Event Troop for their excellent running of the symposium. Now, I hope I don't add to your confusion. I hope I do clear some of the confusion. I'll try my best. So this is a study on esophageal cancer from the Netherlands, more than 1,000 patients. And what you can see are over the years, the different number of patients who receive different types of therapy. And that's, by the way, patients who have metastatic disease. So the arrow here shows you that up to 40% of the patient present and they don't receive any treatment. So it's actually a bad disease. Also, if you look at on the left side, you see the percentage of patients who present with metastatic disease. So about 30% or more of those patients did present with metastatic disease. On the right side of the table, you see the median survival and the 1-year survival of those patients. And you see that without therapy, the median survival of those patients is only 9.4 weeks. And the 1-year survival is 4.6 weeks. So really very bad disease. And with chemotherapy, you probably might approach 1 year, as you could see here, approach 1 year of survival. So that shows you how much there is an unmet need that we need to improve on the result of esophageal cancer. Now, this is an old slide, but I think it's a very important slide that shows you this is data from prospective trials, and then there was a post hoc analysis on the survival of patients with adenocarcinoma from stomach, GE junction, and esophagus. And what it shows you, and those patients were treated with chemotherapy, what shows you that those three curves are superimposed on each others. And in other words, adenocarcinoma, whether it's from the stomach, whether it's from the esophagus, or in the GE junction, if it's metastatic, the survival is actually the same. Now, this is an important slide because it actually shows you the molecular pattern of patient with different type of cancer in the esophagus and in the stomach. And it actually tells you, for example, if you look at esophageal adenocarcinoma, you would see that the incidence of MSI is only 0.4%, so very low. If you look at the tumor mutational burden, high, the incidence of 2%, PD-L1 is 9%. If you look at the for example, here esophageal squamous cell carcinoma, and I see that frequently. People ordering MSI on patients with squamous cell carcinoma, and the incidence here in the 63 patients was actually 0. So tumor mutational burdens are 3%, and PD-L1 is 41, and so forth. So remember, is when you actually want to order MSI or PD-L1, remember to look at what is the likely positivity in this group of patients. And this is similarly GE junction, which is sometimes considered stomach and sometimes considered esophagus. So let's look first at the data post first-line therapy, and quickly I will show you here data from chemotherapy. We know that combination chemotherapy might have a role in the second-line setting of esophageal carcinoma. If you look at the different agents that we used, paclitaxel, docetaxel, the taxane are the majority. And overall survival was not very much encouraging. So it ranges from somewhere like 5 months, 6 months to about 11 months. The first signal of activity for esophageal, for immunotherapy in esophageal carcinoma came from the ATTRACTION-1 study, which was a phase 2 using nivolumab in squamous cell carcinoma. There was 65 patients. That study came from Japan and showed a response rate of 17%. So that kind of like encouraging, and showed a PFS of 1.5%, but an overall survival of 11% or 10 months. Sorry, median PFS of 1.5 months and overall survival of 10 months, which was very much encouraging. That was followed by the ATTRACTION-3 trial, which actually was a randomized trial to confirm the benefit of immunotherapy or of nivolumab in squamous cell carcinoma in the second-line setting in esophageal cancer. So those patients were squamous cell cancer. They were randomized to the standard of care, which is a taxane chemotherapy versus nivolumab, and the primary endpoint of this was overall survival. It was for all comers. There was no PD-L1 requisition, and as you see, the overall survival, there was a 2.5 months difference in overall survival that was statistically significant, and based on this study, the drug was approved in the second-line setting. No significant signal in the subgroup analysis, and PFS was actually lower in the nivolumab. It's minus 1.7, so chemo had a better PFS than nivolumab, and of course hazard ratio was 1.08. Now the second signal was the Keynote 180, which actually used pembrolizumab in the second-line setting in patient, or second or third-line setting in patient with esophageal carcinoma. And in this case, they used both adeno and squamous, and the primary endpoint was overall response rate. Now, the response rate was 10%, median PFS was 2 months, and overall survival was 5.8 months. When they did subgroup analysis, they found that the response rate was higher in the squamous cell carcinoma, 14%, as compared to adenocarcinoma, which was 5%. And the PD-L1 negative, they actually did poorly with the response rate of 16%. And you could actually see why the phase 3 trials, Keynote, I think 560, 590, actually, the primary endpoint in this, which randomized patient to second-line investigator choice of chemotherapy versus pembrolizumab, they actually primary endpoint was patient with PD-L1 of more than 10%, and that was because of the result of the earlier study. Patient with squamous cell carcinoma and intention to treat. And to me, this primary endpoint is very actually confusing. I'm not sure why they use all those three. And when you actually have 3 primary endpoints like this, to me, you have to achieve all 3 for the study to be significant. Now, If you see the characteristics, there was only 1/3 of the patient adenocarcinoma and 2/3 squamous cell carcinoma. And if you look at the primary endpoint, the overall survival improved by 2.6 months, which was statistically significant. So it achieves one of the primary endpoint. For overall population, there was only 1.1 month improvement, which was not significant. And also overall survival, in the intention to treat was not significant. In the squamous cell carcinoma, it was not significant. In the intention to treat, it was also not significant. So let's go to the first line setting. And now I think the second line setting is all obsolete because many of us will be treating their patients with in the first line setting. So the first study that was actually done, or I would like to present, is the Checkmate 648, which is using nivolumab with chemotherapy or with nivo-ipi in the first line setting of squamous cell carcinoma. So just to make you aware, so Bristol Myers with their Checkmate trial, they actually treated histology. So they treated squamous cell carcinoma and they treated adenocarcinoma in different trials, regardless of the location. While when you look at the MSD, they've actually looked at location. So they treated in their keynote trials esophageal cancer with Pimpro, regardless if it's adeno or squamous. So that will actually help you so that you don't get confused. So this trial is looking at adenocarcinoma 648. What I remember, esophagus 648, stomach 649, which actually go in line. So this is the study design, 3 arms. The standard arm is the chemo, as you see, 5-FU cisplatin, and the 2 investigational arm, chemo with nivo or nivo with ipi. Now, here will be the confusion. The primary endpoint is overall survival and PFS. So you have to have 2 co-primary endpoints, and they're looking at the tumor cell PD-L1 more than 1%. That's the primary endpoint, not CPS, not combined positive score, tumor cell PD-L1. Now, so this is what we have. About 50% of the patients that they included. So they included everyone, but 50% of the included were PD-L1 more than 1%. Now let's look at the overall survival. This is on the left-hand side, you see the primary endpoint. One of the primary endpoints, which is actually overall survival, with adding nivo to chemotherapy versus chemotherapy alone. So you have a difference of 6.3 months, and this was statistically significant. Now, on the right-hand side, this is all randomized patients, regardless of PD-L1 status, and you have a 6.5 month overall survival, also statistically significant. This another endpoint, which is progression-free survival, a 2.5 months difference in those with a PD-L more than 1%. So this trial met its 2 primary endpoint, and in all randomized patients, there was no difference in the progression-free survival. Now, when you try to dig in the subgroup analysis, you see patients, for example, with a PD-L1 less than 1 did not benefit, but so as females and so as patients with who have recurrent local regional disease. So it's very difficult to actually make decisions based on the subgroup analysis. Now, this is an overall survival of the primary endpoint with those PD-L1 more than 1%, 4.6 month improvement in survival, and this is all randomized trial, all randomized patients, 2.1 months difference in overall survival. Now, we're talking now on nivo-ipi. So nivo-ipi also, as compared to chemotherapy, there was a slightly lower improvement, but positive improvement in overall survival, 4.6 months, and in all randomized patients, also intention to treat, 2.1 months. Now, when you go to progression-free survival, there was no difference. In the nivo-ipi had a lower PFS of 0.4 months as compared to the chemotherapy. And of course, in the all comers, the Nivo-Ipi had much lower PFS, 2.9 months as compared to 5.6 months. Now, the second trial in esophageal cancer was the Keynote 590. And as I've told you earlier, they've randomized patients with esophageal cancer, whether it's adeno or squamous, to the standard of care plus placebo. So this was a placebo-controlled, and the chemo that was used is cisplatin 5-FU versus the same plus pembrolizumab. Once again, primary endpoint was overall survival and PFS. So you have two double endpoints or co-primary endpoints, and regardless of the PD-L1 status. Of course, there was stratification according to squamous cell or adenocarcinoma. So let's look at the data. So first of all, once again, 1/4 of the patient is adenocarcinoma, 3/4 are squamous cell carcinoma, and PD-L1 CPS more than 10 is actually about 50% of those patients. Now remember, the primary endpoint has nothing to do with the CPS. On the right-hand side is your primary endpoint, which is in all patients, a positive result, 2.6 month improvement in overall survival, hazard ratio of 0.73, that was statistically significant. Now, that was a secondary endpoint. Patients with a PD-L1 more than 10, and you have a 4.1 month improvement in overall survival, hazard ratio of 0.62, statistically also significant. Once again, now they looked at patients who are squamous cell carcinoma, which is about 3/4 of the patient. In CPS more than 10, you have 5 months improvement in overall survival, hazard ratio of 0.57, and in all comers squamous cell carcinoma, regardless of their hazard ratio, regardless of their PD-L1 percentage, you have an improvement of 2.8 months in overall survival. Also, that was statistically significant, hazard ratio of 0.72. Now, PFS, unfortunately, that was not significant, especially the primary endpoint. In all patients, it was actually only 0.5 months, which was significant, but I think that was statistically significant, but probably not clinically significant. When you look at the subgroup analysis, you see the benefit is probably equal in squamous and in adenocarcinoma. This medication was approved by the FDA in all comers in EMEA in patients with PD-L1 CPS more than 10, because those data, although it was secondary endpoint, were more impressive. The second or the third trial that I would like to discuss with you is actually the Checkmate 649, which was looking mostly at gastric, but also, as I said, they looked at adenocarcinoma of the gastroesophageal area. So adenocarcinoma of the stomach, adenocarcinoma of the GE junction, adenocarcinoma of the esophagus. And once again, 3 arms, chemotherapy alone, Nivo-Ipi, or a chemo with nivolumab. And the primary endpoint this time was both overall survival and PFS in patients with PD-L1 CPS combined positive score more than 5. And this is the statistical consideration. It's a very actually complicated one to go through it. Just want to show you that there was a 30% of those patients who either were GE junction or esophageal. So you can actually, we can talk about it in esophageal cancer. The trial met its primary endpoint. There was an improvement in overall survival with the 3.3 months improvement, hazard ratio of 0.71, which was statistically significant. Now, if you look at those with the PD-L1 CPS also more than 1%, there was also an improvement in overall survival with a 2.7 month difference, hazard ratio of 0.77, and also in all randomized patients, all comers, regardless of their PD-L1 status, a 2.2 months improvement in survival that was also statistically significant, with the hazard ratio now coming to 0.80. Now, if you look at the progression-free survival, now the benefit is becoming lower. So improvement in progression-free survival of 1.7 months, that was also statistically significant. Hazard ratio was 0.68. Now, this is just a repetition of the two primary endpoints: overall survival and CPS more than 5, 2.2 months, progression-free survival 0.8 months. And also, this was one of the trials that reported some quality of life, and you see that the time to deterioration of the performance status was actually improved when you add Nivo with chemotherapy. It does not deteriorate. And remember, I did not show you toxicity because of the time limit, but there was no unusual signal with adding immunotherapy to chemotherapy. And in those who looked at the quality of life, or some of them have not been reported yet, there was no deterioration in the quality of life. Now, this is looking at Nivo-Epi versus chemotherapy, and that was actually negative. As you could see here, in the CPS more than 5, Nivo-Epi had a hazard ratio of 0.89. That was not significant. And in all randomized trial, also the hazard ratio was 0.91, which was not significant. And PFS also was much higher in the chemo in the chemo arms than in the Nivo-Epi. So Nivo-Epi in adenocarcinoma was actually not successful. However, when they looked at the patient with the MSI high, whether you look at the Nivo-Epi or you look at the chemo plus Nivo, there was, of course, a significant difference. Here, Nivo-Epi as compared to chemo alone, the hazard ratio was 0.28 in those patients with the MSI high, and in the chemo-Nivo versus chemotherapy, the hazard ratio was 0.38, with a 26-month improvement in overall survival. Remember, if you look at those who are microsatellite stable, they continue to have a benefit with the 2.3 months in overall survival. So the benefit was not driven by those who are MSI high. Finally, I would like to show you quickly the 811 trial, Keynote 811, which actually looked at patients who are adenocarcinoma, whether it's a GE junction or a stomach, and they have HER2 positive. And this trial was comparing the standard, which is chemo plus Herceptin, versus adding pembrolizumab. And as you could see, primary endpoint was overall survival and PFS, double primary endpoint. Now, there was just a preliminary report of only the response rate, showing a much higher response rate of 74% in the pembro arm as compared to the placebo arm, 51%. That was statistically significant. No survival data yet. Based on this, the FDA gave pembro an accelerated approval in patients with HER2 positive, in addition to Herceptin. Finally, the Attraction 4 trial was a negative trial of nivolumab in adenocarcinoma. Now, it's a randomized trial. This is Eastern Oriental trial. They've actually randomized a patient to chemo plus placebo versus chemo plus nivolumab. Now, they've taken all comers, and the primary endpoint was PFS or overall survival in all patients. Remember, in the Keynote 649, the primary endpoint was in patients with CPS more than 5. Here, they've taken everyone. And what actually bothers me is they do not report, although the trial included patients with GE junction, they do not report, even in the publication, how many patients are actually GE junction. So the interim analysis showed that PFS was improved, but overall survival was negative. Now, I have put two tables for you. Esophageal adenocarcinoma looking in the first line setting, you look at the PD-L1, you look at the agent, and you can actually tell what is the difference in overall survival. And here, for example, it strikes you that 26-month improvement in overall survival in the for nivo chemotherapy in MSI high. But then the highest that you can see is actually in adenocarcinoma, giving nivo with chemotherapy with only 3.3 months improvement in survival. Once again, this is in a squamous cell carcinoma, and you would see that the best benefit is with nivo chemotherapy with 6.2 months improvement in overall survival. Quickly, because I think I ran out of time, adjuvant nivolumab have shown in patients who've received prior neoadjuvant chemotherapy PFS advantage. And this is the key Checkmate 577, and it shows it met its primary endpoint with an improvement in PFS, hazard ratio of 0.69. There is still the data of the overall survival was not out yet, but the distant metastasis-free survival is also statistically significant, and in the progression-free survival 2 was also significant, and this is probably a surrogate endpoint for overall survival. Now, I apologize for being for the delay. My summary slide is as follows. So immunotherapy, I think now is an integral part of first-line therapy of advanced esophageal cancer in combination with chemotherapy. Immunotherapy improves survival in the second-line setting of advanced esophageal cancer compared to chemotherapy. So not with chemo, but compared to chemo. But I think the role of it in the second line is obsolete. Adjuvant immunotherapy improved disease-free survival post-resection of esophageal cancer treated with preoperative chemoradiation. And the choice of agent, and I did specifically could not actually recommend which for you, the choice of agent will depend on many factors, be it availability, but also cost and magnitude of benefit. As you could see, there is a lot of difference in the magnitude of benefit depending on which group of patient and which PD-L1 cutoff that you use. And this is a decision that will have to be made center by center. With this, I thank you and I apologize for taking extra time.
This will create a lot of questions during the discussion panel. So I'm going to be introducing the third speaker, Dr. Samir Shahata, as Dr. Hanitan actually is having a flu, so it'll be difficult for him to introduce him. So Dr. Samir Shahata is a professor and the chief of clinical oncology department in Asyut University Hospital in Egypt. He will be presenting about the preoperative therapy of gastric cancer. How would we optimize the treatment? So the mic is yours, Prof. Samir.
Bismillah ar-Rahman ar-Rahim. Dr. Samir Shahata from Asyut Clinical Oncology Department, Asyut University. First of all, I want to thank all of you and my colleagues in King Abdullah Medical City for inviting me to chair in this important and annual meeting, hoping to be physical next year. My presentation today about perioperative management in gastric cancer. Agenda: epidemiology, pathology, management of early disease and the local advanced wrap-up. What about epidemiology? The high-risk area of gastric cancer are Japan, Chinese, Eastern Europe, and certain countries in Latin America. Low-risk area, North America, India, some Western European countries, and most of Africa. It represents the fifth most common cancer worldwide. However, its incidence, particularly in corpus and antral location, is decreasing in Western countries and related to Helicobacter pylori. According to Global 2020, cancer stomach represents about 5.6%, while the mortality or death rate from cancer stomach represents 7.7%. It means that we have a big problem as regards high mortality in patients with gastric cancer. What about pathogenesis? Gastric cancer development process undergoes a cascade from normal mucosa through gastritis to atrophic gastritis, complete intestinal metaplasia, incomplete intestinal metaplasia, dysplasia, and finally gastric cancer. H. pylori is probably a necessary condition for non-cardiac gastric cancer, but it is not associated with cardiac gastric cancer. H. pylori eradication and the frequent gastroscopy might be discussed in high-risk patients. What about risk factors? The most common risk factors is infectious factors like H. pylori and Epstein-Barr virus, smoking, salt and salty food, smoked food, obesity, group A blood, and industrial chemical exposure like rubber and coal mine. The main problem in diagnosis of gastric cancer is vague symptoms. Most of patients come with vague symptoms and wandering in the physician, medical, or GIT, complaining from either sense of fullness, hematemesis, nausea, weight loss, and all these are vague symptoms. So our patient is covered at late stage. Diagnosis: endoscopy with biopsy is the most sensitive and specific test to detect tumor and nodal. Sensitivity may reach to 98%. Endoscopic ultrasonography is important in the initial staging, especially in patients who are being considered for endoscopic resection. CT scan, chest, abdomen, and pelvis, with or without endoscopic ultrasound, should be performed before surgery to assess disease balance or stage of disease. PET-CT can improve staging through an increased detection of pathological lymph node or metastatic disease. It detects about 15% of CT occult metastasis. But in diffuse or mucinous tumor, PET-CT may be inconclusive. Laparoscopy plus peritoneal washing may be useful to rule out peritoneal carcinomatosis. Pathological classification: there is many systems for pathological classification, but the most common is WHO classification, adenocarcinoma, which include papillary adenocarcinoma, tubular adenocarcinoma, mucinous adenocarcinoma, signet ring cell carcinoma, adenosquamous, squamous, small, undifferentiated. There is another two important pathological classification system: Lorraine classification. Intestinal type represent 53%, diffuse type 33%, unclassified 14%. Meinger classification, expanding type 67%, infiltrative type 33%. What about molecular classification? Recently, molecular classification is very important in diagnosis as drug prognosis and treatment instability. Represent 15% of patients with cancer stomach. Microsatellite instability represent about 22%. Epstein-Barr virus 99%, and genomically stable 20%. TNM staging, the most common, the most important factor in staging is N stage, N1 metastasis 1 or 2 renal lymph node, N2 from 3 to 6 renal lymph node, N3 either N3A and B, A metastasis 7 to 15 renal lymph node, and more than 15 is considered N3P. Management of early and local advanced disease recommendation. According to ESMO recommendation 2021, endoscopic resection is recommended for very early gastric cancer, T1A. If they are clearly defined, two mucosa, well differentiated, grade 1 or 2, less than 2 centimeters, and non-ulcerated. But for stage 1B to stage 3 gastric cancer, radical gastrectomy is indicated, and it is a cornerstone in the management. So if we look for this gastric cancer in early stage, the preferred preoperative chemotherapy trial. Eligibility criteria: resectable adenocarcinoma of the stomach or gastroesophageal junction or lower esophagus. Patient randomized to either preoperative AC for 3 cycles, followed by surgery and postoperative AC for 3 cycles, or second arm surgery. This trial shows that perioperative ECF decreased the tumor size, downstaging, and significantly improved BFS and overall survival. The second trial comparing perioperative CF, cisplatin 5-fluorouracil acid, followed by surgery and CF versus surgery alone, and it shows that overall survival increasing with chemotherapy followed by surgery, and also disease-free survival is better in the chemotherapy arm. So perioperative cisplatin 5-fluorouracil acid significantly increase the overall survival and disease-free survival. Another trial, Buroji Trials. This applied for patients with clinical T2 to 3 and plus, or clinical T4. The progression-free survival was better also for patients received preoperative chemotherapy in the form of docetaxel, oxaliplatin, and S1. S1 is the oral form of 5-fluorouracil, all of us know that. And it was better than patient received post-operative chemotherapy plus S1. So pre-operative chemotherapy increase the progression-free survival in patients with gastric stomach early stage or local advance. Adjuvant S1 oxaliplatin was non-inferior after gastric degastrectomy. Perioperative S1 oxaliplatin could be considered a new treatment option for patients with local advanced gastric cancer. And we have this randomization for 3 arms. Arm A, patient do D2 gastrectomy followed by Xelox. Arm B, patient do D2 gastrectomy followed by S1 and oxaliplatin. Arm 3, patient do receive S1 oxaliplatin followed by D2 gastrectomy followed by S1 oxaliplatin. They comparing these 3 arms, so show non-inferiority and superiority for neoadjuvant chemotherapy followed by surgery D2 and adjuvant chemotherapy. And the 3-year disease-free survival was better in patients received S1 oxaliplatin followed by D2 surgery and lastly adjuvant S1 oxaliplatin. So preoperative S1 oxaliplatin could be considered new treatment option for patients with local advanced gastric cancer. The most famous trial is FLOT trial or FLOT4 trial. The eligibility criteria: gastric cancer or adenocarcinoma of the gastroesophageal junction, type 1 to 3, medically and technically operable, including patients with clinically T2 to 4 and the clinical N node or NZ or positive. They randomized to receive either FLOT protocol for 4 cycles, followed by resection, followed by FLOT protocol adjuvant 4 cycles. The other arm, including patients who receive ECF or ECX, fluorouracil or Xeloda, 3 cycles, followed by resection, and followed by adjuvant ECF or ECX for 3 cycles. The primary endpoint was overall survival from attention time to treatment. The baseline characteristic was more or less the same between the 2 arms. FLOT improved BFS and overall survival compared to ECF or ECX. Progression-free survival was 18 months in ECF and 30 months for FLOT. And the overall survival was better, reached 50 months for FLOT versus 37 months for ACF. So back to guidelines, version 3 this year. In patient medically fit and potentially resectable, it's in cases of clinical T1B, surgery is enough. but in clinical T2 or higher, perioperative chemotherapy category 1 is preferred, or preoperative chemoradiation category 2B. But inpatient medical fit and surgically are resectable, chemoradiation or systemic therapy. Take home message 1, float is the gold standard treatment for patients who receive perioperative chemotherapy and the surgery for operable gastroesophageal cancer. Inpatients are not suitable for triplet chemotherapy. Doublet chemotherapy can be considered. Doublet can be cisplatin or oxaliplatin based. Trials are examining float plus immune checkpoint inhibitor and float plus anti-HER2 therapy in resectable gastroesophageal cancer, but neither of these approaches are approved standard of care. Back to guidelines. The preferred regimen in preoperative chemotherapy is float category 1 or fluoropyrimidine and oxaliplatin. What about surgery? In patients with early stage gastric cancer, surgery is the only curative modality to treat localized gastric node is required, but up to 30 for resectable stage 1B, 2, 3 disease. Subtotal gastrectomy may be carried out if a macroscopic proximal margin of at least 5 centimeters can be achieved between tumor and the gastroesophageal junction, or a margin of 8 centimeters is advocated for diffuse type cancer, otherwise total gastrectomy is indicated. Total gastrectomy or radical gastrectomy divide either D1 or D2, but is the better or the standard of D2 lymphadenectomy, which include lymph node in the left gastric artery, along the common hepatic artery, around the celiac axis or splenic hilum. All these lymph nodes should be excised. What about after surgery? If our patient do surgery, you have either R0 resection, R1, or R2. In patients who received R0 resection, not positive or negative, it is better to observation until progression if received chemoradiation therapy, or can receive chemotherapy if received preoperative chemotherapy. But in R1 resection, chemoradiation with fluorouracil or considered re-resection. In R2 resection, either chemoradiation only if not received the preoperative, or palliative management treatment and systemic treatment. Is there is value from chemotherapy versus chemoradiation therapy after surgery and the preoperative chemotherapy in resectable gastric cancer? We compare between which is better to do to give the patient chemoradiation after surgery or chemotherapy alone in patient receive preoperative chemotherapy. The primary, this is the critics trial, and the primary endpoint was overall survival. This trial shows that preoperative chemotherapy, ECX or EOX, followed by surgery and post-operative ECX and post-operative chemoradiation therapy, it's survival. So post-operative chemoradiotherapy did not improve overall survival compared to with post-operative chemotherapy in patients with resectable gastric cancer treated with adequate preoperative chemotherapy and surgery. So it is better to use patient preoperative chemotherapy and post-operative chemotherapy. Adding radiotherapy add no value for this patient. What about adjuvant chemotherapy? Classic trial comparing for patients with no surgery. What is the value of added 6 months chemotherapy box or no treatment? This is the classic trial, and the patient characteristic more or less similar for patient surgery or chemotherapy plus surgery. 3 years disease-free survival. As regard the stage 2 disease was better in patient received chemotherapy group adjuvant. It is 85% compared to 71%. Even stage 3B The chemo, the patient, the group, patient received chemotherapy group was 61% versus 33%. And the 5-year updated survival box versus surgery alone, all patients 5 years overall survival was 78% versus 69%. So adjuvant chemotherapy improved in overall survival and 5-year overall survival. What about the adding of immunotherapy in patients with gastric cancer after surgery? There's post-operative nivolumab following the pre-operative chemotherapy. This patient after chemotherapy followed by surgery received either nivolumab 240 milligram every 2 weeks, 80 milligram every 4 weeks, versus placebo, and the primary endpoint was disease-free survival. Second endpoint was overall survival. The difference in disease-free survival was better in patients received the nivolumab, reached 22.4 months versus 11 months in patients didn't receive chemotherapy, didn't receive immunotherapy, and this is the Checkmate 5770. After this value of preoperative chemotherapy, post-operative, and adding of immunotherapy as adjuvant therapy, there is versa perspective or the future perspective. The Japanese trial combining the post-operative chemotherapy versus post-operative chemotherapy, perioperative versus post-operative chemotherapy. This is an ongoing trial for operable gastric cancer, comparing between S1, which is a famous 5-polar seal in Japanese and Asian, S1 and oxaliplatin 3 cycle followed by surgery, followed by adjuvant S1 for 8 cycles, versus surgery alone followed by adjuvant S1 for 8 cycles, and the primary endpoint is 5-year overall survival, and we are waiting the results. Another trial, post-operative chemotherapy combined with immunotherapy. What is the value of adjuvant immunotherapy? There's also ongoing trial comparing operable gastric cancer after D2 gastrectomy, pathological stage 3, nivolumab, 360 milligram plus chemotherapy, followed plus chemotherapy for 1 year, versus placebo plus chemotherapy for 1 year, and the primary endpoint was recurrence-free survival. And also keynote 585, this compared perioperative chemotherapy combined with immunotherapy. This compared with patients received pembro plus chemotherapy followed by surgery, and pembro plus chemotherapy adjuvant and continue chemotherapy pembro for 11 cycles, versus patient didn't receive pembro, and the primary endpoint was overall survival. Wrap up. Endoscopic ultrasonography is important in diagnosis and biopsy. Molecular biomarker testing as MSI and BDL1, since the diagnosis new recommendation may have future implication. Perioperative float is a standard of care in gastric cancer, increase PFS and overall survival. Gastrectomy only curative in localized disease. Adjuvant Cabox for 6 months is a standard of care after gastrectomy, increased disease-free survival and overall survival. Neoadjuvant chemotherapy or chemoradiotherapy not preferred unless patient not candidate for chemotherapy and surgery alone. Survivorship and monitoring of patients after finishing the treatment is an important issue for better quality of life. Finally, all of you are invited to our 13th Clinical Oncology Department of Asyut University Conference in Luxor in next February, hoping to see you physically. And thank you.
Well, thank you, Prof. Samir, for this nice and elegant talk. And we will leave the question to the end. And as we decided, we'll leave the mic to Dr. Walid Al-Salawi for introducing the next speaker. Please, Dr. Walid.
Thank you, Dr. And thank you for organizers for such very prestigious meeting. It is my pleasure to introduce the next speaker, is dear colleague and my friends, Dr. Fahad bin Shamsa. He is the consultant medical oncology and he is the chair of adult medical oncology in King Fahd Hospital, Dammam, and he is the chair of the outreach, director of the outreach program. He will talk about and he will talk taste to the systemic therapy in HCC. Please, Dr. Fahad.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you very much, dear Chairman, Dr. Walid. It's really a great privilege to be introduced by yourself as a prominent oncologist and a cornerstone in our group in Dammam. I also thank you for the other chairs of this session, and to Dr. Sharif Salmani and Scientific Committee for inviting me and giving me the opportunity to participate in this prestigious meeting. So in 20 minutes or less than 20 minutes, I'll be talking to you about HCC and transition between TACE and systemic treatment. And I think myself and my generation are very lucky and blessed to live this revolution in the landscape treatments of all cancer sites, and HCC is no exception. And that's why we see these debates and hot discussions, because now we have more effective systemic treatment, and also more effective and advanced technologies of local regional treatments and surgical procedures. That's why I will start my talk by focusing on the importance of multidisciplinary setting approach to these patients, and probably I will conclude with that too. So those who treat HCC, they know that they deal with many challenges. They see one patient, but they treat two diseases, two competing causes of death, cirrhosis and HCC. Cirrhosis and impaired liver function complicates treatment selection and patient eligibility for treatment, and complicates clinical trial design. That's why we have different modalities of treatment for HCC according to stage. This is the most recent updated Barcelona Clinic guidelines. And you see intermediate stage is treated mostly with chemoembolization and TACE. If they are not fit or refractory to TACE, they move forward to the advanced stage where patients are treated with systemic therapy. And surgical resection is best for non-cirrhotic liver or very good liver functions. It results in excellent 5-year survival of up to 70%, but recurrence rate is also high, up to 70%. Ablation and local regional treatment are considered less invasive, and they're good for smaller tumors. Survival rate is up to 50%, but also they come with high recurrence rate of up to 70%. The optimal treatment is liver transplant because it cures both cirrhosis and HCC, but it's limited by its selection criteria, and the demand is always more than supply. It results in excellent survival of more than 70% with relatively low 5-year recurrence rate of 15%. We always use the Child-Pugh score, as you can see, you are all aware of it, and it's the discussion in our liver tumor board always when to transition patients of intermediate stage from TACE to systemic treatment. And again, it's the multidisciplinary approach that will ensure the best treatment selection and the best clinical outcomes possible. So liver transplant and resection are the curative therapies for early HCC, as you can see. but recurrence rate after resection is high, and that's why there is neoadjuvant or adjuvant unmet medical need. But there are several ongoing trials to answer this question. That's why all organizations related to HCC treatment does not or do not recommend adjuvant treatment yet. So this STORM trial is a phase 3 trial that explored adjuvant sorafenib after surgical resection. I myself recruited some patients to this study during my training, but unfortunately the study came to be negative. But now we are in a different era. Now it's the immune therapy era. And look at this recent report from this phase 2 prospective multi-center study, which showed a very promising recurrence-free survival after adjuvant nivolumab. And several phase 3 studies are ongoing in the adjuvant and neoadjuvant setting that probably will change the treatment landscape. The keynote 937, we worked hard as our group and all the oncology community in Saudi to open this trial in Saudi, but unfortunately the organizing company failed to open the study in Saudi. But we're holding tight and waiting for the results of all of these phase 3 study for the adjuvant setting. TACE improves survival, but is not curative for most patients. For most patients, TACE is palliative treatment. That's why it's always important to do every effort to select the best patients for TACE and to move them to systemic treatment if they do not benefit from TACE, because our systemic treatment are getting better and better. And look at this prospective study for larger or higher risk intermediate stage. So intermediate stage is heterogeneous population, and the higher intermediate stage where either they will receive lenvatinib, systemic treatment, 30 patients, or TACE, as usual, 60 patients. And you can see, without looking at numbers, that systemic treatment with lenvatinib produced much better and clearly better and improved progression-free survival and overall survival. The response rate for lenvatinib was 70% compared to TACE 33%. Also, maybe the answer between TACE and systemic treatment is the combination, and maybe in the near future we will utilize these strategies and look at all of these very important phase 3 studies exploring the combination of systemic treatment. Of course, it's immune therapy combinations with TACE. So probably in the recent or the near future, we'll have some answers for that. Now I'll move to systemic therapy and to prove to you that we have effective treatments, and the story of effective treatment started in 2007 with sorafenib, but now we have all of this list on the right side of your screen. You see we have several effective treatments for HCC. And the story started with the landmark SHARP trial and also Asia-Pacific studies, which put sorafenib as a treatment of choice for first-line treatment, systemic treatment for HCC. That was followed a few years later with the REFLECT study, which showed that lenvatinib was non-inferior to sorafenib, and it also produced a numerically better progression-free survival. And then it's the immune therapy, of course, era, and nivolumab showed in this phase 1/2 trial a decent and reasonable response rate, and that led to the design of the Checkmate 459, nivolumab versus sorafenib. The primary endpoint was overall survival, but unfortunately the study, despite being numerically better overall survival, it did not meet its superiority statistical significance. But of course, by trial design, we cannot say that nivolumab is not inferior. However, the response rate also was doubled with nivolumab compared to sorafenib, and the tolerability was better in nivolumab. Grade 3 for adverse event treatment related were 22% in nivolumab, but 49% for sorafenib. That's why we, as HCC oncologists, we see nivolumab as an option on the table for selected patients. But the best answer came later with the IM Brave 150 study, tislelizumab, bevacizumab compared to sorafenib, and the primary endpoint of this study was overall survival. So 2-to-1 ratio, the patients were randomized to these treatments. And this is the updated OS and PFS in the last ASCO GI that showed improvement in overall survival to 19.2 months compared to 13.4 months for sorafenib. Progression-free survival was also improved. The complete response rate in this study was reported at 8 to 12%. That was never seen in HCC before. These patients, despite having a little bit preferable tolerability profile than sorafenib, it was mandated to have endoscopic evaluation for esophageal varices, and despite that, the GI bleeding rate were higher in the atezo-bev arm, 7%, but to be fair, also it was 4.5% in sorafenib arm. And the beauty of this, again, in immune therapy studies, they also improve quality of life, and here it was measured by the median time to deterioration, and it was improved markedly by the atezo-bev combination compared to sorafenib. A nice paper came out from this study that tell us that overall survival correlates and is to the response rate. So if you have a patient treated with this regimen and you see response, that predicts a better survival. Of course, this combination immune therapy is not for everybody. So patients with transplant, autoimmune disease, or active immune-mediated pneumonitis or hepatitis, they're not good for this treatment. But atezolizumab, bevacizumab is not expected to be the only one in the near future, because as you can see, very important and very effective, as we believe, regimens are ongoing studies to look at them, the LEAP, the Himalaya, the Cosmic, and the Checkmate 9DW. So very soon we'll have other options that are also a choice for first-line treatment. So because of all of these advances, now we have a treatment algorithm like this, where several options in first line and several options in second line are available, again, to discuss and offer to your patients and to use them when you sit in the multidisciplinary tumor board to think for your patients. Nivolumab, ipilimumab in a second-line setting in this phase 1/2 study also resulted in a very impressive overall survival of 22.2 months. This is yet to be confirmed in phase 3 study. And as we saw before, there's an ongoing first-line study for the nivolumab, ipilimumab. We have multiple options for second-line setting, very solid phase 3 high-level evidence for regorafenib, cabozantinib, and ramucirumab. Regorafenib produced the best hazard ratio, but of course, we will not compare between the study, and it has to be regorafenib, has to be for sorafenib tolerating patients. Cabozantinib, according to a celestial study, is good for second and third line treatments. Ramucirumab is for a clinical biomarker selected population of high alpha-fetoprotein, more than 400. Again, now we enjoy this a bit rich treatment algorithm to think and to offer our patients. And this is to improve in the very near future. We'll have more complicated treatment algorithm, and I cannot complain about that. We are really waiting to have more options for our patients. So treatments are effective if you select them for patients, but also keep in mind that now we have effective systemic treatments, and actually they're getting better and better with time. So it's always important to determine the treatment plan through a multidisciplinary approach, because it improves survival. As you can see from these different papers, all of them, they show that when you select treatment for a selected patients through this multidisciplinary approach, that improves clinical outcomes. Thank you very much. I hope I could save a few minutes.
So we will have our moderators also with us here. Dr. Kanaan is back. I can see Dr. Shawqi. I wonder if Dr. Samir are with us?
Yes, sir. Yes.
Perfect. So, well, I'll start with the first question to Dr. Shawqi, if you don't mind. Dr. Shawqi, you went through a lot of data, and thank you for actually putting all the on the kind of the results on the table. Again, we see these patients now, they comes and because the G junction, the esophageal, the gastric, so we have some classification. Some people still they're using the flood, some people they move using the chemoradiation. I know the setting for a neoadjuvant, Dr. Samir has put on that, but where do you see the immunotherapy is coming? Do you think the immunotherapy will be coming to affect that? And if so, where are you gonna, how that's gonna affect your metastatic setting for treatment?
Are you talking about early stage?
No, well, let's say now we're we're having the data coming in early setting for treating an early stage. So would you see that's going to affect your treatment in the metastatic setting?
Absolutely. So as I said, we started using immunotherapy in the second line setting. And I think now it's obsolete. Most of the people will use immunotherapy in the first line setting. So that now second line won't be used, because you will not use immunotherapy in the second line if it's been used in the first line. And similarly, if you have used it in the neoadjuvant or adjuvant setting, just like what you have done in the we have done in the esophageal cancer post chemoradiation, you won't use it in the metastatic. However, I think we have to be careful of the disease-free interval. So somebody who have received adjuvant nivolumab in esophageal cancer post-resection, and 3 or 4 years later, he recur. Would I use immunotherapy if he's eligible? Yes, I would. So it also depends on the relapse-free interval.
Okay. Dr. Kanaan, do you want to comment on that? I think we had an early discussion about that, a few weeks ago. So I don't know if you want to comment on that too.
To be honest, I don't have a comment after Dr. Shawqi, but I do have a question for Dr. Shawqi. So I thank you for the great presentation. I think you clarified a lot of issues. It is still, I think we still have so many options. So many clinical trials have different entry criteria. However, my question is a general question about metastatic esophageal, gastroesophageal, and gastric cancers. I know I'm being very broad in my question, but a lot of the biomarkers are still send-out tests, Dr. Shawqi. We still have PD-L1, we have CPS score, we have MSI test, and we have tumor mutational burden. What would you order as an upfront when you're approached with a patient who's in stage 4, esophageal, gastric, or gastric adenocarcinoma? And apologies about the long question.
No problem. I think it depends on what you have made a decision in your institute to use. Let me give you an example. In gastric cancer, nivolumab, the primary endpoint was positive when it's added to chemotherapy in patients with PD-L1 more than 5, CPS PD-L1 more than 5. However, also all comers had a statistical 2.2-month improvement in overall survival. And that will actually, now the approval by the FDA is actually in all comers. It's not limited to the primary endpoint. And then that's what I said in my last slide. I think those are very expensive medications. And we need to make a decision, and I think either collectively as a country or as a center, how much you want to pay for that amount of extra survival that you will get. Will you go with the only 5 or 6 month improvement of survival, or would you take a statistically significant 2 months improvement in overall survival? It's a very, there is no right and wrong answer in this, to this question. I think each center have to look at the cost-benefit ratio and make a decision. At the end, you see a benefit in most of the cases. I mean, in esophagus, pimpro, adeno, and squamous, there is, for all comers, there is a survival advantage. In esophagus, squamous cell carcinoma, nivolumab had also in all comers and in the stomach. So there's a benefit, but there is a difference in the magnitude of the benefit. And this is very important that we should look at.
Prof. Samir, I think you
were
earlier. Please, can we go to Prof. Samir before Dr. Ali?
Dr. Shawqi, I think we should put a standard of care in our centers before treating a patient with gastroesophageal junction, because a lot of trials for immunotherapy, and the added value to chemotherapy, it is not significant or equal to the cost of treatment and the side effect of treatment. Do you agree?
Yes, I agree that it should be on a national level rather than hospital level. I do definitely agree that if the those people who treat gastroesophageal cancer sits together and agree on something, that it becomes across the board for any country, or even more than a country.
Dr. Ali,
Shadi, please.
Dr. Ali, تفضل.
Assalamu alaikum. Do you hear me?
Yeah, we can hear you well.
Thank you so much for all the speakers for fantastic talks. I would give a question to ask a question to Dr. Samir Shahata. Thank you so much for tackling such important topic of management. But I will ask about a case scenario that sometimes we encounter in the clinic, not infrequently, that patient after surgery comes with positive margin. Do you advise for any specific treatment change for those patients with positive margin?
Thank you, Dr. Ali. What do you mean by positive margin? Positive margin microscopically or macroscopically? By anyhow, if microscopic positive margin, you can add chemoradiotherapy, or you can do resurgery again for this patient if his condition is allowed. But in macroscopic positive margin, it is better to give chemoradiotherapy immediately. But the added value of adjuvant treatment
to suggest such approach? Are you aware of any studies?
I suggested to chemoradiotherapy for adjuvant in microscopic positive margin or resurgery, if our surgeon can do this. But in macroscopic or residual, it is better to do chemoradiotherapy immediately or palliative chemotherapy. But chemotherapy adjuvant only in R0 only.
Dr. Walid, I think you have a question. Comment, please.
Thank you, Dr. Shadi. My question is to Dr. Fahad. now with all of this improvement in the first line in HCC, where do you see that can combine the TACE and those immunotherapy or this modality of the systemic chemotherapy? Where will you see that, Dr. Fahd?
Thank you very much, Waleed. I think very similar to other discussions. We are seeing a revolution in the treatment landscape, and every few months you have a new evidence that will affect your approach and your thinking of treatment selections for patients. So when it comes to combination of systemic treatment to TACE, we have controversial, mostly negative studies, but that was from sorafenib era. But now we have a better treatment that are being looked at in a much better trial design with TACE. I think because when you see the number of studies, it's really a good number of studies with effective treatments. So we'll have a more complicated landscape combining with TACE. And then you have others will be approved as first-line treatment. As Dr. Shoghi now, you have evidence in different levels of and lines of treatment, and we need to be broadly really thinking and open-minded to look at this thing. I think the future, some of these studies will be positive, and we will be using neoadjuvant and adjuvant and combination with TACE, awaiting these important studies to be positive.
Thank you for all speakers for this excellent presentation, and for الذكوى اللي عندي PCR نيجاتيف، يعني ما في مشكلة للكورونا، عملته امبارح حساسة قدرت أفوت السعودية. My question for all panels, for this new era of immunotherapy and the role of immunotherapy in neoadjuvant treatment. We are all of us know that early shrinkage disease response rate بنسبة خاصة بالcolon cancer and other كمان organs. Immunotherapy response rate بضل delay respect chemotherapy immunotherapy. I showed the Dr. Samir Shahata showed some studies about neoadjuvant treatment using immunotherapy. Questions. Still, we have a role of immunotherapy in neoadjuvant treatment, knowing in the response delay. Same time, the early shrinkage of disease is very important.
I don't know, Dr. Hani, I wish to be there to say Assalamu alaikum to you personally. We miss you a lot, but inshallah we'll see you physically. So you did not say what tumor site you are asking about, but from HCC, I can tell you that the response rate is much better with immune therapy rather than the TKIs, sometimes double, sometimes even triple. So that's from this point, sounds to me promising in HCC, and I leave other tumor sites to my colleagues.
Thank you. Dr. Shawqi, what do you think?
Well, I actually agree with Dr. Fahd. If you look for colon cancer, for example, Keynote 177, response rate for the Pimpro was higher than chemotherapy. So there was 10% difference. So not necessarily in all tumor sites, immunotherapy has a delayed response or a poor response to response rate. So those where the treatment is effective in MSI high in colon cancer, the response rate was even better.
Okay. Well, thank you all. And well, at the end of this session, would like to thank all the speakers and all the presenters for this very interesting discussion that we had and the exchange of the knowledge that we had over the last 1.5 hours. With this, we'll close the first GI session, and I'll ask Dr. Sharif and the organizing committee to proceed, I think, with the second session. So please, thank you all.
Thank you.
Any break, because we're gonna just start immediately with the second session now. Thank you all.
Thank you.
Thank you very much, Dr. Shadi. The next session will be Amgen Satellite Symposium. I will invite Dr. Hani Al-Khatib to chair this symposium. Dr. Hani, can you hear me?
Assalamu alaikum. Can you hear me?
Yes, Dr. Hani, we can hear you very well.
Okay. صباح الخير جميعا. طيب بسم الله الرحمن الرحيم. أولا I would like first to thank the Amgen company who is taking the care of this meeting and allowed us to meet with our colleagues. And I would like to present our consultant of medical oncology, Dr. Sharif Al-Sammani, and to present our lecture and symposium today. And the title is about Vivasusuma biosimilar related clinical data and updates. Dr. Sharif, please.
Thank you very much, Dr. Hani, and I would like to thank our colleagues from Amgen for inviting me to present this data about biosimilar in the Debates of Oncology conference. Last GI session, we heard a lot of talk about the cost of medication, whether it is relevant to the benefit from immune therapy, and of course we have a lot of talk about the financial toxicity of the new medication. Now we'll have in the coming few minutes some solution about the financial toxicity which may come with introduction of biosimilar to the Saudi market. So we'll talk today about the concept of biosimilar, and we'll have a focus on the data of bevacizumab biosimilar compound, and we'll cover some of the practical challenges of the introduction of biosimilar, and we'll finish this talk by having some insights about the pharmacoeconomic impact of the introduction of biosimilar. So first we'll talk about what is biosimilar. We have multiple definitions. We have definition coming from Europe, from the EMA. We have another definition from the FDA. They are quite similar, but myself, I prefer the FDA definition. Biosimilar is a biological product that is highly similar or quite similar to the reference product, except for some minor differences in the clinically inactive component or inactive part of the compound. It is quite similar in terms of purity, efficacy, safety, potency to the reference compound. So this is biosimilar. So biosimilar are products coming from the living system, coming from the similar to the target therapy or monoclonal antibodies coming from the living system like cell lines, and they have only minor differences in comparison to the reference product. We have the story of biosimilar started several years ago, starting maybe 2007 with the introduction of the biosimilar erythropoietin. Then we have another products, and recently we have biosimilar trastuzumab, we have biosimilar bevacizumab, in addition to rituximab and other compounds. So actually, the development of biosimilar products is very strict, and there are multiple steps that need to be strictly followed to have robust data about the efficacy, safety, and similarity of the biosimilar to the reference product. This step starts with certain chemical analysis to make sure that this product is quite similar to the reference product. We can accept certain minor differences that will not affect the active component of the reference compound. After having this robust clinical analysis or chemical analysis, we have some animal studies to check for the toxicity of the biosimilar compound, some immunogenicity to check that there is no more immune reaction, and we have some data as well about the activity of the biosimilar product in comparison to the reference one in animal models. Then after this preclinical data, we'll move to human testing, and in human analysis, we'll start with looking for the pharmacokinetics of the biosimilar in comparison to the reference product. And after making sure that everything is quite similar in terms of preclinical, clinical data, now it is the last step to move to have some clinical trial comparing the biosimilar product to the reference product. And this is the end step of the development of biosimilar. To make sure that everything is perfect, everything is quite similar to the reference product. So when we shift from the reference product to the biosimilar, we are quite sure that everything is okay. So this is, again, this is we can classify the development of biosimilar into two main steps: preclinical assessment and clinical assessment. As we said before, chemical analysis, in vivo studies in animal models. Then we have human analysis or human assessment in first with pharmacokinetics, and then we have comparative clinical studies. But we have quite important difference between the clinical studies in the biosimilar compared to the reference product. When we are talking about the reference product, for example, trastuzumab or bevacizumab, we need, after having some preclinical data and early clinical studies, we need to test, for example, bevacizumab in every indication. We need to test the efficacy of bevacizumab in lung cancer, in GBM, in colon cancer, in everything. We need to test the efficacy in every clinical trial. Trastuzumab is the same. And for breast cancer, we need to test it in adjuvant setting, neoadjuvant setting, metastatic, first line, second line. So to have the indication in every setting, we need to have a clinical trial in every setting. However, this is not the case of biosimilar. In the biosimilar, we can invest a lot of money and a lot of time in the early phases of the exploration of the biosimilar product, the chemical analysis, some preclinical data, pharmacokinetics, pharmacodynamics. And after making sure that everything is okay, we need to have only one clinical trial to demonstrate the similarity in the clinical trial between the biosimilar and the reference product. And then after that, actually, there is no need to test in every indication, because we know that trastuzumab is working in adjuvant, neoadjuvant, metastatic. Why to repeat the clinical trials in every indication, as long as we are now make sure that everything is quite okay and similar to the reference product. So the next step after demonstrating the similarity between the two products is to extrapolate the indication to other approved indication of the reference product, indication 1, 2, 3, or 4, as long as we have proven that in one clinical trial that we have similarity between the biosimilar product and the reference one. And there are certain assumptions that we need to make sure that everything is there before making that extrapolation. We need to make sure that the mechanism of action in different indications are the same. For example, for trastuzumab, it is working in the same mechanism against the HER2 receptors in adjuvant, neoadjuvant, metastatic setting, everything in gastric cancer. So it is working in the same way in every indication. So if we extrapolate from one indication to another, I think it's okay and we can proceed with this approach. So the second part of this talk is to look for data about the development of bevacizumab biosimilar. This is bevacizumab biosimilar developed by Amgen. The name of this product is Imvasi, or the original name is ABP 215. And it is approved by the American FDA in the all indication, while the reference product Avastin was originally approved, as you can see in this label. Let's look to the steps of the development of the bevacizumab biosimilar. It started with, as we said before, chemical analysis. Then we have demonstrated the similarity to the reference product in animal models in terms of toxicity, immunogenicity, and some activity as well. And after demonstrating that in animal models, they went to the human assessment. We have some pharmacokinetic assessment in humans, and they compared the similarity of the biosimilar bevacizumab, ABP 200 0.15 in comparison to the Vivasusumab from US and Vivasusumab manufactured in Europe. And this is actually required by the regulatory authorities to be able to register the new biosimilar compound in Europe and US as well. And this pharmacokinetics has been demonstrated as well. You can see the serum concentration of the three products. The curves are quite overlapping, the same curve actually. So this pharmacokinetics have been demonstrated. So now it is the time to move to a clinical trial comparing the reference product to the biosimilar Vivasusumab. And here we have three types mainly of clinical trials: superiority trial, non-inferiority trial, and the third type is what's called equivalence trial. In equivalence trial, we need to demonstrate that the experimental product is not inferior but not superior to the reference one. So we have two margins, upper and lower margins, and if the new product lies within the two margins, we can say that equivalence is demonstrated. And this is the design that is adopted in the clinical trials of biosimilar products. And of course, we have multiple indications for Vivasusumab. When we would like to choose one of them, we choose the indication that's more likely to be sensitive to Vivasusumab, and we have chosen to test Vivasusumab against a reference product in non-small cell lung cancer. So this is a clinical trial, equivalence trial, where patients with a stage 4 non-squamous, non-small cell lung cancer were randomized between Vivasusumab biosimilar AB215 compared to the reference Avastin. In addition to a chemotherapy backbone, including carboplatin and paclitaxel for 6 cycles. And I'm sorry. And this is the primary endpoint of the study is the overall response rate. And as you can see in this diagram, they are quite comparable. The hazard ratio 0.93, and even the upper and lower boundaries of the confidence margin of the odds ratio lies within the boundaries of the bioequivalence. So the primary endpoint is met. We can demonstrate equivalence of the Vivasusumab biosimilar compared to the reference product, as you can see in this diagram. And the secondary endpoint of this trial is a progression-free survival. And again, I think without further talking, you can see how overlapping of the two curves. So we have quite similar progression-free survival between the two products. The important part as well, in addition to the efficacy, is the safety. And again, without further talking, you can see how similar is the frequency of different toxicities between the two products. So after demonstrating that we have similar efficacy, again, we have similar safety profile of the two products. So after demonstrating all this preclinical, clinical data, equivalence in terms of efficacy in the clinical trial and safety as well, we have what's called totality of evidence, all this evidence in addition to the previous clinical indications of Avastin. So after that, we are extrapolating the indications of reference product Avastin to be adopted by the new biosimilar product. So that's why the biosimilar Vivasusumab is approved in metastatic non-small cell lung cancer, advanced GBM, metastatic CRC, metastatic renal cell carcinoma, in addition to cervical cancer. In addition to the data that we just presented in non-small cell lung cancer, we have some data as well for the biosimilar Avastin and biosimilar Vivasusumab in patients with metastatic colorectal cancer. Actually, this was a pharmacokinetic study, which was demonstrated to be quite similar between the two products. And they looked as well for some efficacy data, including overall response rate and BFS and safety profile as well, which again and again were quite similar between the two products. And this is quite assuring. Even in another disease site, we have more or less similarity between the two products. And actually, this have been adopted, the introduction of biosimilar have been adopted by different guidelines and different societies, given that the cost of biosimilar is much lower. So if you have similar activity with much lower price, I think it is quite wise to adopt the new strategy. Now, after having this data, what are the challenges of the introduction of biosimilar into the market? and into the clinical practice. Actually, we have some concerns. We'll move from one to the next briefly, inshallah. The first one is the theoretical concern of the risk of switching in the same patient from the reference product to the biosimilar product. Is there any risk of producing some immune reaction or some hypersensitivity reaction with the introduction of the new product to the patient? Shall it produce some anti-drug antibodies that may elicit some hypersensitivity or immune reaction in the patient after the introduction of biosimilar? Actually, this have been tested in many studies, and the outcome of all these studies, that approach of switching from the reference to biosimilar product is quite safe and no more immunogenic reaction. I will skip that details. Just I want to say, even within the reference product, from year to year, from batch to batch, there are some changes from one batch to batch, from 1 year to year, due to variable reasons, including some changes in the manufacturing of the reference product. So even there are minor changes in the reference product, despite that, we are using in a safe way. So there is no reason to think about this hypothetical threat of having some immune reaction after introduction of the biosimilar, or shifting from the reference product to the biosimilar. The next concern is reluctance of some healthcare professionals for shifting from the reference product to the biosimilar. Actually, even for many medication, we have what's called prescription habit. We are used to prescribe Herceptin. Why to shift to the biosimilar? This is a prescription habit. So, and even some healthcare professional may have some concern. Is it quite safe? Is it effective as the reference product? So I think it's important from the companies and the importance from the societies to orient the healthcare professional about the efficacy, the safety, the concept of biosimilar, and that it is quite effective and safe, but much cheaper compared to the reference product. And we have a lot of educational material for patients and healthcare professionals to address this issue. The third concern, patients themselves. So sometimes we have some resistance. Actually, we face this several times when we, for whatever reason, we shift from one medication to another, or so. We have even, for example, we have subcutaneous for many years in our hospital, and it was deficient for a few weeks. When we started to shift to the IV formulation, we have a lot of concern from the patient, actually. So I think this concern may raise as well while shifting from the reference product to the biosimilar. So we have what's called nocebo effect. What is a nocebo effect? The nocebo effect is a negative effect of treatment, which is induced by the stress and negative expectations of patients, which is actually unrelated to the medication, unrelated to the physiological action of the effects of the medication. It is something of some negative expectation, stress, thoughts, and so, which is reflected into increase of the adverse event, increase of perception of symptoms and so of the patient, which actually unrelated to the medication, but it's something like psychological stress related to the patient. And actually, this is not an easy phenomenon. This is maybe reflected into discontinuation of treatment. Patient may be reluctant to receive the treatment, having extra side effect, and you need to manage this side effect, extra cost, extra visits. So we need to actually, in a proper way, address this phenomena to avoid this adverse effect of shifting to the biosimilar. So what are the concerns that are usually raised by the patient when shifting to the biosimilar? Is it quite effective? Is it safe like the reference product? As long as it is cheaper, will have the same effect like the other one? If the cheaper product is less effective than the more expensive one, why you shift? I'm doing well with my medication. Why you shift to another one? So a lot of questions and concerns. And actually, we in the start we have a lot of resistance. Sometimes we have some anger, some depression from the patient, but with time, with proper communication, proper explanation, and everything is safe, everything is quite effective, like the reference one, the acceptance of the patient start to increase. by time. And to do that, we need to have proper communication with the patient, proper explanation to the concept of biosimilar. And for me, the most important thing, we need to have what's called one voice approach. What's one voice approach? The physician, pharmacist, even nurses, they need to deliver the constant and consistent message to the patient. Suppose that I am the physician telling something, and while the patient went to receive in the chemotherapy area, the chemotherapy nurse said something else to the patient. Okay, the patient will be quite confused. So I think we need to have consistent and constant message to be delivered to the patient by all healthcare professionals that's dealing with the patient in this context. This is quite important to manage this nocebo effect. So the last part of this talk is quite touch about the pharmacoeconomic impact of the introduction of biosimilar in the market. So if we talk about colorectal cancer is the second most common in Saudi Arabia and the most common diagnosis of cancer among males. This is a Global Can 2018. We have new diagnosis of 3,500 new patients with colorectal cancer. And according to the Saudi Cancer Registry, we have about 20 to 24% of metastatic disease at the time of diagnosis. In addition to some patients who will relapse, stage 3 or 2, who will relapse and will have a stage 4 later on. So we can roughly say that each year we'll have about 800 patients with a stage 4, at least 800 patients in Saudi, at least in one indication. If you add to that non-small cell lung cancer, GBM, cervical cancer, and so to see how the magnitude of the pool of patients that's being treated with Vivasusuma. So if we know that the biosimilar products are quite cheaper compared to the reference one, for example, for biosimilar Vivasusumab, 30 to 40%, trastuzumab about 40 or 45%. So if you calculate that in relation to the large number of patients treated with this target therapy, PVAT, trastuzumab, and so you can imagine how much is the cost saving for our hospital and healthcare system with the introduction of biosimilar products in the clinical practice in Saudi Arabia. So I will conclude my talk by saying that biosimilar have a robust preclinical and clinical development process, and biosimilar are tested in adequate equivalence clinical trials in comparison to the reference product. And Vivasusumab, as an example, displayed comparable activity and safety to the reference Avastin. And we need, and this is very essential, to have proper orientation of all healthcare professionals, including physician, pharmacists, and nursing, all people dealing with the patients. And patient communication and education is very, very, very important to address all concerns of the patient. And of course, the pharmacoeconomic impact of the introduction of biosimilar will be quite substantial for the healthcare system. Thank you very much for your kind attention. Dr. Hani, can you hear us? معنا دكتور هاني. Dr. Hani, you are mute.
Can you hear me, Dr. Sharif?
Yes, I can hear you very well.
Just there was a problem. I'm sorry for this. Yeah, thank you very much, Dr. Sharif, for this great presentation. And really, it is a great advance in this issue to get new and similar old medications with biosimilar efficacy and effect to our patients with lesser cost, hoping that further medication we'll see in the future. And my question here is if the Saudi they approved or not yet? According to the last table you showed, I think, but was not clear whether approved or not.
I guess it is approved. Our colleagues from Amgen can elaborate more on that. Yes, I think Saudi if they approve. Yes.
Yeah. Any question from our colleagues?
Excuse me.
Dr. Hassan.
Can I ask?
Yeah, please go ahead.
Okay, Dr. Ali Jubran has a question.
Thank you so much, Dr. Sharif. Very nice talk. I think it's really natural now to move to biosimilar, as you very correctly highlighted, for basically financial reason. But I have really concern about switching one drug to biosimilar in one patient. As you already highlighted, this is definitely an anxiety provoking, especially for patients, but also to the treating physician. Would you agree that probably the best approach for switching to biosimilar is not to switch in the same patient, but to gradually switch for the new coming patients? At least to avoid such dilemma of anxiety and concerns that can be raised by both physicians and patients. That's number one. Number two, if you have biosimilars, let's say multiple biosimilars approved by a regulatory authority, what is your margin of choice to choose among them? Is it only the price? You are going to choose only the one with the lowest price, or you have other parameters to use for picking up the best one?
Thank you very much, Dr. Ali. Very important two questions, actually. Regarding the first one, I totally agree with you that the best approach, especially with the early introduction of the biosimilar in each hospital, is to introduce the medication for new patients. It will be quite easier. You will not need a lot of time to convince a patient for shifting from one medication to another. And after a few months of this switch, even the other patients who are on the reference product will be more comfortable to switch to the biosimilar because you will have now, even yourself as a physician, you will have confidence that you use this medication for several months with many patients, and it's quite safe, quite effective, like the reference one. So it will be much easier to convince a patient who are on the reference product. But as you said, Dr. Ali, I totally concur with you that myself, if I'm doing that, I will start with the new patients. Several years ago, when we started to introduce subcutaneous trastuzumab in our hospital, when we started to shift some patient from the IV to subcutaneous, we have a resistance. But we don't have that resistance for the new patient. So I totally agree with you. It will be much easier, at least in the start. Your next question, Dr. Ali, please.
If you have multiple approved biosimilars, how can you choose?
This is a difficult one. However, we'll look for two things. The first is how robust is the development process of the different biosimilars. Okay. The next choice, reason for choice is the reputation of the manufacturing company. If we have a company that have good reputation in the field for a long time, especially in the field of oncology, I think this will be another important factor. The third factor, of course, if everything is quite similar, the price will play a role, of course.
Any further question, please?
Yes. Last question, Dr. Hossam.
Okay. Thank you, Dr. Sharif. Should we tell our patient we are using the biosimilar in our practice?
I think the rule, Hussam, for everything and while you are dealing with your patient, you need to be transparent with the patient, everything. Of course, we need to tell the patient, but in the meantime, we need to explain the patient that this is quite similar, quite effective and safe like the reference one. Yes, you need to tell the patient, of course.
Thank you very much, Dr. Sharif. Thank you for all. Thank you for Amgen and colleagues from Amgen who sponsored this meeting, and hoping that we'll meet again soon with the new scientific meetings. Thank you all.
Thank you very much, Dr.
Sharif, we will go just and move to next sessions, inshallah.
Yes. I will move to the next GI session. I will invite Dr. Marwan Hijali and other colleagues to chair the session. Thank you very much.
Thank you.
Assalamu alaikum wa rahmatullah. My name is Marwan Hijali. I'm a medical oncologist at King Abdulaziz University Hospital. I'll be chairing a session, co-chairing a session with my two colleagues, Dr. Nidal Bukhari, who's a medical oncologist from King Fahad Specialist Hospital in Dammam, and Dr. Majid Jahel, who's a medical oncologist from King Fahad Hospital in Medina. We will start, this will be the second GI cancer session for the meeting. And we will start with our first speaker, Dr. Mohammed Al-Garni. He's a medical oncologist leading the GI oncology at the National Guard Health System in Riyadh. And he will be speaking about the progress in the treatment of metastatic cholangiocarcinoma.
Thank you very much, Dr. Marwan, for the introduction. And thank you, Dr. Sharif and the organizing committee for the kind invitation. I was given the task to talk about the progress in systemic treatment for patients with cholangiocarcinoma. So are we making progress in systemic treatment for patients with cholangiocarcinoma? We'll try to go over this in this presentation. As you know, biliary tract cancer is not a common malignancy. It represents about 3% of all cases of GI cancer. It's a heterogeneous group of disease histologically, and now we understand it's also molecularly different. Unfortunately, most of the patients present an advanced stage, and about 1/3 of patients will be eligible for surgical treatment. And historically, this cancer considered to be a poor prognosis and chemo-resistant, with 5-year survival less than 20%. So we used to classify biliary tract cancer based on their anatomical classification. So the biliary tract cancer classified into mainly 3 classifications by location. The gallbladder is considered the less frequent tumor. Then we have the intrahepatic cholangiocarcinoma with reported increased incidence worldwide, and the distal cholangiocarcinoma that is decreasing in size, decrease in epidemiological studies. Most of them, they arise de novo, so there is no predisposing factor. However, we know there are certain risk factors for this malignancies. And one of the important things here is the hepatobiliary flux, which is more common in the southeastern of Asia. And this also translated in different molecular or different biology of the cholangiocarcinoma related to the parasitic infection. So challenges, as I already mentioned, delayed in diagnosis, non-specific symptoms, jaundice and biliary obstruction, which is very challenging, especially if you have someone with recurrent obstruction and recurrent infection and hepatic abscesses, which will not allow to deliver a proper systemic therapy. And we don't know what is the population at risk as to develop certain screening recommendations. So we end up having most of the patient in advanced stage. So most of the patients with metastatic cholangiocarcinoma or biliary tract cancer will be for systemic chemotherapy if they are fit for therapy. Historically, the best supportive care, median overall survival between 2.5 to 4.5. We now have the standard of care cisplatin in addition to gemcitabine based on different studies, the APC2 studies, and the BT22, which was done in the Japanese population. The meta-analysis of these 2 studies showed the combination of cisplatin and gemcitabine is favorable, except for patients with equal performance of 2. So in those population, you might be careful with adding doublet chemotherapy, and gemcitabine might be as good as the combination. So, as you know, in Japan and the eastern part of Asia, they use S1 very frequently. So they did a study, which is the non-inferiority phase 3 studies, and they randomized patient to GemCis versus Gem with S1. And as I mentioned, it's a non-inferiority study, and it meets its primary endpoint. And this is considered as an option for Japanese patient with metastatic biliary tract cancer. So in order to optimize the systemic therapy for the chemotherapy in patients with advanced cholangiocarcinoma, a different approach has been used. One of them is adding nab-paclitaxel Abraxane to the standard, which is GemCis. And this was in the phase 2 study. They initiated higher doses initially, then due to the significant side effect with neutropenia, they went down with the doses. And in this study, the partial response rate was reported at 45%, and the disease control rate was 84%. 12 patients converted from non-resectable to resectable and had surgery, and 2 of them, they have complete pathological response. So this combination showed some efficacy, and based on this, it was taken to a phase 3 clinical study, and we are expecting the result in the near future. Another option to optimize the systemic chemotherapy option in the metastatic setting is using the NUC 1031 in addition to cisplatin versus gemcitabine and cisplatin. So this agent is a new class of drug. It was studied in phase 1B study, which is ABC08, and it showed favorable safety profile and encouraging efficacy activity across all biliary cancer subtype. And if you compare this new agent with gemcitabine, it has greater plasma stability and increased intracellular level of anti-cancer metabolite, and it has reduced toxic metabolites. So this is also being studied in a phase 3 study with a primary endpoint of overall survival and objective response rate. This study was presented the last ESMO. It's the NAIF study, which looked to the non-liposomal irinotecan in combination with 5-fluorouracil in comparison to cisplatin and gemcitabine in phase 2 study. The primary endpoint of this study was the progression-free survival at 4 months, to have more than 50% of the patient progression-free in 4 months, and the study meets its primary endpoint. Interestingly, from this study, the mostly benefited patient from this combination was patient with extrahepatic cholangiocarcinoma, and the intrahepatic cholangiocarcinoma was the patient were less likely to benefit from this agent. Moving from the first line to the second line, we know that the combination or addition of oxaliplatin to 5-FU has been considered a standard of care second line for patients progressed on first line and still fit for chemotherapy. This is in addition to active symptoms control. So in this study, the ABC6, they compared the FOLFOX in addition to active symptoms control compared to active symptom control alone. And the study meets its primary endpoint that FOLFOX and active symptom control considered as a new standard of care. And this has been adopted by many of the oncology, GI oncology. Now, what are the other options for patients with cholangiocarcinoma progressed on first-line therapy? We have also the NIFTY study, which is also a recent study published or presented in the last ASCO, and it's also studying the non-liposomal irinotecan plus 5-FU compared to 5-FU. So this is a Korean study. The comparison arm was not the standard of care, which is the ABC protocol that we just mentioned, FOLFOX. And in this study, the primary endpoint was the progression-free survival as assessed by the blind independent central review. The patients were balanced between both arms in terms of baseline characteristics, and the study meets its primary endpoint in terms of the progression, improvement of progression-free survival. It was a 7.1 month in the intervention arm compared to the 5-FU leucovorin. Also, was the secondary endpoint, the overall survival, which was in favor of the use of non-liposomal irinotecan. So now we have two studies, two phase 2 study, one in the first line setting and one in the second line study. Both of them showed that non-liposomal irinotecan could be one of the options for patients with biliary tract cancer. Now we move to the more of personalized approach for patients with cholangiocarcinoma. So we know that cholangiocarcinoma is one of the heterogeneous group of disease. It's not one group of disease. This was mainly understood from the understanding the molecular biology and the molecular profile of those patients. Now, most of the evidence that we have about the molecular profile of those patients came from resected cholangiocarcinomas, which is one of the caveats about knowing the epidemiology of the genetic mutation in patients with cholangiocarcinoma and how much this correlates with metastatic disease is unknown. However, this is the best that we have. And we know that the frequency of mutation, it depends on the tumor location. So if you have intrahepatic, you have different mutation distribution compared to extrahepatic and compared to gallbladder cancer. If you look to this paper, which looked to 3 different studies and looked to the common actionable alteration in cholangiocarcinoma, the figure above is for intrahepatic cholangiocarcinoma. The one down is for extrahepatic cholangiocarcinoma. You can see there is a difference in the distribution of the mutation. You have more of IDH1 mutation and FGFR2 mutation in patients with intrahepatic cholangiocarcinoma compared to HER2 PIK3CA IDH2 mutation in extrahepatic cholangiocarcinoma. So is there a role for precision medicine in biliary tract cancer? Definitely there is. This is one of the aerial study that looked to some patients with druggable molecular alteration. They included 23 patients who were treated with targeted therapy. And if you look to those patients who have druggable targeted mutation, they have definitely better overall survival compared to a patient with no identifiable mutation. One of the commonly reported alteration is the FGFR rearrangements, and it happened about 10 to 15% of all cases of intrahepatic cholangiocarcinoma. There are different studies that looked to different agents in this rearrangement. One of the earlier study is the FIGHT 202 trial, which looked to the role of pemigatinib in patient with FGFR alteration. So you have patient with fusion translocation, you have 20 patient with FGFR alteration, and you have 19 patient without FGFR alteration. The primary endpoint of this study was the overall response rate, and in the median follow-up of 17 months, 36% of patients, they have objective response rate, including 3 complete response. Now, this is only for the group who have FGFR rearrangement, and no patient with FGFR alterations or lacked FGFR alteration achieve any response in this study. This is to show the change in the tumor response among patients with FGFR rearrangement. The response rate was 35%, and clearly you can see those with FGFR rearrangement has clearly better survival compared to those without FGFR mutation or any FGFR alteration other than the rearrangement. So what about the adverse event? So the dose to start with is 13.5 milligram, 2 weeks dose followed by 1 week off. The treatment was tolerated overall. The hyperphosphatemia is one of the commonest side effects that you see with this drug. Other side effects include arthralgia, stomatitis, and hyponatremia. One of the most important adverse events to be careful about is the retinal detachment that can happen due to fluid accumulation. It's occurring in 4% of patients. It's mean that we need to keep an eye on the eye symptoms if the patient reported any side effect and to make the patient aware about any thing related to ophthalmological symptoms. Based on this study, the FDA granted accelerated approval for pemigatinib for cholangiocarcinoma, and it was taken also to the first line setting compared to gemcitabine and cisplatin, and this is the FIGHT 302 study, and it's ongoing clinical trial. Another agent is the infigratinib, which is FGFR 123 selective tyrosine kinase inhibitor. It was studied also in a single arm trial of 108 patients who previously treated and they have unresectable locally advanced metastatic cholangiocarcinoma with FGFR2 rearrangement. The major outcome of this study is to look for the overall response rate and the duration of the response. And after the median follow-up of 10 months, the objective response rate was 23%, and one patient has complete response. And in this study, they noticed that the patient who received the drug in the second line, they have more chance to respond compared to third line setting. Again, it has similar or comparable toxicity to pemigatinib in terms of the hyperphosphatemia and eye disorder as well. And based on this, in May 28th of this year, FDA also granted approval of infigratinib in this indication. Another agent that's been studied in phase 2 study, which is the fiotibatinib. It's also an tyrosine kinase inhibitor that is being studied in FGFR fusion on rearrangement, the same or endpoint, the objective response rate. And it was reported that those patients treated with this agent have response rate of 73.3%. So moving to another targeted agent or targeted mutation is the IDH1 mutation. The Clary IDH study was conducted in patients with cholangiocarcinoma progressed in one or prior lines of therapy. They included more than 180 patients, and they were randomized to ifosidenib 500 milligram daily versus placebo. The primary endpoint of the study was the progression-free survival, and the study meets its primary endpoint in terms of improvement of the progression-free survival, although it was a marginal benefit. And also FDA approved this ifosidenib agent as in an accelerated pathway for patients with metastatic cholangiocarcinoma. So now we have 3 drugs that's been approved in the second line setting in patients with advanced cholangiocarcinoma progressed in first line therapy. One of the potential application of liquid biopsy, since the liquid biopsy start to emerge in different across the different cancer type, is the use of cell-free DNA in following the response of patient on targeted therapy. And this one of the publications that looked to the IDH mutation circulating tDNA, and they looked to the association between the clearance of plasma, the clearance of the mutation of IDH from the plasma and the progression-free survival in patients treated with ifosidenib. And as you can see here, those patients who have clearance of their mutation, when they're followed by the circulating tumor DNA, they have a better progression-free survival. So this might be considered one of the application of liquid biopsy in patients with cholangiocarcinoma. Now we have, as we mentioned, we have multiple different other mutations that can happen in cholangiocarcinoma. One of them is the BRAF P600E mutation. In this study, they looked for the dabrafenib and trametinib in those patients with a primary endpoint of overall response rate, and they followed the patient for almost 10 months. And in this study, the response rate was reported 47%, and the median progression-free survival was 9 months. So this is also considered one of the options for patients with BRAF mutation, advanced biliary tract cancer in the second or third line setting. There are multiple other targeted mutations that can happen, but in less frequency. And we will focus a little bit about the immune targeting in this patient. So cholangiocarcinoma, also they can have MSI high tumor. The prevalence of this mutation estimated to be 5 to 10% of all biliary tract cancer. So in the keynote 16, which include non-colorectal cohort patient, there were 4 patients with biliary tract cancer. The response rate for those patients who were treated with pembrolizumab was 53%. In the keynote 158, 9 patients with cholangiocarcinoma, and the response rate was about 37%. The tumor mutation burden highest in patients with gallbladder cancer, and it's estimated to have more than a 10 mutation per megabase in 3 to 5% of patients. So nivolumab was studied in a phase 2 study in patients with advanced biliary cancer, and the response rate in those patients was 22%. 9 out of 10 patients express PD-L1, and all patients, they have proficient mismatch repair. The median progression-free survival was 3.5 months, and the overall survival was 14.2 months in this phase 2 study. The combination of EPI and NIFU was also studied in a phase 2 studies, and they included 39 patients, biliary tract cancer. Majority of them, they have intrahepatic cholangiocarcinoma. Only 5 patients have objective response, and all of them, they have intrahepatic cholangiocarcinoma, and the PD-L1 status on those responder was unknown. And the duration of response was ranged from 3 to 14 months. And all the patients included with extrahepatic cholangiocarcinoma have no objective response. And as you would expect with the combination immunotherapy, almost 50% of the patients experienced significant toxicity. There are multiple ongoing immuno-oncology combination trials, as you can see. Some of them combined with locoregional therapy, some of them combined with MEK inhibitors. So we'll see in the future the outcome of these studies. So just to answer the question, are we making a progress in systemic treatment for cholangiocarcinoma? Yes, we are making progress, not only in targeted therapy, but also in the chemotherapy. And my conclusion for this talk is that chemotherapy is still the standard of care for first-line setting with cisplatin, gemcitabine, plus minus Abraxane, and some people might adapt also the non-liposomal irinotecan approach. I think we should do NGS for all patients with cholangiocarcinoma, especially those who progressed in the first-line setting. We have 3 FDA-approved agents in the second line and beyond. Folfox with patients with no targeted mutation is still considered the standard of care. And as I mentioned, we have many ongoing trials, and stay tuned. And by this, I conclude. Thank you very much.
Thank you, Dr. Mohammed, for your excellent and nice presentation. I would like to thank Dr. Sharif for inviting me as a moderator for such a successful conference. And it's now the time to move to our next speaker. It's my honor and pleasure to introduce our next speaker, Dr. Ali Jubran. Dr. Ali Jubran is a consultant medical oncology at King Faisal Specialist Hospital and Research Center in Riyadh. He will present for us what is the new regarding the new adjuvant chemotherapy in rectal cancer. Dr. Ali, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thank you so much for the organizing committee for such nice invitation to participate in this important meeting. And I'm going to talk about the chemotherapy role in the rectal cancer, especially in the preoperative time, which is now gaining lots of momentum as TNT. This is the landmark study that actually compared the preoperative versus post-operative chemoradiotherapy for rectal cancer. And the idea behind presenting these well-established data is to know the benefit of the possible approaches of TNT as added to the standard concurrent chemoradiation. Basically, there was significant difference in the local recurrence between the in favor of preoperative chemoradiation as compared with post-operative chemoradiation. But when it comes to the risk of distant metastasis, disease-free survival, or overall survival, both treatment of a preoperative or post-operative chemoradiation yielded almost similar results. The pathological CR in that landmark study was 10%. The conversion from APR to LAR was 39% versus 19%, of course, in favor of a preoperative chemoradiation. And the acute and late toxicity was significantly less in the preoperative chemoradiation. But we know that there was a consistent pattern of failure with more incidence of distant metastasis in almost all clinical trials of rectal cancer. And that is consistent among old and recent studies in the range of more than 30 to 35%. This increased rate of distant metastasis speak probably for less efficacy or less introduction of systemic chemotherapy for patients with rectal cancer. This is a comparison between the most important and latest studies of a preoperative treatment for rectal cancer, where patients were randomized into chemoradiation plus oxaliplatin or chemoradiation alone. And as you know, the German study CAI-ARO-AIO4 was positive, and the ADOR, the smaller study, was also positive in favor of addition of oxaliplatin. But just look at the compliance rate of post-operative chemotherapy in all of these trials. It can be as low as 48%, but they were ranging in the range of 55 to 65% of patients received full courses of adjuvant chemotherapy. And here we are talking about patients enrolled in prospective trials where the investigators tend to be more meticulous in delivering all the treatments to patients. But what about the routine practice? This is really very interesting study from the NCDB database, where patients with rectal cancer, huge number of patients, 23,000 patients, were analyzed. Quarter of them actually achieved complete pathological response. 3/4 no pathological response. But just look at those who used both neoadjuvant and adjuvant chemotherapy. And it is surprised that almost only 25 to 35% of patients received both neoadjuvant and adjuvant chemotherapy. Big fraction of those patients actually tend to have high-risk features, including node-positive disease, where only 40% of them received adjuvant chemotherapy. So we are talking about very poor compliance of receiving adjuvant chemotherapy in patients with rectal cancer. This is the current trimodality paradigm for T3 or 4 or node positive rectal cancer that you will give chemoradiation. Chemoradiation will give rise to path CR of about 20% and 5-year overall survival of 70%. And then patients will go to receive chemotherapy. And we know that there is really a tremendous decline in compliance with the adjuvant chemotherapy, ranging from 25 to 70%. Now, if you are able to move this segment of a treatment from post-op to pre-op, you are likely going to increase the compliance, and this will lead to better path CR or a clinical CR, which might facilitate non-operative treatment, and also may decrease the distant relapse and potentially improve overall survival. So that's the main idea of TNT, is to give all the treatment before surgery. Now I'll go to discuss the landmark and latest studies of TNT, starting with the Buroji 23 that was presented in ASCO 2020 and not published yet. Patients were randomized to receive long course chemoradiation, then surgery, then 6 months of adjuvant Folfox or Cabox, that's the standard arm, or to receive induction chemotherapy with FOLFIRINOX, then chemoradiation, then surgery, then another 3 months of adjuvant Folfox or Cabox. The primary endpoint is disease-free survival. In this trial, neoadjuvant FOLFIRINOX is feasible with 90% compliance. Additionally, overall grade 3 toxicity is less in the neoadjuvant chemotherapy as compared with the post-operative chemotherapy. If you see the outcome results of the study, path CR is improved with the TNT. The 3-year disease-free survival is also improved with hazard ratio 0.69. The 3-year metastasis-free survival has also improved, but the overall survival has no statistical significance. However, there is a trend towards improvement in the TNT. The second trial is the Rapido trial, where patients again randomized to receive the standard chemoradiation surgery and adjuvant chemotherapy, or the TNT protocol of short course chemoradiation followed up by consolidation chemotherapy with 9 cycles of Folfox or 6 cycles of Cabox, then surgery with no adjuvant chemotherapy. It is really interesting that even in this randomized prospective trial, only 42% in the standard arm received or completed adjuvant chemotherapy. The primary endpoint for this study was the disease-related treatment failure. And this is the outcome. The path CR is more with the experimental arm. The disease-related treatment failure is better with the experimental arm. And the distant metastases are less with the experimental arm. However, the local grade failure is probably more with the experimental arm. However, this is not statistically significant, probably because of the small number of patients with local recurrence. But this can partially attributed to that those patients in the experimental arm received short course radiation, not the standard concurrent chemoradiation. So there are definitely a few challenges to the approach of TNT. The first is selection. How do we select patient to go ahead on the TNT approach? Because of course we would like to avoid over-treatment. Now the definition of locally advanced disease is any T3 or T4 or positive lymph nodes. But again, are those very well validated? If you check one of the studies, which is the Mercury study, where small number of patients were followed up according to MRI staged rectal cancer going for mesorectal excision. In this study, lymph node positivity actually did not change disease-free survival, overall survival, or even local recurrence. What really mattered in that particular study was the CRM positivity, extramural venous invasion, or advanced T3 or T4. So the poor risk MRI-based features are CT4, involved CRM, extramural venous invasion, or advanced T3 in addition to lateral pelvic lymph node. Now, there are also questionable features that are not proven yet, which are early T3, A or B, or positive lymph nodes or low-lying tumors. And to know the importance of selection for TNT, I am presenting this example of a small randomized phase 2 Spanish trial where patients were randomized to the TNT arm with K-Books plus radiation and K-Books, then surgery, or K-Books plus radiation, then surgery, then adjuvant K-Books. The primary endpoint was pathological CR. Now, if you look into the patient's characteristics enrolled in this small study, you will find that vast majority of patients actually had favorable risk factors, with only 6% of T4, with only 10% of involved or threatened CRM. And the results of this study was that the addition of induction Xelox did not significantly improve resectability, PathCR, fraction of patients who needed APR, DFS, or overall survival. So you can say that probably not all patients should go for TNT, and this should be preserved for those patients with really locally advanced disease. Otherwise, patients will be subject for unnecessary over-treatment. The second challenge is about the clinically meaningful benefit of TNT. Now, there was a huge question that was raised with evolution of TNT, and that was whether TNT prevent or just delay distant relapse. I'm again presenting one small study, which is randomized phase 2. It's actually a randomized phase 3. It's called Polish 2 trial, where patients with locally advanced disease were randomized to short course radiation, then consolidation chemotherapy, then TME, or the standard chemoradiation. And the primary endpoint was R0 resection. There was no difference in the R0 resection in this study. But if you look at the overall survival, which was not primary endpoint, there is clear difference in overall survival in favor of the TNT approach. But actually, when more duration of follow-up was given to such a trial of about 7 years, that difference in overall survival was obliterated for the TNT approach. So it is definitely a valid question to ask about overall survival advantage with TNT as opposed to the standard CRT approach. One of the challenges actually is whether you give chemoradiation or radiation. Sorry, chemotherapy first or radiation first. And there are at least 2 major studies presented in this presentation trying to answer such important question. One of them is the Operable study, where patients were randomized to induction chemo, then chemoradiation, then surgery or non-operative treatment, or chemoradiation, then consolidation chemotherapy, then non-operative treatment. The second trial is the German trial AIO12, where patients were randomized to the TNT of induction chemo, then chemoradiation, including oxaliplatin, or chemoradiation, including oxaliplatin, followed up by consolidation chemotherapy. And the primary endpoint was pathological CR. The result of that study, it clearly indicated that patients with chemo first approach had less pathological CR as compared with patients receiving radiation first. And that will definitely raise the question whether it is because of the regimen of chemotherapy used or the sequence of radiation versus chemotherapy, or basically because of the duration given to the patient from the end of radiation to the time of surgery. And this has been consistent findings in many trials comparing the pathological CR according to the duration from radiation to surgery. This was also confirmed in one of the landmark studies called timing study by Garcia Aguilar, where patients were observed in at least 4 cohorts according to the timing from radiation to surgery. And of course, during the time of rest before surgery, patients received chemotherapy, either 2 cycles, 4 cycles, or 6 cycles waiting for surgery. And it is clearly evident in this trial that patients waited for longer time before surgery achieved better path CR. So in conclusion, TNT is effective approach, and actually there is a trend towards no adjuvant treatment. So you give all the treatment pre-operatively. We need actually to define better selection criteria for the TNT to avoid over-treatment. And one of the promising methods actually is to check the circulating DNA for patients after chemoradiation to guide us whether those patients need to receive more chemotherapy before surgery or just go ahead to surgery and avoid over-treatment. This is an interesting study of 47 patients indicated clearly that detection of circulating DNA correlates very well with the metastasis-free survival. This is true for the measurement of 21 days from the start of chemoradiation or 37 days after the end of chemoradiation. Other approach, which was actually suggested by NCCN guidelines, is to give chemoradiation upfront for patients. And then you're staged with MRI at 6 weeks post chemoradiation. If you find that the CRM is involved or the patient has still bulky disease, you give chemotherapy before surgery. Or if the CRM is clear with no bulky or residual disease, you just take patient to OR. And of course, with this approach, you need to look for long-term follow-up, especially in data of overall survival. Thank you so much.
Assalamu alaikum. You guys hear me?
Yes, we can hear you.
Very well.
Excellent. Assalamu alaikum. Excellent presentation, Dr. Ali, Dr. Muhammad Al-Garni. First of all, I would like to thank Dr. Sharif Al-Sammani, Dr. Hafiz Ghanim, and Dr. Imad Tashkandi for inviting me to this great meeting. Our next speaker will be a person who is well known to everybody, Dr. Abdullah Sharm, Director of Oncology Center at King Fahd Medical City in Riyadh. He's a senior colleague and a GI/GU oncology expert. And he's going to talk today about maintenance therapy in RAS wild-type advanced colorectal cancers. The mic is yours, Dr. Abdullah.
Thank you so much, Dr. Nadal. Assalamu alaikum jami'an. To start with, I would like to thank Dr. Sharif Sammani, Dr. Hafiz, and Dr. Imad Tashkandi for giving me this opportunity to share with you on a very important, actually, huge controversy subject, was actually maintenance approach with anti-EGFR therapy in metastatic colorectal cancers. As everybody knows, there is no doubt in the last 30 years, we have huge improvements in overall survival. As you can see in this slide, in 1970, we were speaking about 6-month overall survival in metastatic colorectal cancers. And nowadays, with systemic therapy, we are reaching almost 33, and definitely we are going higher with the new era of new medications and the new targeted therapy, and especially introducing the immunotherapy now with metastatic colorectal cancers. We are approaching 5-year survivals. So if you ask any GI oncologist, what's your treatment goals? We know clearly when the patient presents with metastatic disease, we give them some sort of therapy. However, ultimately, most of those patients, they will progress again and they will develop some sort of resistance. And finally, and eventually, they will die with the same disease. So we start with extensive disease, then we try to reduce and shrink the tumors, but ultimately, the patient will come again to the baseline that started with. This is the majority of metastatic colorectal cancers. So when you ask yourself, what's the treatment goal in metastatic colorectal cancer? Definitely you are aiming for prolongation of the survival. However, we need to have maintained good quality of life and improvement tumor-related symptoms and definitely disease controls. And nowadays, we are speaking about continuity of care. And when we speak about continuity of care, we are using a lot of strategical approach to maximize the benefit of the therapy. Either to go with successful systemic therapy, either to go with a maintenance therapy, stop and go approach, or drug reintroductions, and definitely treatment-free interval or what's called drug holiday. However, we should keep in our mind to have a balance between the prolongation of the survival and definitely maintain full good quality of life when you apply any one of those approach. And the big question actually, we would like to have a combination of approach that have a prolongation of the survival with maintenance therapy. When I speak about good quality of life, it means that I'm aiming for to have some approach of maintenance therapy that reducing the toxicity of systemic therapy. However, it does not dismiss the prolongation of survivals. Now, when we look for anti-GFR and endothelial growth factor, the two fundamental targeted therapy that clearly showed an overall survival benefit in the first line setting, either with vascular endothelial growth factor, basically bevacizumab, or with anti-GFR, basically with cetuximab and benitumab, which is a very well studied in the first line setting, and both of them, either cetuximab or benitumab, showed an overall survival in the first line setting in a famous phase 3 clinical trials. So the big question, what about the anti-GFR monotherapy maintenance versus observation after induction therapy? And this actually was studied in a phase 2 clinical trial, time trial. And basically, unresectable RAS wild metastatic colorectal cancer who had a first-line therapy with induction of FOLFIRI plus cetuximab for 4 months. And patient, once he reached to the stabilized disease or responsive disease, they were randomized to cetuximab as a maintenance therapy versus complete stopping the medication or discontinuation of the therapy and observations. And once the patient have a disease progression, they would be reintroduction of the same medication, the same combination therapy with FOLFIRI cetuximab. And when we look for the patient and disease characteristic, it was almost equally in terms of the patient and a characteristic disease. As you can see, the age was 64, and the primary side, actually, the majority, they were in the left side. Almost, you can see the objective and stable disease was approaching almost objective response in 75, and the stable disease in 25%. And the primary endpoint was 6-month progression-free survival. And as you can see, the cetuximab maintenance arm, they were approaching 34.3% versus observation of 6.9, indicating the monotherapy with the using of cetuximab maybe it's better option. And this is, remember, this is phase 2 clinical trials. And as you can see, the median progression-free survival, very nice separation between the two arms of 2 months with observation versus 5.3 with cetuximab maintenance therapy. And when we look for the safety analysis, there is nothing, striking. We know that the side effect of the cetuximab, basically with the GI symptoms and some electrolyte disturbance, was definitely high with the maintenance therapy. At the conclusion of this trial, it showed clearly the primary endpoint, the 6-month progression-free rate was 34 versus 6.9 with observations. And as you can see, the progression-free survival, the median 5.3 months versus 2 months with a clinical meaningful difference. And in my view, I do believe cetuximab monotherapy is better than observations based on this phase 2 clinical trials. So the second approach, what about the cetuximab maintenance therapy as a monotherapy versus continuations of full inductions? Now, this was answered in macro trial. This is again open label phase 2 clinical trial, metastatic colorectal KRAS wild, and 193 patients. They were randomized to receive cetuximab plus FOLFOX for 8 cycles, and followed by maintenance cetuximab alone, or continuation with cetuximab and FOLFOX until the patient have disease progression or toxicity. And as you can see clearly, the difference between the two is negligible, and clearly there was no difference between the two in terms of progression-free survival, median overall survival, overall response rates, indicating that cetuximab alone versus cetuximab and FOLFOX chemotherapy, there was no difference between the two. And definitely this was stated with improvement in treatment compliance, and definitely the toxicity was less with the approach of cetuximab maintenance therapy. However, when they look for the Valentino trial, which is again phase 2 trial, 229 patients, RAS wild type, the primary endpoint was 10-month progression-free survival. The arm A was FOLFOX 4 plus benitumab versus followed by VIVU and benitumab. And the other arm, FOLFOX plus benitumab induction phase, followed by benitumab alone. And a matter of fact, you can see there is a nice separation indicating that VIVU plus anti-EGFR with benitumab is better than benitumab, controversing the other macro trial. And definitely in those group, the patient, you can see the median progression-free survival was in favor of maintaining chemotherapy plus anti-EGFR rather than anti-EGFR as a monotherapy. Now, in the MACBETH trial, again, phase 2 trial with FOLFOXIRI chemotherapy, and this again, previously untreated RAS wild, BRAF wild, 116 patients. They were have both of them in the both arm. They were have induction chemotherapy with cetuximab plus cetuximab plus FOLFOXIRI chemotherapy, and upon patient they will put in maintenance with cetuximab or bevacizumab. We know clearly the data about bevacizumab is almost have good quality, good phase 2 and 3 clinical trial indicating that the benefit of bevacizumab were as a maintenance therapy in metastatic colorectal cancers. And both of them, as you can see, those who underwent for cetuximab or bevacizumab, there was no difference between the two. As you can see, the median progression-free survival and overall survival were equals. Now, when we go for the Nordic trial, which is again the famous trial, phase 3 clinical trial, there was a 3-arm of the trial. You remember the FLOX arm 185, were randomized with arm B, cetuximab plus FOLFOX. And there was a 3rd arm, actually, they were arm C, where intermittent cetuximab plus FOLFOX. And after inductions with cetuximab FOLFOX, the patient will be maintained on cetuximab arms. And definitely you can see in terms of the progression-free survival, overall survival was identical and there was no difference between the two. The NORDAC 7.5 phase 2 trial with again FOLFOX and continuation of biweekly cetuximab, it actually showed that clearly cetuximab every second week was safely integrated in intermittent chemotherapy strategy and may lead to longer chemotherapy-free intervals. What about the using of cetuximab? You know now that most of the clinical trial, although it's phase 2 trial, but it's coming with cetuximab and only 1 or 2 trial with benitumab. Cetuximab was tested in this clinical trial with reduced dose of Xeloda in a Chinese clinical trial. You can see 61 patients, RAS wild. They have induction chemotherapy with cetuximab. And after that, they were shifted to maintenance therapy with reduced dose of capecitabine, 1,000 milligram per meter squared twice daily plus cetuximab. And in matter of fact, you can see the median overall survival of 27 months, which is the historical point that we know with this treatment, indicating that reduced cetuximab may be a way that we go with reduced dose with the capecitabine plus cetuximab. It's maybe the way that we would like to go with maintenance therapy. Now, in the last ASCO, we have the famous Panama trial, which is again maintenance therapy, RAS wild metastatic colorectal cancer. They have induction FOLFOX plus benitumab for 6 cycles. And if the patient have good response, they were randomized to VIVU, leucovorin plus benitumab or 5-FU leucovorin alone. And in this clinical trial, you can see clearly that 5-FU plus leucovorin, which is the primary endpoint of progression-free survival, there is a nice separation with almost 3-month improvement in progression-free survival with a hazard ratio of 0.74 and p-value of 0.014, indicating that chemotherapy plus anti-EGFR play a major role, either reduce dose or reduce regimens play a major role in the maintenance therapy. And matter of fact, this was not translated to overall survival benefit. And as you can see, the response rate was 51 compared to 32, and there was no major or new striking adverse effect apart from what we know with the GI symptoms and electrolyte disturbance with 5-FU and benitumab. Are we going to stop there? The answer is definitely no. There is a lot of ongoing study. This is a phase 3 clinical trial times, 8 cycle of first-line FOLFIRI plus cetuximab. They are going to randomize to cetuximab and observations, and hopefully to see the results soon. Another important clinical trial, which is ARMS trial. Again, in the first-line setting, you can see a huge number of patients. They were having almost the same identical design of the trial, cetuximab FOLFIRI induction therapy versus cetuximab FOLFIRI continuation of therapy, and they are looking for the primary endpoint of progression-free survival and grade 3 and 4 toxicity. So I do believe, in my humble opinion, cetuximab with anti-EGFR, either with cetuximab or benitumab, with reduced dose of chemotherapy or reduced regimens, and instead of FOLFOX chemotherapy using 5-FU, and instead of FOLFIRI using 5-FU again, is definitely based on what available data we have at the meantime, better than anti-EGFR monotherapy, and it's definitely more, more efficacious than observations alone. So in 2nd of October 2021, as of today, maintenance therapy in colorectal cancer has become a fundamental concept, and we are doing this in our clinic in daily practice. And definitely, when we look for definition of good maintenance therapy, it should have good survival benefits with huge improvement in quality of life. And definitely, the role of maintenance therapy is rapidly evolving. That's coming very soon. And the evidence at the meantime, as we discussed before, most of the clinical trial was phase 2 trials. And definitely with maintenance anti-EGFR with reduced dose of chemotherapy, maybe single agent 5-FU, reduced dose of capecitabine. And definitely there is more data coming to establish the best maintenance therapy. And with this, I would like to conclude. Thank you so much.
Assalamu alaikum. Thank you, Dr. Asharm, for the excellent presentation. We now go for the discussion. We have few minutes, so we'll have some time for a few questions or a couple of questions. I have my colleagues, Dr. Majid and Dr. Nadal online, and they will see if any question in the chat box. Dr. Nadal?
In the chat box, there is no questions, but I have a question for Dr. Shah, if you allow me. Dr. Abdullah, we saw the data that the patient who received the maintenance reduced dose chemo plus anti-EGFR, they are doing better than patient with anti-EGFR alone. But we don't have, we certainly have patients who will tolerate anti-EGFR alone regarding the toxicity and long-term toxicity of the chemotherapy. So did you recommend just to go with anti-EGFR alone? despite the strongest data is going with the reduced dose chemo?
Yeah, thank you so much, Dr. Majid. And now, when we look for the data, actually, I mean, almost all the data is phase 2 trial. The only phase 3 was Nordic trials. And Nordic, they were looking for arm A and B, and we will not concentrate in arm C. Now, definitely, the patient, he cannot tolerate the chemotherapy. I mean, we have phase 2 trial, the time trial, it showed that maintenance with anti-GFR, specifically with cetuximab, it's better than observations or complete discontinuation of therapy. However, keep in your mind, this is phase 2 trial. Until we have phase 3, I will be very reluctant to have any recommendations. But I will tell you my practice. After induction chemotherapy with 6 or 8 cycles of chemotherapy plus anti-GFR, if the patient doing remarkably well, I may reduce the dose of the regimen of chemotherapy. If the patient FOLFOX, I will reduce it to 5-FU or single agent capecitabine, and I will keep them in anti-GFR. I have only one patient that I kept anti-GFR, which is a patient who has a prolonged course of chemotherapy as well as anti-GFR. And I keep him now on anti-GFR as a monotherapy. Now he's almost complete 6 months and he's doing remarkably well. But we cannot take this as as a recommendation or advice. I mean, every patient differs from others. I have patients that I reduce the dose of the chemotherapy, when I say the FOLFIRI chemotherapy, to 5-FU plus cetuximab, and the patient progressed very quickly. So I was planning to bring the patient to the full induction therapy. So totally agree with you, Majid. You can do, all the option is there, and what we have at the meantime is highly recommending. If you are going to do the maintenance therapy, go with reduced dose of chemotherapy plus one of this anti-GFR.
Thank you, Dr. Abdullah.
Yeah, Dr. Marwan, if allowed me, I'm Dr. Walid.
تفضل Dr. Walid. Go ahead.
Yeah. Thank you, Dr. Sharm, for excellent presentations, and for all speakers, Dr. Muhammad and Dr. Ali Al-Jubran. I have questions to Dr. Abdullah Sharm. We have there is publications this month regarding maintenance capecitabine or just active surveillance, and that is non-inferiority for those patients who receive induction chemotherapy and then there is a chemotherapy with BEV or chemotherapy or just active surveillance. There is no overall survival benefit, and there is a lot of data regarding holiday and just how is emphasized about this with idea of the maintenance.
Yeah, thank you so much, Walid. So I'm totally agree that, stopping or discontinuation of therapy completely, you need it necessarily in some necessary time. For example, Ramadan, for example, in Hajj, and in some occasions that we'd like to have complete discontinuation of therapy. And there is, as you say, there was some data about complete discontinuations of therapy, that there was no big difference, or what's called intermittent therapy. However, this is, again, you should remember, this is a phase 2 clinical trial, and we cannot judge on it. We need to have some time to see the clear impact on our daily practice. But we are doing it, Walid. We are doing this. I'm sure if you ask Mohammed Al-Garni, Marwan, Majid, Naval, we are doing this in daily practice. We are stopping the therapy for some times. There is some data that showed clearly that there is an impact on survival and decremental if we discontinue the therapy totally. And there is some data, they say it's not, but the quality of data, we cannot have a clear judgment to which way we should go. And I would like to hear from my colleague Marwan, Majid, Naval, Mohammed Al-Garni, what they think. It's an option, but we cannot recommend it. Still one of the options, but I don't believe that we can recommend to have complete discontinuation of therapy for at least prolonged times. I can do it for 6 weeks, 4 weeks, 6 weeks, 8 weeks maximum, but I cannot do it more than this.
Yeah, thank you, Dr. Sharm. A very interesting question, and I think maybe we will have a dedicated presentation, Dr. Sharif, for next year debate to talk about maintenance versus no maintenance. I think it's a very important topic. It's a common cancer in Saudi Arabia, and we always have that question whether to continue with more therapy or not, and what agent we should choose if we will do any. And as Dr. Walid was saying, the survival benefit is one of the most crucial outcome. But however, there are some controversies about discussing overall survival in the maintenance setting. But I will take just my position as a chairperson, and I want to ask one more question before we end the discussion to Dr. Mohammed Al-Garni. Dr. Mohammed, if now at this stage you were talked about metastatic or advanced cholangiocarcinoma or biliary tree tumors, what molecular testing you think we should do or include for all those patients if we want to treat them, and whether you do it in the first line or beyond the first line? If you want to choose a marker, which marker we need to do?
Thank you very much, Marwan, for the question. So I think most of the evidence that we have until now is coming for the second line and beyond. So regarding the timing of doing the test, it depends how quick you get the result and how the resources that you have. But most of the time, it's the second line or beyond. And sometimes in my practice, for those patients who are really fit for systemic therapy and I'm expecting them to be going to receive more lines of therapy, I order a test beforehand. Now, which test is selecting, also it depends on the facility, because initially we requested, this is my personal experience, when you request for FGFR, then you request for IDH, then you request for MSI. So our lab initially they were doing this test, in a different setting. So they do FGFR alone, they do the IDH alone, the MSI alone. Then they find the cost is really high. So now for all patients with cholangiocarcinoma, we are doing next generation sequencing, comprehensive profiling. It's because of the cost that we that is related to doing single gene test. I believe MSI should be done for all patients. And now we have FGFR, we have 2 approved medication. IDH1 also, it's important because we have the ifosidenib. Intrac for certain patients, if they are really still good for systemic therapy. So these are the markers that I would really very keen to do it. But by the end of the day, it's, it depends on the facility that you have and the how quick you can get the results.
Yeah, thank you, Dr. Mohammed. If any of the chairperson has any comment before we move to the next session.
Dr. Majid and Dr. Shar, mashallah, read my mind and asked the question I had actually. Excellent presentation. We learned a lot from the 3 of you. I was honored to participate in moderating this session. Thank you, guys.
Thank you. So thanks to all the speakers, Dr. Sharm, Dr. Mohammed, and Dr. Ali. And thanks to my co-chairperson, Dr. Majid and Dr. Nidal. With that, we will conclude the second GI cancer session, and we'll move to the next satellite symposium. And I think the moderator is Dr. Nidal Bukhari. Nidal Tashkandi.
يعطيكم العافية جميعا.
Yeah, he just walked into me, so get me a surprise.
Assalamu alaikum wa rahmatullahi wa barakatuh. Special thanks to Sharif, surveyor, for allowing me to chair this satellite symposium. I would like to introduce to you today a public figure and also a medical educator and consultant medical oncologist in Princess Noura Hospital, who is a big fan of coffee. So this is along the International Coffee Day. We'll be talking about the second line treatment, the recent trends. Please arrange for 1 or 2 hot questions, and the winner for that will be getting a subscription for a coffee, either from Sharif or Dr. Ahmed Al-Shehri or from Surveyor.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you all for being here today. Thank you once again, Dr. Sharif Al-Sammani, the organizer of this meeting, and of course, Surveyor for sponsoring this satellite symposium. I'd like also to thank my dear colleague, Dr. Imad, for his nice introduction. So I'm supposed to talk about the best strategy for colorectal cancer beyond the second line. So from second line beyond. So mostly in the third line setting and beyond that. So we know that colon cancer is one of the most common cancer entities globally and also in Saudi Arabia. If we rely on the Saudi Cancer Registry of 2017, which was the last report, almost 1,700 cases have been diagnosed. Almost 55 of them were in males and 44% were in females. You can see colorectal cancer rank number 2 among the most common cancer that have been diagnosed. It's number 1 in males. It's number 3 in females. The median age for males and females, it's around like 59 to 60 years old. Okay, you can see that Saudi Arabia still is not among the top recording or registering for colorectal cancers, as you can see here. However, if you look here, that a little bit more than 1/4 of the patients are diagnosed with synchronous metastasis. So they present with metastatic disease upfront. And almost like 39%, they present with locally advanced or lymph node positive disease. And out of those patients, like almost 15%, 15 to 20% will relapse over the next 5 years. So this will make us a total of 40% of all colorectal cancer diagnosed in our country, either with synchronous or metachronous metastatic disease. So this is the volume or how big the issue in our country. So how to rely on biomarkers to select the best treatment? We know that colon cancer is not one disease. There are been like several factors to choose the best treatment strategy, mostly in the first line, like the patient characteristics with regard to his age, comorbidities, patient preferences with regard to how toxic should we go with the chemotherapy to achieve the goal of management, the tumor characteristics about resectability, the tumor burden, and tumor location, right versus left, and most importantly, the molecular characteristics, like all the genetic mutations that we hear about since this morning about the RAS, BRAF, MSI high, and INTARC mutation. And this is why we have so many options nowadays that we use either sequentially, like to use single agent one after another, or to use it in combination to give the best treatment for patient X, Y, and Z. As you can see, either to use combination doublet or triplet plus one of these biological treatments like anti-VEGF or anti-EGFR. And of course, some of these like single agents can be used in later lines of treatments, like for example, regorafenib and TAS-102, as you can see here. So the secret of the longevity and improved survival of these patients is to use as much lines of therapy as much as you can, is to expose your patients to all these systemic therapies that we were talking about. So this is why we have first line, we have second line, and we have third line, and even beyond third line. Nowadays, we are talking about fourth and fifth line in colorectal cancer. And you can see that the hazard ratio will get less and less by subsequent lines of treatment. Like for example, by having one line of chemotherapy, you can see the hazard ratio is around 0.6. However, if you go up to 3 lines of systemic therapy, the hazard ratio will go down to 0.3, which means that the risk of reduction will be reduced by almost 70% if the patient was given more and more like systemic therapies. And this is why we see that the curve for survival went from like the classic 12 months with a single agent 5FU to what we have seen in the CLGB study, which have been presented almost 5 years ago, to over 3 years of overall survival, which is a huge kind of improvement due to the advances of all these systemic therapies that we have seen. So this couldn't be achieved, I mean, this kind of improvement in the curve of survival without having further and further lines of treatment. And this is why I'm focusing my talk now about the systemic therapies that can be given beyond the second line of chemotherapy. I like this graph because it presents the best approach for colorectal cancer, first line, second line, and third line beyond. And of course, according to the genetic mutations, as you can see, wild type, mutant RAS, BRAF, MSI, and so on. So based on this kind of algorithm, you can choose the best treatment strategy in the first line, second line, and third line. So I will focus now mostly on the second line and beyond, or beyond the second line. If the patient failed the classic chemotherapy options like FOLFOX, FOLFIRI, bevacizumab, cetuximab, panitumumab, all these fancy drugs that we have been talking about since this morning, what do we have options after those? We have three viable options. One of them is to go with one of the classic options that can be used universally in the third line setting, regorafenib, TAS-102, or to look for a targetable mutation, or to re-challenge with anti-EGFR, and I will talk quickly about each of these approaches. Let's start with the classic option, regorafenib and TAS-102. Regorafenib is an oral multikinase inhibitor that targets several tumor pathways. The most important of them would be VEGFR. And from where we get the clinical data is according to the CORRECT trial, where the first published trial about use of regorafenib with the classic dose of 160 milligram a day for 3 weeks out of 4 versus placebo. And the overall survival was the primary endpoint. There was significant improvement from 5 months to 6.5 months, 6.4 months with a hazard ratio 0.77 with a significant p-value, as you can see here. Progression-free survival also has improved significantly with a hazard ratio 0.49. So this trial was positive, okay? So we had another trial using what we call the sequence approach, regorafenib followed by cetuximab, or cetuximab followed by regorafenib. It's called the REVERSE study. It's a small one. It's a phase 2 study that included 180 patients. You can see that those patients who started the blue line here, who started regorafenib followed by cetuximab, they did better with regard to overall survival, although progression-free survival, despite the fact that it was numerically better for this arm, regorafenib followed by cetuximab, but was not statistically significant. So this might tell you that the earlier you use this agent, the better the outcome in these patients. The only problem, and actually the major problem that we face with regorafenib, is the toxicity. It's a kind of toxic kind of treatment with the current dose of 160 milligram. So this is why we had another study called REDOSE study. And what they have done, they tested 2 different groups, those who started the classic dose of 160 milligram daily versus those who started the lower dose or escalating dose. The first week, 80 milligram, second week, 120, then third week would be 160, and the fourth week will be rest, of course. And what they have found that the primary endpoint of this study, that the percentage of patients who were able to make it to cycle number 3. So 43% of the escalating arm were able to reach cycle number 3, while only 26% of those who went for the original dose or classic dose were able to go to cycle number 3. And as you can see, the overall survival, despite it was a smaller study, however, it favors the escalating dose of regorafenib. So this is why the current recommendation of using regorafenib, if you're gonna use it, is to use the first week of 80 milligram. If tolerated, you can escalate to 120. The second week, if tolerated, you can escalate to 160, and the fourth week would be off. If the patient couldn't tolerate this dose, you might reduce the dose to previous one. So if he couldn't tolerate it 160, so you can go back to 120 and so on. So what about the second option, which is TAS-102? TAS-102 is a kind of newer kind of like medication to be used in the third line setting of metastatic colorectal cancer. It's a combination actually of the active agent trifluridine, which is the most active agent as a chemotherapeutic agent. And the dose will be based actually on this one. So the classic dose is 35 milligram per square meter to be taken twice a day for day 1 to 5 and from day 8 to 12. What I recommend my patient to do, so they will not get confused, I'll tell them to take the dose from Sunday to Thursday and to take Friday and Saturday off and to start again Sunday to Thursday, and then will be 2 weeks off. I found my patient will be very, very compliant using this kind of regimen and using this kind of instruction. And of course, you can titrate the dose based on the body surface area, as you can see here. Okay, the RECOURSE study is a phase 3 study testing TAS-102 versus placebo in the third line setting. As you can see, with the classic dose, 35 milligram per square meter, I'm talking about trifluridine, versus placebo, as we mentioned. And the primary endpoint, as you can see, it was overall survival. You can see that the vast majority, actually all patients were ECOG 0 to 1, which is good. So it means that to get the best outcome of this treatment, you have to choose it while patient still in a good performance. Don't get late on your patient to start such a treatment. Okay, you can see that the number of cycles given before have been entered in this study. Like you can see, more than 80% they received at least 3 lines. And actually you can see 60% of patients, they received 4 lines and more of chemotherapy before they received the TAS-102 in this study, which means that this group of patients are heavily pretreated. So you can see this is the overall survival. It has improved from 5.2 months to almost 7.2 months. And you can see the 1-year survival improved from 16.6% to 27.1%. You can see the hazard ratio of 0.69, which means like there was a risk reduction of death by 31% with a significant p-value, as you can see here. And this is the progression-free survival. Once again, there was a significant improvement in favor of TAS-102 over placebo with a hazard ratio of 0.48 with a significant p-value. As you can see, this is the response rate is more than almost tripled by having the TAS-102 versus the placebo. This graph will tell you the preservation of the quality of life and performance status. So you can see that patients who had TAS-102, they had longer time to preserve their performance status in comparison to placebo, which indicate that this kind of treatment is quite tolerable by patients, and it was quite effective to control their disease so they can preserve their performance status for a longer time. And you can see in this graph, we started with 100% with a performance status of ECOG 0 to 1, but at the time of treatment discontinuation, when they progressed, you can see still 84% of those patients still in ECOG 0 to 1, which means again, that this kind of treatment had helped these patients to control their disease and performance status for as long as it takes. There was an analysis of this study, which was really interesting analysis to choose the best prognostic patients who might get the benefit out of TAS-102. And they have categorized those patients into 2 major categories. One of them is the good prognostic group, and the other one is the poor prognostic group. And the definition for the good prognostic group, those who have like 2 or less metastatic sites and who had a time interval from the diagnosis of metastatic disease till the time they have started the TAS-102, like more than 18 months. Okay, for the poor prognostic group who had more than 2 sites of disease, and those who have shorter than 18 months from time of diagnosis till time of randomization to TAS-102. And among the good prognostic group, there is what we call the best prognostic group, who have, in addition to 2 or less metastatic sites and more than 18 months from metastatic disease till randomization, they don't have liver metastasis. So these are the best prognostic groups. So let's see the outcome in each of these groups. You can see the intention to treat population for the whole population, the hazard ratio was 0.69, which is good, and it was significant. If you look at the good prognostic group, you can see the hazard ratio is even less, 0.69, which means that the benefit in this group was even bigger. Look at the good prognostic group without liver metastasis, what we call it the best prognostic group. You can see the hazard ratio 0.47. So you can see the median survival was in the range of 16.4 months, which was quite significant. So if you want to choose the best patient to receive TAS-102, will be those patients who have less than 2 metastatic sites and those who have more than 18 months from diagnosis of metastatic disease till randomization or till receiving TAS-102, specifically those who don't have liver metastasis. Those are the best performers on the TAS-102. The toxicity TAS-102, I actually started several patients, actually many patients of my colorectal patients have been started with TAS-102. It's quite tolerable kind of treatment. As you can see, the only problem that we see, like roughly around 40% of those patients might develop neutropenia. The vast majority of them is not symptomatic neutropenia. So the febrile neutropenia like risk or rate is about 4%. So in general, it's a quite tolerable kind of treatment. Apart from that kind of neutropenia, with the support of GCSF, patient can continue the treatment without interruption. There was another study in TAS-102 combining Avastin or Vivasusumab. So it was TAS-102 plus Vivasusumab versus TAS-102 alone. And you can see the progression-free survival and overall survival, both in favor of the combination of TAS-102 plus bevacizumab. This study in the third-line setting. There is another study in the first-line setting that I didn't include in this talk. But here, if you're gonna use the TAS-102 plus bevacizumab in the third-line setting, I prefer this kind of approach over TAS-102 alone, given the fact that the progression-free survival and overall survival was better. So enough said about the classic options, the regorafenib and TAS-102, and let's move on to the targetable mutations. What are the mutations that you look at cycle 2 and beyond, okay? I would say one of them is the BRAF mutation, one of the most important kind of mutation that you have to look at. Nowadays in our center, we test all colorectal cancer. From day one, we test them for BRAF mutation. We know that BRAF mutation is a bad prognostic kind of biomarker. Those who have BRAF mutation, usually they do worse, as you can see, in comparison to those who have wild type BRAF, as you know. Why it's important to test for that? Because there was a study called Beacon study, which have tested a combination of anti-MEK, anti-BRAF, and anti-EGFR in the second or third line of treatment and beyond. So they have tested triplet treatments, the encorafenib, binimetinib, and cetuximab versus encorafenib and cetuximab versus the classic chemotherapy FOLFIRI or irinotecan plus cetuximab. Those patients were required not to receive cetuximab in prior lines of treatment. And as you can see, whether talking about the triplet regimen, the anti-BRAF, anti-MEK, anti-EGFR, or the doublet of cetuximab and encorafenib, there was significant improvement over chemotherapy and cetuximab. And this is why we have seen that kind of combination of encorafenib and cetuximab to be the standard of care in those patients who have BRAF mutation from second line and beyond. And as you can see, the responses were far better for the biological treatments over the chemotherapy plus cetuximab. And this is for the doublet regimen, as you can see, encorafenib plus cetuximab versus chemo plus cetuximab. So this is why I think this kind of regimen should be the standard of care. Nowadays, I have 2 patients on this kind of regimen. They quite tolerated this kind of treatment. The only problem that some of them might face would be diarrhea, which is really manageable by most of us who are trained to treat such a problem. What other targetable mutation? One of them is the HER2 positive disease by immunohistochemistry or FISH. And as we know that the incidence or the prevalence of such a problem is about 4%, is more commonly associated with left-sided colon cancer with RAS and BRAF wild type cancer. So you don't have to test every patient for colorectal cancer with this kind of testing, only for left-sided, those who have wild RAS, wild BRAF. And as you can see, if you use different kind of combinations of anti-HER2 with trastuzumab, lapatinib, trastuzumab, pertuzumab, and there are a lot to come on the way, you still see a deep and durable responses because of anti-HER2. And you can see this is the My Pathway study, trastuzumab and pertuzumab. There was a Destiny study, which was presented like almost 1.5 years in the ASCO 2020, testing the trastuzumab deruxtecan kind of treatment. As you can see, the overall response rate was in the range of 45%, which is quite significant. This is third line of treatment. So this is why you have to test the right patient for this targetable mutation. And if you have it, you will get a good and durable responses. And these are the different anti-HER2 agents that have been tested in HER2 positive colorectal cancer with all of the responses that you can see ranging somewhere between 35% to up to 50%. So consider that seriously for your patients if they have such targetable mutation. Of course, these anti-HER2 treatments differ with regard to their toxicity profile. So you have to look into that before you prescribe any of these agents to your patients and to discuss the treatment options with them. Another kind of targetable mutation would be MSI. Nowadays, we test MSI upfront in the first line setting. And if the patient was MSI high, you start Pimpro in the first line setting. However, we still have large number of patients who used to be treated with the old standard. So some of them did not receive the immunotherapy in prior lines of treatment. So if they haven't, you have to test for MSI. And of course, if the patient was MSI high, you may consider one of these agents, Pimpro or nivolumab, in the third line setting. As you can see, the responses here are impressive, somewhere between 30 to 35% if you have an MSI high colorectal cancer in later lines of treatment. The last targetable mutation that I'll talk about is the INTARC gene fusion. And as we know that there was a basket trial that have included several types of cancers with this specific fusion mutation, the INTARC fusion. And if they have been tested positive for that, those patients will be candidate to anti-INTARC like larotrectinib and entrectinib. And this is one of the studies, the larotrectinib, and they have included almost like 11 colorectal cancer patients, and all of them showed a remarkable response to the anti-TARC treatment. So enough said about targetable mutation. The last kind of strategy to use in the second line and beyond would be a re-challenge with anti-EGFR. And I wouldn't go deep with that because some of my colleagues have discussed that in previous talks. In summary, if you have a RAS wild type colorectal cancer who received anti-EGFR in the first line setting and progressed on that, received second line treatment, after second line progressed, you have to test for RAS mutation by circulating DNA. If found to be RAS wild type, you may consider reintroduction and re-challenge with anti-EGFR, either like alone or with irinotecan. So there have been like 2 phase 2 trials, which showed some efficacy with a response rate between 25 to 30%, which is another reasonable kind of approach. So what is my approach beyond the second line? If I have a patient now who failed 2 lines of treatment, what should I do by tomorrow? First of all, I think the best strategy to test for targetable mutation. If you have one of these mutations, I think the best treatment strategy is to target these mutation. MSI for those who didn't receive it before immunotherapy, and all patient colorectal have to be tested for that. BRAF mutation, all colorectal have to be tested for that. And if you have it, then patient has to be treated with the combination cetuximab and encorafenib. HER2, preferably a left-sided colon cancer, and it has to be wild type RAS and wild type BRAF. Then you can use either dual anti-HER2 therapy or trastuzumab deruxtecan. INTARC fusion, you have to test for that also only for wild RAS, BRAF, and for MSI high colorectal cancer. And if it is found, you can start either larotrectinib or entrectinib. If you don't have any of these targetable mutation, then you can go with one of these classic options, TAS-102, regorafenib. TAS-102, I told you about the best prognostic group, those who have 2 or less metastatic sites, those who have 18 months from time of diagnosis metastasis till the time of starting TAS-102, and specifically those who don't have liver metastasis, those are the best candidate for TAS-102 if you want to get the best results out of it. And if classic option failed, if you start these agents and patient progress on that, then you may consider re-challenge with anti-EGFR with these conditions. If upfront wild type RAS on tumor tissue, if received anti-EGFR first line for more than 6 months, then progressed. If received second line with no anti-EGFR for 6 months, then failed. And number 4, if retested for RAS by having circulating DNA and found to be wild type RAS, then you may consider re-challenge with anti-EGFR plus minus irinotecan. So to summarize my talk, in metastatic colorectal cancer, beyond second line systemic therapy should focus on quality of life and survival. Determinants include performance status, tumor burden, toxicities of previous systemic therapy. Consider targetable mutations and biomarkers first, like BRAF, MSI, HER2, and INTARC. If no targetable mutation or biomarker, then go for the standard third line options like regorafenib or TAS-102. Avoid recycling or re-challenge with previous systemic therapies. Leave them as a salvage option. So don't go to re-challenge without trying the third line options that have a phase 3 like kind of studies like TAS-102 or regorafenib. Predictors for best outcome for TAS-102, we said 1 to 2 metastatic site, more than 18 months since first metastasis, no liver metastasis. TAS-102 plus bevacizumab is more active option than TAS-102 alone in later lines of therapy and might be better than cytibine bevacizumab in the first line setting. And with that, I would conclude. Thank you.
Such an elegant presentation. Thank you, Ahmed. So you can prepare your question to win the coffee subscription. Now I'll start by the first for you, Ahmed. So now if I would like to integrate your classic options and targetable mutation, if I talk about TAS-102 or regorafenib, you know, many patients, we put them on and they have good benefit. Now, is there any biomarker approach based on the current existing literature or based on your experience can guide us for those who can help us, they will do better on those drugs?
You mean they do better on TAS-102 or regorafenib?
Yes, based on the biomarker approach.
Yeah, I think we don't have biomarkers, to be honest with you. And this is why we call them like classic option that can suit all patients. Like, for example, if I have a patient who failed 2 lines of treatment and I don't have any of these targetable mutation available, I have to test for them. The good thing about these options, you can start immediately because you don't have a predictor which one will work the best. The TAS-102, specifically, we have what we call the clinical predictors, not biomarkers, like not a genetic kind of testing. As I mentioned, with regard to the metastatic side to be less than 2, no liver mets, preferably, and the interval from first diagnosis of metastasis till starting TAS-102 more than 18 months. If I have these criteria, those are the best candidates to start TAS-102, to be honest with you. And as we can see, the median survival was approaching like 16 plus months in those patients. So in those patients, I would jump immediately to start such a treatment. But to have a specific biomarker for these two, I'm not aware of any biomarker.
All right, we have a question here from Faisal.
Thank you, Dr. Ahmed, for the nice presentation. My question, about the second line, if there is no targetable mutation or whatever, or MSI, BRAF, whatever, if you want to use TAS or regorafenib, which agent you will start? Regorafenib is approved before, then came the TAS. Which one you preferred to use in the third line setting?
Yeah, this is a tough question, to be honest with you, because...
And do we have data about the sequencing to use Regora followed by TAS or TAS followed by...
predictor to response to TAS-102, I might choose this option. As I mentioned, with regard to the time interval, more 18 months, metastatic size less than 2, I prefer to use TAS-102. At least I have some clinical data that support the TAS-102 might be more beneficial in this kind of clinical scenario.
I have a comment as well for that point, Dr. Ahmed. I think they are all available options.
That's right.
And if you look to the survival outcome for colorectal cancer now, 10 years back, we have better outcome. This is in part at least because we have more options. So it is incremental effect of additional medication. So the most important thing, as much as you can expose the patient to more medication, it will increase the survival outcome.
I totally agree with you, Dr. Sharif. And one more comment about that. Don't let your patient to get down and down before starting third line. But because what we see in clinical practice sometimes, we continue second line. Okay, the patient is progressing on CT scan and he is getting down, and we continue for extra 2 months or 3 months on the same kind of chemotherapy. Okay, so as we saw in most of these clinical trials, whether talking about regorafenib or TAS-102, the vast majority of these patients have been started on this treatment while they still have a performance status of 0 to 1. In clinical practice, what we see, most of the patients, they start while they have ECOG 3. Okay, and this is why sometimes we don't have the good outcome as we see in the clinical trial for TAS-102 or regorafenib. Okay, regorafenib has the added problem of the toxicity that we need to work on it and to monitor our patients closely just to pass the first 2 months. Once they pass the 2 months with no major toxicity, they can continue that like with no major problems. I totally concur with you, Dr. Sharif, with this regard.
Well said. Kindly, can we look at the Q&As? I noticed there was one question, if I'm not mistaken. No? All right. If there is no question, I could ask the last question and then we can conclude for lunch. So now you highlighted very important slide. How can we give the good option for patient based on the dose for regorafenib? And also you showed us a slide about TAS-102. Now, how can we, practically speaking, how can we give the correct dose based on TAS-102 if the patient has some intolerance?
Yeah, I think for the dose, the proper dose is 35 milligram per square meter. I know that sometimes, we have a problem with the available strength of the pills. So usually I discuss the case with my colleagues in clinical pharmacy, and between the two of us, we titrated to be close to 35 milligram per square meter. So to be honest with you, it's a combined decision between me and my clinical pharmacist on how to use it. As I mentioned, in the TAS-102, no major toxicity except for neutropenia, and most of the time is asymptomatic neutropenia. And this is the only reason where sometimes I'm forced to reduce the dose a little bit just to keep patients following with me. But because of the availability of the pills and the strength of these kind of agents, I always consult my colleague from clinical pharmacy to titrate the dose to be around the 35 milligram per square meter.
All right. With that, thank you so much. Thank you, Servir. Thank you, Sharif. And now we move to next session, which is lunch. All right. Thank you.
Okay, the lunch will be in Spears restaurant and we'll come back at 3 inshallah. Thank you very much.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. السلام ورحمة الله وبركاته.
السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام ورحمة الله وبركاته.
معلش أساتذتنا وزملائنا الأعزاء، بس إحنا حنتأخر أبو 5 إلى 10 دقائق لأن هم في السيشن قبله الآن تكلمتهم، فقالوا إنه بس تأخير من 5 إلى 10 دقائق عبين ما يبدو إن شاء الله.
تمام إن شاء الله، خلاص بعد 10 دقائق نفتح تاني إن شاء الله.
من بعد إذنكم. جزاكم الله خيرا.
الله يحفظك، الله يخليك.
السلام
ورحمة الله.
بسم الله الرحمن الرحيم. Are we ready? بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وأزواجه. First of all, I want to thank Dr. Hafiz, Dr. Sharif for arranging this interesting and fruitful conference. Actually, we'll start the GEO meeting. We'll chair this session, Dr. Mubarak Al-Mansour. He's a senior consultant medical oncologist at Princess Noura Oncology Center, and he is the head of the Oncology Center. And Dr. Han Al-Khatib, he is a consultant medical oncology at King Abdullah Medical City. I'm Dr. Faisal, also a consultant medical oncology from King Abdullah Medical City. We'll start with the first presentation by Prof. Yusri. Prof. Yusri, he is a professor of clinical oncology, and he's the head of clinical oncology and the nuclear medicine department at Alexandria University. Dr. Prof. Yusri will speak about the IO versus IO-TKI, first line metastatic RCC. Prof. Yusri, the mic's with you.
Assalamu alaikum. My presentation is recorded. Please start the recording and I'll be with you for any questions. I'd like to thank Professor Hafiz and Professor Sharif for this invitation, and I hope we meet together next time face to face. Rostom, Head and Professor of Clinical Oncology and Nuclear Medicine, Alexandria University, Egypt. I'm honored to join you from Alexandria in this esteemed meeting. I'd like to thank my dear friend, Professor Hafiz Ghanem and Dr. Sharif Samani for inviting me to this esteemed conference. Today, I'll be discussing the role of IO versus IO-TKI in the first-line treatment of metastatic renal cell carcinoma. As you all know, 30% of renal cell carcinoma patients have metastatic disease at their initial presentation. The International Metastatic Renal Cell Carcinoma Database Consortium put certain criteria for categorizing metastatic renal cell carcinoma into 3 categories. Either favorable risk group with no prognostic factors, or intermediate risk group with 1 or 2 prognostic factors, and poor risk group with 3 to 6 prognostic factors. What are these prognostic factors? These prognostic factors are mentioned here, which is time from initial diagnosis to treatment less than 1 year, Karnofsky performance test less than 80%, low hemoglobin, high calcium level, high platelet level, high neutrophil level. 75% to 80% of metastatic renal cell carcinoma patients are poor or intermediate risk. This risk factor categorization reflects well on survival, where patients who receive treatment with low risk factors showed 75% overall survival at 2 years, while patients with poor prognostic factors show only 7% at 2 years. These are the NCCN guidelines of systemic therapy for relapse or stage 4 renal cell carcinoma. As you see here, TKIs and immunotherapy combinations, or immunotherapy and immunotherapy combinations, are all category 1 in the treatment of this kind of disease. Now we come to the combination of immunotherapy and immunotherapy, testing nivolumab, ipilimumab. This Checkmate 2014 categorized patients according to the IMDC prognostic score. The treatment-naive renal cell carcinoma, clear cell, with measurable disease, Karnofsky performance status more than 70%. Patients received either arm A Nivo 3 milligram plus epi 1 milligram every 3 weeks for 4 doses, followed by nivo every 2 weeks. Or arm B, sunitinib 50 milligram once daily for 4 weeks on, 2 weeks off. Treatment until disease progression or an acceptable toxicity. The combination of nivo-epi showed significantly better overall survival at 17.5 months and 30 months and 42 months, with a hazard ratio of 0.6 to 0.66% for all the 3 groups, compared to only sunitinib. This was also translated to a better progression-free survival at the same intervals, with a decreased risk of progression of about 18%, significantly better than the sunitinib at 17.5 months, and decreased the risk of progression by 24% at 42 months. Nivo-epi combination showed a better response rate in the intermediate and poor risk, as well as intent to treat population. When we have an exploratory favorable risk patient, the sunitinib showed a better response rate. As regards adverse events, as expected, the group who received sunitinib suffered more from diarrhea, fatigue, while the patients who received nivo plus epi suffered more from fatigue. Now we move to another keynote 426, which compared axitinib, pembro against sunitinib. The same categorization as the other studies, about 430 patients in each group. The endpoint was overall survival and progression-free survival. Patient at arm 1 received pembro 200 milligram intravenous every 3 weeks for up to 35 cycles, plus axitinib 5 milligram orally twice daily. While in the sunitinib arm, they received this conventional 50 milligram orally once daily for the first 4 weeks of each 6-week cycle. The combination of pembro-axi showed a better overall survival through 18 months, 30 months, 36 months, with a median overall survival for the pembro-axi of 45.7 months, compared to only 40 months to sunitinib, with decreased the risk of death of about 27%. This improvement was maintained in the progression-free survival in the intent to treat population. Patients who received the combination showed a better median overall median progression-free survival of 15.7 months, compared to only 11 months for sunitinib, with decreasing the risk of progression of disease of about 32%. The combination of pembro-axitinib showed better objective response rate of 60.4%, compared only to 39.6% for the sunitinib group, which was significantly different. Adverse events were, as usual, seen in this kind of medications, with diarrhea and hypertension in the pembro-axitinib group and sunitinib group as well. Checkmate 9ER, which randomized 651 patients with previously untreated, advanced or metastatic RCC clear cell component, any IMC risk group, either to if there is any problem with the presentation. When in patients with a favorable risk, the median overall survival didn't differ significantly between the two groups of treatment. The combination of Nivo plus Cabo showed a much better progression-free survival when compared to sunitinib alone, where the decreased the risk of disease progression or death by 49%. Overall response rate favored Nivo plus Cabo over sunitinib across all subgroups, including by MDC risk status, tumor PD-L1 expression, either more or less than 1%, and bone metastasis, with 55.7% overall response rate for the combination arm, compared only to 27% in the sunitinib arm, which was statistically significant. Adverse events were quite similar, and the incidence of grade 3 and 4 toxicity were within the acceptable range. Of course, diarrhea, hand foot syndrome, hypertension, and hypothyroidism are the main adverse events in this group of patients. The CLEAR trial, which is a first line lenvatinib pembro or lenvatinib everolimus versus sunitinib in advanced renal cell carcinoma, where 1,069 patients with treatment-naive advanced clear cell renal cell carcinoma were stratified by region into either lenvatinib pembro or lenvatinib evero or sunitinib. The primary endpoint was progression-free survival. Secondary endpoint was overall survival, overall response rate, as a key exploratory endpoint with the duration of response. As expected, median progression-free survival was significantly better for the lenvatinib pembro of about 24 months compared to the lenvatinib everolimus, which is 14.7 months, and sunitinib, which was 9.2 months alone. When we compared lenvatinib pembro versus sunitinib, it decreased the risk of progression by 61%, while when we compared lenvatinib plus everolimus versus sunitinib, it decreased the risk of progression by 35%, which was statistically significant in both groups. The combination pembro plus lenvatinib showed a better overall survival when compared to sunitinib alone, with decreasing risk of death of 34%, while the combination of lenvatinib plus everolimus didn't show a significant survival difference between the both groups. The combination, either lenvatinib plus pembro or lenvatinib plus evero, showed a significantly better overall response rate when compared to sunitinib alone, where it was 71% for the lenvatinib pembro and 53% for the lenvatinib evero, while it was 36% only for the sunitinib, which was significantly different. In the CLEAR trial, the combination of lenvatinib pembro showed a much better median duration of response of 20.8 months compared to the other combination of lenvatinib plus evero, which showed 16.6 months, and the sunitinib, which showed only 14.6 months. Regarding treatment exposure, a patient who received lenvatinib pembro exposed to treatment of a median duration of 17 months compared to 11 months in the lenvatinib evero arm and 7.8 months in the sunitinib arm. Grade 5 treatment adverse events were observed in 1.1% of patients in the lenvatinib pembro arm, 0.8% in the lenvatinib evero arm, and 0.3% in the sunitinib arm, which is logic. Alkaline transaminase elevation observed in 9.7% patient with lenvatinib plus pembro arm and 8.8% of patients in the sunitinib arm. Grade 3 in 3.1% of patients in the lenvatinib plus pembro arm versus 1.8% in sunitinib arm. AST elevation observed in 9.4% of patients with lenvatinib plus pembro arm and in 8.8% of patients in sunitinib arm. Grade 3 in 2.6% of patients in lenvatinib plus pembro versus 0.6% in the sunitinib arm. The Javelin 101 trial tested avelumab plus axitinib for advanced renal cell carcinoma. About 886 patients were stratified according to the ECOG PS geographic regions into either avelumab axi against sunitinib. In patients with PD-L1 positive tumors, the combination of avelo-axi showed much better progression-free survival of 13.8 months compared only to 7.2 months for the sunitinib group. While in the overall population, the combination showed a better, significantly better progression-free survival of 13.8 months compared to 8.4 months for the sunitinib, which decreased the disease progression or death by 31%. Regarding overall survival in the PD-L1 population, the combination of axitinib avelumab showed significantly better median overall survival when compared to sunitinib and decreased the risk of death by 17%, while in the overall population, it decreased the risk of death by 20%. The combination of avelumab axi showed better anti-tumor activity in both PD-L1 positive tumors and overall population, where the confirmed objective response rate were 55% in the combination arm compared to patients who received sunitinib in the PD-L1 positive tumors, and 51.4% for the combination arm compared to 25% in the overall population. The median duration of the response was shorter in the combination arm in PD-L1 tumors of 1.6 months compared to 3 months in the sunitinib arm, as well as in the overall population, the avelo-axi showed better duration or a shorter time to response of 2.6 months compared to 3.2 months for this. The incidence of adverse events were similar in both treatment groups, with all the known complications as already mentioned before. Here, to conclude, as you see here, this is a kind of summary or conclusion where the Checkmate 214 tested IO against TKI, which is sunitinib. It showed duration of overall response rate of 42% only, while the other 4 trials, Keynote 426, axitinib pembro, Javelin axitinib avelumab, and Checkmate cabozantinib nivolumab, and Clear lenvatinib pembro showed better overall response rate of 59, 55, 55.7, and even 71%. And the progression-free survival followed the same pattern, where the patient who received IO plus TKI showed better progression-free survival. We cannot do this kind of comparison, but it's kind of indicator to us to guide us to which treatment we can use. There is something to note is here for the IO plus IO, the 4-year progression-free survival is 31%, and with 38.4 months for the suitant arm. And this is a very high 4-year progression-free survival for this kind of patients. IO-TKI combination yield the best combination of upfront for overall response rate and progression-free survival and long-term overall survival benefit to date in the treatment of patient with metastatic or relapsed renal cell carcinoma, while IO shows more durable sustained response. For favorable risk patients, some can be observed or started on single agent VEGF TKI as suitant. Good toxicity management ensure responding patient can stay on active therapy. Thank you very much. You are all invited to our next ACOD meeting, which is Alexandria Clinical Oncology Department annual meeting. The next meeting is the 24th. It will be held in Alexandria in hybrid pattern from 3rd to the 5th of November 2021. Thank you again, and see you live next time or in Egypt favorably.
Thank you very much. Nice presentation. Dr. Hani.
Thank you, Dr. Yusri. Our next speaker will be presented by Dr. Amin Tijani. Dr. Amin Tijani, he is a consultant of medical oncology at King Abdulaziz Medical City, and his presentation will be about the role of targeted therapy in urothelial cancer. Would you start, please, Dr. Amin?
Thank you very much, Dr. Hani Al-Khatib, for your kind introduction. And also I would like to thank the organizing committee of this successful meeting, especially Dr. Sharif Al-Sammani and also Dr. Hafiz Ghanim. So my task is to talk about the role of targeted therapy in urothelial cancer. So my agenda today, I will make quick first-line treatment updates and also second-line treatment updates, and then I will talk in more details about the targeted therapy in metastatic urothelial carcinoma. And when we talk about the treatment of metastatic bladder cancer, especially in the first line, we need to consider cisplatin eligibility. And as we know that cisplatin eligible patient, they should have good performance status, normal creatinine clearance, and also they should not have hearing loss or peripheral neuropathy or heart failure. And this is defining the medically frail patients with echoic performance status 2 or more, creatinine clearance less than 60, hearing loss of 25 megabecquerel, and peripheral neuropathy, and also class 3 heart failure. And when we see the treatment for cisplatin eligible since long time, maybe more than 20 years, cisplatin, gemcitabine, and dose-dense MVAC are standard of cares. And till now, there is no changes on that. Regarding cisplatin ineligible patients, usually they will receive carboplatin and gemcitabine. And if we look in the second line for chemotherapy, there is some data in phase 2 trials with limited activity of the taxanes. And when we come to the era of the immunotherapy and checkpoint inhibitors, in the second line, we have initially like 5 immunotherapeutic agents, which was approved. But now currently there is some updates. I will discuss about it later. And also in cisplatin ineligible patient, we have 2 medication, which is atezolizumab and pembrolizumab for patients with PD-L1 high. So what is the first line treatment updates? And if we look to most of the guidelines now, as I mentioned, cisplatin-based chemotherapy is the standard of care, beside carboplatin for those patients which are ineligible. The question here, the role of, what about the role of switch maintenance? And this question actually was addressed in this trial in Javelin Bladder 100, avelumab maintenance for advanced metastatic urothelial carcinoma. And this trial patient, after receiving the first line chemotherapy, which including cisplatin and gemcitabine or carboplatin gemcitabine, they received 4 to 6 cycles. And for those patients who achieve complete response, partial response, or stable disease, and after treatment-free interval of 4 to 10 weeks, patient randomized to receive either avelumab, 10 milligram per kg IV every 2 weeks, plus supportive care, and the standard arm is the best supportive care alone. Patient treatment continue until progression of disease or unacceptable toxicity or withdrawal from the trial. The primary endpoint here is overall survival in all randomized patients and also in the PD-L1 positive population, with the secondary endpoint, which include PFS, objective response, safety, and patient-related, patient-reported outcome. Stratification all done here according to the response and the metastatic site. And in this trial, the overall survival, which was the primary endpoint in this trial, was met, favoring avelumab plus best supportive care, which with a median overall survival of 21.4 versus 14.3 months for best supportive care alone, with the hazard ratio of 0.69 and a significant p-value. If we look to those with PD-L1 positive population, also the overall survival is significantly better, favoring adding avelumab to best supportive care, which was not reached in the PD-L1 positive population in avelumab versus 17.1 months for best supportive care, and the hazard ratio was 0.56. Again, progression-free survival is significantly better, also 3.7 versus 2. And also in the PD-L1 positive, it is also significantly better, 5.7 versus 2.1. So the conclusion of this trial, Javelin Bladder 100, it met its primary endpoint by showing significant longer overall survival with avelumab as the first-line maintenance versus control. And this is both in the overall population and in the PD-L1 positive population. Also, this overall survival was longer across all pre-specified subgroup, which actually did not show here. Safety profile for avelumab as the first-line maintenance was manageable and consistent with the previous study of avelumab monotherapy, and avelumab first-line maintenance now approved for patients who has not progressed with platinum-based induction chemotherapy. And this represents a new first-line standard of care now. If we look, this slide shows that there is, like if we look to compare between switch maintenance versus second line, and here is the switch maintenance, which showed 21.4 overall survival benefits. And this patient, as we mentioned, had to have stable disease, partial response, or complete response. When compared to Keynote 45, which is a study of pembrolizumab versus chemotherapy in the second-line setting, we can see here overall survival of pembro about 10.1 months. So the question is platinum, post-platinum based chemotherapy, is a switch maintenance checkpoint inhibitor preferred over treatment break followed by second line? So actually for most patients, the answer will be yes. There is longer overall survival with the switch maintenance, and the progression-free survival is meaningful in this setting. But not all patients can receive we know that not all patients can receive second-line therapy. However, if we can grant you to give patients second-line checkpoint after treatment break, so this might not impact their survival. And as we know, some patients have durable responses to platinum chemotherapy, and they might not need the treatment, and those patients will be like over treated. What is the second-line treatment updates? So in the first line, the only thing which is recently more than 1 year is the avelumab maintenance after first-line chemotherapy. In the second-line treatment updates, and as you know here, we have before 5 point inhibitors approved in the second line in the treatment refractory after platinum-based chemotherapy. And actually, you cannot compare these head-to-head, but most of these are phase 1 to phase 3 trials with different number of patients. The objective response rate in this trial ranges from 15 to 20%, with median overall survival also from 7 months up to 18 months. Modest median progression-free survival and the toxicity are more or less the same. But in 2021, there is some recent update, and regarding atezolizumab, there is a study which is the phase 3 trial, which is called IMvigor211, which is a randomized phase 3 trial. This study actually showed lack of survival benefit for atezolizumab, and this leads to withdrawal of the regulatory approval of atezolizumab for this indication. The other medication, also durvalumab, also tested in DANO phase 3 trials. And in this trial, it showed also lack of survival benefit for durvalumab. And based on this data, the regulatory approval for durvalumab in second line was voluntarily withdrawn. So we left like with three immune checkpoint inhibitors in the second line, but here I can say if we use avelumab in the maintenance, all of these will not be valid in this setting because we cannot use immuno after immuno. What about targeted therapy in metastatic urothelial cancer? We have this important trial, which is a phase 2 study of erdafitinib with metastatic urothelial carcinoma with FGFR alteration. And the fibroblast growth factor receptor alterations, as we know, is common in cancers. In metastatic urothelial cancer, it goes up to 20%. And we can find it actually more in non-muscle invasive bladder cancer, reaching 70%, and we have it also in multiple other tumors, including cholangiocarcinoma, non-small cell carcinoma, and others. And we see that FGFR3 specifically mutation are particularly common in those with upper urothelial tract. It reaches up to 37%. Erdafitinib is a potent FGFR inhibitor. It is a pan-FGFR1-4 inhibitor. It's actually taken by the lysosome, which results in sustained intracellular release, which may contribute to its long-lasting activity. And it shows promising activity in multiple malignancies, including bladder cancer with FGFR alteration. And in this trial, it includes actually 3 regimens. Patient randomized who have actual FGFR fusion mutation. After that randomization occurred according to the doses. Here I will focus on the regimen 3, which receive 8 milligrams once daily with pharmacodynamic uptitration according to toxicity to 9 milligrams once daily, and number of patients here about 99 patients. The primary endpoint was objective response rate, and the secondary endpoint progression-free survival, duration of response, overall survival, and safety. And this is the primary endpoint, which was the objective response rate, which is about 40%, with a complete response about 3%, partial response 37%, and stable disease 39%. And if we look to the progression-free survival and overall survival, the progression-free survival for irdafatinib was 5.5 months versus, and for median overall survival, it was 13.8 months. This is the same, maybe the same data. And according to this is more than 2 years now, the FDA granted accelerated approval of irdafatinib for platinum refractory metastatic urothelial carcinoma patients with FGFR2 and 3 genetic alterations. The other medication today I want to discuss is the enfortumab vedotin, which is antibody drug conjugate, which is targeting Nectin-4. And this antibody drug conjugate actually is made up of 3 parts: the antibody, which is anti-Nectin-4, the payload, which is MMAE, which is the microtubule disrupting agents, and it contains the linker, which will be stable. Actually, the linker is stable in the circulation, but when it goes to the target cell, it releases the cytotoxic agents, and it will have its effects. Enfortumab vedotin actually tested in different phases of trial, and this is one phase 1 trial in patients with metastatic urothelial carcinoma, and it showed confirmed objective response rate ranging about 40% in those with prior checkpoint inhibitor treatment naive, 43% for those received checkpoint, 40%, and even with patients with poor prognosis with liver metastasis, about 39% is the objective response rate here. Another study, EV201, and this study actually there is 2 cohorts. For the sake of this presentation, I will discuss cohort 2 for those who are platinum naive and cisplatin ineligible. And the primary endpoint in this trial was objective response rate. And the confirmed objective response rate reaching 52% in this trial with complete response about 20%, and partial response 31%, stable disease 30%. This is the duration of response in the trial, around 11 months. The progression-free survival and overall survival, 5.8, and in the overall survival, 14.7 months. There is another large phase 3 trial of enfortumab vedotin versus chemotherapy in patients with previously treated locally advanced or metastatic urothelial carcinoma. And in this trial, patient with histologically, cytologically confirmed urothelial cancer, even they include squamous differentiation, after radiographic progression or relapse during or after PD-1, PD-L1 treatment for advanced urothelial cancer, and patient also received prior platinum-containing regimen, randomization 1-to-1, enfortumab vedotin versus chemotherapy, and chemotherapy used here docetaxel, paclitaxel, and vimflonin. The dose is 1.25 milligram per kg on day 1, 8, and 15, each 28-day cycle. The primary endpoint was overall survival, and secondary endpoint include PFS, disease control, overall response, and safety. And this is the overall survival, the primary endpoint, which was met 12.88 months for enfortumab vedotin versus 8.97 for chemotherapy arm. This is the progression-free survival, which is also significantly in favor of enfortumab vedotin versus chemotherapy, 5.55 versus 3.7 months. Objective response rate, this is the overall response rate, 40.6 versus 17.9. This is for chemotherapy group. This is the adverse effects.
Yes. Doctor, I mean, just 2 minutes, please, and will to end up, please.
Okay. I will finish. The last one is this trial, which is tested the sacituzumab govitecan in patients with metastatic urothelial cancer. And it is the TROP2 directed antibody, and also tested in this study. There is 3 cohorts according to prior treatment with platinum or checkpoint inhibitors, and this is the doses here and the treatment. This is our primary objective response was overall response rate, which is 27% objective response rate. This is the responses here, and I will go through this to conclude for the sake of the time. This is a survival outcome. This is a progression-free survival, 5.4 months, and overall survival, 10.5 months. This medication also granted the FDA approval in April this year after platinum chemotherapy and checkpoint inhibitors. We have other exciting agents in the first line combination, Vidutin plus Pembro, Lenvatinib plus Pembro, and other second lines also with different combination, including also PARP inhibitors combining with immunotherapy. So if I look to the current standard of care now, frontline therapy for cisplatin eligible, as you know, dose-dense MVAC or GIMSIS. For ineligible patients, for PD-L1 unknown, carboplatin will be the choice here. Unless they are platinum eligible, I can use Pembro or Atezo. For cisplatin ineligible, PD-L1 positive, Pembro or Atezo. Here or carboplatin alternative for that. Avelumab maintenance now is the standard of care after for those who are not progressed after platinum. This is the subsequent therapy. Here now in the targeted therapy we have erdafitinib for patients with FGFR3 mutation of FGFR2/3 mutation, and also we have in the subsequent therapy, enfortumab vedotin and sacituzumab govitecan. So my conclusion of this talk, actually, there is limited progress with the standard chemotherapy and with chemo-IO combination in the first line setting. The changes on current treatment landscape actually specific in immunotherapy, targeted therapy, and antibody drug conjugates, but not all patients, not for all populations. We know that toxicity are challenges and also the cost effectiveness of the disease. So we are expecting new therapies and combination which might improve the therapeutic outcome for these patient categories. Thank you very much.
Thank you very much, Dr. Amin, for your presentation. And now we'll move with Dr. Mubarak Mansour, one of our panelists. He will present our next speaker. Dr. Mubarak is a section head at the Adult Medical Oncology Section, consultant of medical oncology at Princess Noura Oncology Center. Dr. Mubarak, please.
No voice.
Dr. Mubarak?
No voice.
Can you hear me?
Yes. I didn't hear Dr. Mubarak.
Yes, Dr. Mubarak. Hold on, Dr. Hussein. I will check.
Prof. Hussein, do you hear us? Well,
now,
yeah.
yes.
Yeah,
okay.
Go ahead, Dr. Mubarak.
So the third speaker is Professor Hussein Khalid. He is the former dean of the NCI at the Cairo University, and he will be presenting on how can we define the standard of care for the hormone-sensitive metastatic prostate cancer. So, Prof. Hussein, the mic is yours, and we'll take all the questions at the end of the session.
بسم الله الرحمن الرحيم. السلام عليكم. الحقيقة قبل ما ابتدي I would like very much to thank Professor Sharif Al-Sammani, Professor Hafiz Ghanem, and Professor Mubarak Al-Mansour for inviting me to participate, and other colleagues for inviting me to participate in this important event. And now my presentation will be recorded. Bismillah ar-Rahman ar-Rahim. Before starting my presentation, which will be on, can we define the standard therapy for first-line metastatic hormone-sensitive prostate cancer? I would like to thank the organizers for inviting me to participate in this very important event. Of course, hormone-sensitive metastatic prostate cancer, there is a big picture issues that include it is a heterogeneous disease state, include de novo cases versus recurrent metastatic disease. And also there is a compelling evidence now that antidiuretic hormone plus X is the standard of care. But though this compelling evidence, there is a recent study that found 43% of patients with metastatic hormone-sensitive prostate cancer receive anti-androgen deprivation treatment alone. What is the optimal? X therapy is not based on comparative trial evidence, but requires the consideration also of multiple disease and non-disease factors. And also the role of local radiotherapy in metastatic disease will be discussed, and germline testing is now the standard of care also for all metastatic patients. What we are going to speak on this presentation is about the clinical metastatic non-castrate state, which is the core of the natural path history or pathway of prostate cancer from being discovered from a clinically localized disease to the death from other causes or from the death of disease. There are many reported frontline randomized clinical trial in high volume and high risk disease that include docetaxel in 3 trials, androgen receptor pathway inhibitors in 5 trials, and also 2 studies using radiotherapy in the metastatic disease. And on the right side, you see the hazard ratio for overall survival of these trials. And also for the same low volume and low risk disease, we have the same 3 trials in docetaxel and in androgen receptor pathway inhibitors, and also in radiotherapy in the use of radiotherapy. Now we will come to study or to see them drug by drug. For docetaxel, the charted trial produced a long-term follow-up overall survival of a median of 53.7 months. And it shows clearly that the total patient population benefited from using the docetaxel in addition to ADT, also in high volume disease, but not statistically significant difference in low volume disease. Then the Stampede trial schema, the RMC of this huge study, showed also that the overall survival in metastatic patients were better for those receiving docetaxel with a significant p-value. And however, the GETAG trial have a reverse or an opposite conclusion that overall survival did not differ using or adding docetaxel to ADT or not. And this led the investigators to combine the results of charted and GETAG trial. And as you can see here, the low volume disease did not benefit from using the docetaxel or the combined treatment regimen, while the high volume disease in both produced a statistically significant difference in terms of overall survival. Now we come to abiraterone, which is the second drug. And there are two studies for using this drug in hormone-sensitive metastatic disease. The inclusion criteria two studies are clear here, and for the Stampede trial, the patient was newly diagnosed metastatic disease that was pelvic node positive or high risk, locally advanced with 2 or more high risk features like glycemic score 8 to 10 or T3, T4 this lesion on PSA equals or more than 40 nanogram per ml. In this trial, which included the arm G and the Stampede trial, the overall survival and the failure-free survival in those patients benefited from adding the abiraterone to the ADT regimen. And also the Latitude trial, which included at least 2 of the following 3 features: glycemic score 8 or more and measurable visceral metastasis with 3 or more bone lesions. They show that the radiological progression-free survival in more than 12,000 patients, the radiological progression-free survival and the overall survival benefited from adding abiraterone. And also the BSA progression also showed a difference between the 2 arms. And of course, the Latitude trial in studying the overall survival in high and low volume disease also showed the same conclusion of the previous trial, that the high volume disease benefited while the low volume disease did not benefit. This led us to define what is the high volume and high risk disease. The high volume disease was defined as the presence of visceral metastasis or 4 or more bone metastasis with 1 or more beyond the vertebral bodies and pelvis, while the high risk disease was defined by the presence of at least 2 of the following criteria: glycemic score 8 or more, visceral metastasis, or 3 or more bone metastasis. Then the meta-analysis for the use of docetaxel produced a 9% overall survival benefit in most men, while the meta-analysis for abiraterone produced 14% overall survival, hinting that abiraterone may be better than the docetaxel as frontline. But in the Stampede trial, when we compare the 2 arms using docetaxel versus abiraterone, there was no much difference in overall survival, but we must be cautious in interpreting this because it was underpowered analysis. Then coming to the enzalutamide. The enzalutamide was tried in the ARCHES trial, and you see this is the graph of the randomization arms in this trial. And again, the radiological progression-free survival was better for using the enzalutamide. And if we do a subgroup analysis of this radiological progression-free survival data, we will find that the low volume benefited a little bit more than the high volume, and also no prior docetaxel therapy benefited a little bit more than using prior docetaxel therapy. The time to PSA progression was better also in the treatment in the drug arm, and also the time to initiation of new antiplastic therapy was also better. But the ARCHES showed that the overall survival was not different between both arms. Now, again, came the MET trial, where overall survival rate was studied in 2 arms, using the enzalutamide in 1 arm and the usual non-steroidal anti-androgen drugs like biclatomide and so on. And you see here the overall survival was better than the for enzalutamide compared to the use of the NSAA. Also, the progression-free survival in terms of clinical progression or death or time to clinical progression was also different. And this was not affected by the use of or having patients with high volume or low volume disease, as you can see from this table. However, the enzalutamide was more toxic than the classic non-steroidal anti-androgens, as you can see here from the serious side effects or events rate, especially having causes leading to discontinuation or having hypertension or fatigue. So the conclusion of the ENZAMID trial was that the enzalutamide improved survival compared with the standard NSAA. However, there was increased toxicity that was shown with the addition of enzalutamide as expected. Now coming to the ablutamide, the ablutamide was tried in the Titan trial, which was a phase 3 trial using ablutamide versus placebo, in addition to the ADT, and also the progression-free survival in terms of radiographic pictures was better for the drug. Overall survival, again, was better for the drug with a p-value 0.005. And also the safety was not much different between the two arms, the grade 3 and 4 toxicity and the serious adverse events. So the conclusion of Titan was that in patients with metastatic castrate-resistant prostate cancer, the addition of ablutamide to ADT significantly improved survival, and in addition to prolonging the time to initiation of cytotoxic chemotherapy, and the drug was well tolerated with adverse events consistent with previously reported data. If we use the local treatment, the electron beam radiotherapy, this was tried in 2 trials, the HORAD and the STAMPEDE trial. And in the HORAD trial, there was a significance. Also in the STAMPEDE trial, which was a randomized double-blind phase 3 trial, the results showed improved failure-free survival with a significant p-value, but not the overall survival. And pre-specified analysis of low-volume metastasis group produced improvement in overall survival. What about combination therapy? For example, in the PEACE-1 trial, where abiraterone plus radiotherapy plus standard of care was compared to abiraterone plus standard of care, to radiotherapy plus standard of care, and to standard of care only. And this was in about more 1,000 patients distributed along the 4 arms. And as you can see here, the radiological progression-free survival was better for abiraterone arm, whatever the arm used in it. And also the castrate-resistant prostate cancer-free survival was better using the abiraterone. Also, the clinical progression-free survival was also better. And of course, the grades 3 and 4 toxicity was reported more in the ADT plus docetaxel population compared to the abiraterone acetate. This led the NCCN this year to provide a guideline that showed clearly that M0 cases, the systemic therapy will be either monitoring, which is preferred, or only anti-ADT androgen deprivation treatment only. In M1 cases, which is the case of our presentation today, the NCCN showed that ADT may be used with one of the following. The preferred regimen is abiraterone, ablutamide, docetaxel, and enzalutamide, which are all category 1 significance. Also, the electron beam radiotherapy may be given to primary tumor for low volume M1 cases, or using only androgen deprivation treatment, but this is category 2A, as usually stated by the NCCN. The MD Anderson prostate cancer guidelines showed that in cases with metastatic disease and hormone sensitive, orchiectomy or LHRH agonist or antagonist with or without androgen receptor inhibitors may be used, and we may consider docetaxel for 6 cycles in high volume disease. Coming to the European Association of Urology and ESMO guidelines, as you can see here, I just put the strong ratings, which shows that in metastatic first-line disease, we may offer immediate systemic treatment with androgen deprivation therapy to palliate symptoms and to reduce the risk of potentially serious sequelae. And also, we may offer androgen deprivation treatment combined with chemotherapy to patients whose first presentation is M1 disease and who are fit for docetaxel. Also, we may offer androgen deprivation treatment combined with abiraterone acetate plus prednisone or ablotamide or enzalutamide to patients whose first presentation is M1 disease. And lastly, we offer androgen deprivation treatment combined with prostate radiotherapy using the doses from the Stampede study to patients whose first presentation is M1 disease and who have low volume of disease by the charted criteria. And lastly, we do not offer androgen deprivation treatment combined with any local treatment, whether it is radio or surgery, to patients with high volume charted criteria M1 disease outside of a clinical trial. What about the ongoing clinical trials in metastatic hormone-sensitive prostate cancer? We have the SOG 1802, where the standard systemic therapy plus definitive treatment, prostatectomy or radiotherapy versus the standard systemic therapy. And this trial is ongoing. We have also the SWOG 1216, where androgen deprivation treatment plus TAC 700 versus the ADT alone or ADT plus glutamide, the classic non-steroidal anti-androgen, will be also compared. And in the ARASENS phase 3 trial, the darolutamide will be tried again in the same schedule algorithm. So, the therapeutic making for patients with metastatic hormone-sensitive prostate cancer are based upon disease states and the clinical factors. The clinical factors must include fitness for chemotherapy, fitness of androgen receptor inhibitors, virility and comorbidity, fitness for abiraterone in terms of presence of diabetes mellitus or cardiac history or liver disease, and if there is prior therapy with androgen receptor inhibitors in non-metastatic castrate-resistant prostate cancer. And also the non-AR phenotype is important, where poor PSA expressor and presence of hepatic metastases are usually present. These clinical factors must be put into consideration in terms of or skills of the medical oncologist, because as we see from this presentation that there are many trials or many drugs that can be safely and equally used in treatment of metastatic hormone-sensitive prostate cancer. Also, we have to consider the low volume disease because chemotherapy here is less appropriate and the evidence of using androgen receptor inhibitors and abiraterone are less compelling data for docetaxel in low volume disease, while the high volume disease chemotherapy is appropriate in addition to any of the androgen receptor inhibitors. Also, we have to take the patient preference because the duration of therapy may be also discussed being 18 weeks versus minimum of 2 years. Or if he say, I hate taking pills, I will never take chemotherapy, then we will consider either of which. And also in addition to this, the perceived versus actual quality of life impact is important. The economics, of course, especially in countries with low limited resources, we have to be also considered. So this is the patient preferences. And lastly, there is a compelling level 1 evidence suggesting that the majority of those patients will be receiving ADT plus an additional agent or X agent, as I said in the beginning of my presentation. And by this, I thank you very much for your attention, and I be ready to receive any comments or questions.
Thank you very much, Prof. Hussein, for the nice presentation and fruitful information. The last presentation.
Bismillah ar-Rahman ar-Rahim. Thank you so much for the organization.
Dr. Imad Tashkandi will present the prostate cancer with biomarker mutation. Dr. Imad is a consultant medical oncology at King Abdullah Medical City. Dr. Imad, the mic's with you. Okay, Dr. Imad.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Thank you, Mr. Chairman. And I believe managing prostate cancer is very unique in terms of this population, and also with the advancement of many drugs we have. I also feel that Prof. Hussein have done extremely great job highlighting and going overview of management of prostate cancer, especially the hormone sensitive. And also we will notice that those patients, we do have for them many options, but these options sometimes are not long lasting for many reasons. And this is why we will talk about what happens to those patients in terms of biomarker mutations and what is the future for those people. All right. Next, this paper came out in 2015, and it was a very impressive paper. For us as geo-oncologists, we feel that many genomics are undergoing, and especially why people they develop mutations and resistance. And the key player for that is the androgen receptor pathway. It is the main driver, which is the most active pathway in prostate cancer. Therefore, targeting this pathway can improve outcomes. In some patients, there is also PI3K, which is also activated. And similarly, we have DNA repair. So, of course, there are many other rare mutations, but the focus will be about very common pathways that are targetable. And with this great paper also, we noticed that AR pathway around 70% and PI3K ranging from 4 to 60%. And the DDR, which is the DNA repair, is around 25%. We also have learned over time that these can be used as prognostic, and they do worse when we have those mutations compared to people who don't have those mutations. So this is why we can improve outcome by providing newer targets. I'll spend a little bit of time here because this is the most common one was published in New England Journal of Medicine, and Karim Fizazi did a great job highlighting what's going on. So basically, if this is the androgen receptor, we have the ligand binding domain, and also we do have the DNA binding domain and N-terminal. So in cancer cells who are progressing, what they have, they lost the ligand binding domain. So enzalutamide or abiraterone will not work because we call that the AR/variant. So the newer drugs and the targetable mutations can be used and by inventing molecules that can target the N-terminal domain. So newer medications or newer targets have been proposed, and one of them is the use of proteasome. And this was published in the past ASCO, and we see good PSA changes with this drug. However, these changes, we don't know much about the efficacy and the safety of these drugs for now. What we really know about, if we have wild type AR, and the androgen will work since this is activated. But when we do have a mutation such as this one, or the other mutation as this one, they are activated by corticosteroids and progesterone. So no matter how much abiraterone or enzalutamide or taxane we're using, they will not work simply. So people would like to know, then this is a very complex pathway present in our body. So they're looking and they're developing these drugs to shut off the cholesterol pathway. So many ongoing trials were there to supplement those with essential hormones to overcome those resistance when we have the mutation. In the same side, we want to provide the essential hormones in the body. And they also have looked at the PI3K pathway and the AKT with many targetable drugs. And we have to know that also when we have this mutation here, we also have to give this drug. They have tried giving this combination, and this combination have showed that there is improvement in the radiographic progression-free survival, but however, it's not clinically meaningful. We're talking about 63 versus 64. And the reason why also this is not practice changing, you can see the combination has led to increase in grade 3 and 4 adverse events. Very astonishing result in the past years is the presence of or knowing about the role of PARP in the BRCA mutant population. If we have the double-strand DNA breaks and we have normal cells, then this will lead to damaging repair mechanism activated, and we have the cell cycle going very nicely. But when we have a BRCA mutation, this will not be fixed. And this paper also have been published in New England Journal of Medicine, and we know that germline DNA repair mutations is around 12% in M1 disease, and also somatic mutation in 10% in metastatic CRPC. So putting all together, we're talking about roughly 20%. So when we further divide this into what is the most common, so based on the profound study, they looked at the alteration HR genes, and they tested more than 2,000 patients. And the most common were BRCA followed by ATM, and there are other rare genes. And this study was published by Maha Hussein and presented in the past ESMO. And there was a statistically significant improvement. We're talking about 7.3 versus 3.5, and hazard ratio of 0.3, and p-value was significant. So this is cohort A. When we go to cohort B, we're talking about the non-BRCA genes. And you can see the curve overlay on each other, and that will lead to conclusion that probably this PARP inhibitor is not going to affect the outcome on patients who have no BRCA mutation or ATM. Many molecules have been studied, like olaparib, rucaparib, taluzaparib, and neratinib. All of them, if you look at the objective response rate ranging from 40 to 50, and the PSA between 60 and 70. But when we talk about the rare genes, then we're talking about less benefit. We're talking about 20 or 30%. So this is why these results can guide us on who are the patients to give them the PARP inhibitors. And you can know that also it is around 70% they don't have the HRR genes, therefore will not benefit from PARP inhibitor. Interestingly, you can see sometimes patients who are in your clinic, and that has been published in the literature. They had this MCRPC, they're progressing on post-docetaxel, and they have started, for instance, ipilimumab with XRT. And then they have very undetectable PSA for years. So A study also was then analyzed, and you can see that the green curve is the immune therapy, the ipilimumab. In the beginning, they did not respond, but over time, they have improved, and they have now complete response or good control over 4 years. So we have to know who are those people. And it was published in New England Journal of Medicine, and we know that 2% of prostate cancer, they have the MMR mutations. So probably giving the PD1 and CTLA4 will help those patients. And also another study which have showed approximately, we're talking about 6 to 7% of men have the CDK12 biallelic mutations, which is also tend to respond more to immunotherapy. And this is what we call immunogenic class of advanced prostate cancer. And what we have noticed also, if you have high TMB, those people will have better results. Another shifting paradigm in the management of prostate cancer is the PSMA. And the data came from the Australia and New York in the Memorial Sloan Kettering in USA. The first one was the therapy trial, and the second one was the vision trial. And in the past, ASCO PSMA was also have showed a good result in terms of improvement in overall survival and progression-free survival. So PSMA is not new. It is present there for almost 2 decades. And the Germans have found a ligand for PSMA to bind the radioligand isotope. What they have in the therapy, the Australian study, there is 37% versus 66%. So deep responses and improvement in those people after progressing on many lines. So this was the first the phase 2, followed by the Michael Morris from the Sloan Kettering in the past ASCO, where they tested this protocol combined with the standard of care. And what we have seen, the overall survival benefit and also progression-free survival. So in conclusion, we do have many biomarkers that have led to improvement in outcome in prostate cancer. One of them is the PARP inhibitor. The second one, when we have MSI high, so PD1 inhibitors are using for PTN, AR mutations, and CDK12 still ongoing. And the past ASCO, we have the PSMA lutetium. With that, I conclude and thank you.
Thank you, Dr. Ahmad, for the nice presentation. Do we have a question in the system or Dr. Mubarak? Any question, please? Okay.
Thank you so much for all the speakers. Excellent, mashallah, tabarakallah, session for the GU, covering most of the topics. I have a question for Dr. Tijani. Amin, are you still with us?
Yes, Dr. Mubarak, go ahead. Yes.
So can you just elaborate more on those patients who received epidemiology post, let us say, a PR or a CR, platinum-based chemotherapy, and they progressed in the future? What will be your option based into the available data?
Actually, there is no available data now to say what we will give after immunotherapy. So if the patient receive platinum-based and then maintenance immunotherapy in the second line, I don't think there is a role to give immunotherapy here again, even to change to other like Pembro or Atezo. So I think those patients, it is better to do for them the FGFR, and if there is alteration, they will be candidate for erdafitinib. Otherwise, also we have the antibody drug conjugate, like enfortumab vedotin, can be option, or chemotherapy also. Chemotherapy here may be another option to give for this patient. But I don't think immuno here will be appropriate.
Thank you. Prof. Yusri with us? Prof. Yusri? Okay. For Prof. Hussein with us?
Yes.
Thank you, Dr. Hussein. Actually, regarding the prostate cancer, Now we have many hormonal treatment and we have the chemotherapy. So regarding the chemotherapy, in your practice, Prof. Hussein, do you think still we need to use the chemotherapy, and which patient is suitable to start with docetaxel rather than the hormonal treatment?
As I said in my last 2 or 3 slides, that we have to consider many aspects before deciding on which treatment we are going to give. And most importantly are the clinical factors. So if the patient has a high volume disease and is have good fitness for chemotherapy, and there is no room for using highly cost drugs, then docetaxel will be fine to start with, or even cabazitaxel. But in case of there is no option for chemotherapy, and the economics allow giving high price drugs, or if we have low volume disease, then we may go to the androgen receptor inhibitors. And for me, as in my personal experience, I usually start with androgen deprivation treatment and give the non-steroidal anti-androgen receptors inhibitors. And I have many patients that are living for many years using this easy and less expensive treatment, just the ADT plus the androgen receptor inhibitors and non-steroidal. Of course, the ablutamide is also one of the choices because it is, in my opinion, the least toxicity possible. So the room is open for any kind, and من رحمة ربنا, and we have many options and many drugs, so we can tailor the treatment according to the patient needs, costs, and his general condition.
Thank you, Prof. Hussein. Prof. Yusri, with us?
Yes, sir, I'm with you.
Regarding the first line RCC, also, we have now 4 options, and all of them, they are effective in the treatment of metastatic RCC. Actually, the usual question, how you select your patient and which combination in your practice may be the best?
I think the best combination regarding side effects and results of response and progression-free survival and overall survival is axitinib pembro. Why? It gives a very high response rate and with very acceptable side effects.
So you preferred the TKI immuno rather than immuno upfront?
Yes, as I showed, the TKI immuno gave a better overall survival, better progression-free survival, and even better response rate. But the advantage of immuno is only the durable response. When you have a patient who responded to immuno, usually the duration of response is prolonged.
I have one question to Dr. Imad. Excellent presentation, very important topic in the landscape of the management of the prostate cancer. So, and Dr. Imad, in your practice, where do you put this targetable mutation as part of your management, and when do you decide to do the genetic, let us say, testing, either with the foundation one or just doing the BRCA 1 and 2 and ATM?
So this is a very nice question, because if we talk about the evidence, I think we have to test all people from the beginning to know about the targetable mutations and to use the effective drug based on that. if we talk about what we currently have, we do have access to the BRCA, and I haven't yet tested it anyone, but we are in the process of approving that in our institution. So first line we will be the way to go. This is one thing. The other thing is also how can we make that very simple in terms of the process. So this needs also pathology in the center also to get that test done easily. I think for now I have not tested anyone till now. Maybe others can tell us more.
I think Dr. Abdullah Sharm is raising his hand. Abu Badr, any question? Abdullah, are you with us? Well, this is from the previous maybe session.
I have a question, Dr. Mubarak.
Sure.
Dr. Hani.
Yeah, my question to Dr. Amin. As you know, Dr. Amin, we have limited kind of treatment options for bladder cancer, and the evolving drugs even limited for certain mutations. And as we know that in ineligible platinum-based or patients for platinum use, we can go for immunotherapy in first line if they are PDL positive. Suppose that you have in your clinic a patient with PDL1 negative and you gave him different chemotherapy and came back after a while after progression for second line. And we know from the beginning that he is negative, was negative. Still, can we use nivolumab, for example, because as we know from Checkmate 275, irrespective of expression. Please.
Thank you. Thank you for your question. This is an excellent question. Actually, here the PDL1, we are doing it for cisplatin ineligible in the first line. In the second line, I will give the treatment regardless of doing the PDL1 testing. And it shows, actually, it shows in most of these trials, there is a response in the second line. And this restriction for the positivity, I will use it only in the first line.
No, I mean, if the patient is known to have PDL1 negative when initially, are you still going to use it in the second line?
Yes, I will use it. There is nothing say that I should not be using the second line if it is PDL1 negative. I will use it in the second line, yes.
Okay. I have a question for Dr. Imad regarding the PARP inhibitors. You know, if you have the test HRR, and I think we have now, and you have the BRCA1, BRCA2, and ATM, you know, this is a group A. Which patient you'll use PARP inhibitor? Is it BRCA1, BRCA2, or ATM? Still, you will use in the ATM group?
So that's again a very nice question, because based on the profound trial, there was a clear benefit in this cohort A. So this will lump the BRCA 2, 1, and ATM. Now, if you talk about ATM specifically, then this is less common. And based on the current data, we don't know if they respond or not. So for now, we will treat them as cohort A. This is my view about it.
Dr. Faisal?
Go ahead, Dr. Hani.
Yeah, Dr. Mubarak, regarding your question about use of where to use like this newer medication for certain mutations. In my opinion, that I have a comment for this, just because of the current proven data about the first and second line use of different drugs with major studies. I think with limited data about these drugs, new drugs, to keep them at the end after failing certain current standards until further studies or clear studies sharing these drugs with the certain mutations in the first or second line. I don't know if you have any comment on this, Dr. Mubarak.
Agree with you. Actually, after failure of the hormone treatment, this is the recommendation. We test patient for HRR testing, and if the patient failed first-line hormonal treatment, then we have the option to start PARP inhibitors in the second lines for those patients with positive mutation, specifically BRCA1, BRCA2. Any questions? I think
yes. May I have a question to Dr. Amin?
Okay, Prof.
Thank you for your presentation. I just want to know, have you tried the use of immunotherapy in squamous cell carcinoma of the bladder rather than the transitional cell carcinoma?
Yes, I use it actually for one or two patients in the second line, yes. And it showed there is a response, the patient responding for I cannot recall now exactly when he progressed, but there is some response. Because as you know, squamous cell carcinoma, most of those cases are not included in these clinical trials. So actually, practically, I use it maybe two patients.
Okay.
I think at the end, I would like to thank all the speakers and all the audiences. And I would like also to نسلم على البروف يسري والبروف خالد إن شاء الله. We'll see you إن شاء الله in face to face بمشيئة الله يعني في next conferences.
إن شاء الله.
إن شاء الله. أشكركم جدا و I really enjoyed all the meeting. Thank you very much ونلتقي قريبا لايف بإذن الله.
إحنا نتمنى نشوفكم في مصر إن شاء الله بإذن الله تشرفونا. نسعد جدا بوجودكم معانا.
شكرا.
Thank you again. Thank you, Dr. Hani, Dr. Mubarak, Prof. Hussein, Prof. Yusri, Dr. Amin. By this, we end the GU session. The next session will be a satellite symposium. Actually, Dr. Mubarak al-Mansour, well-known consultant, medical oncologist, and he is the head of Oncology Center at the Princess Noura Oncology Center. Dr. Mubarak al-Mansour will speak about the new strategy in management of muscle invasive bladder cancer. Dr. Mansour.
الرحمن الرحيم والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. I would like to thank the organizing and the scientific committee as well as BMS for the kind invitation. This is my topic today is on the new strategies and the management of muscle invasive bladder cancer. Usually this topic is a little bit complex in the time being with a lot of data into the immunotherapy, but still standard of care not changed yet. And as well as it's not covered in most of the topics or GU conferences. So hopefully the review will be more into elaborate how what is the current practice for the management of the muscle invasive bladder cancer and immunotherapy into the MIBC, and also a few slides into the incidence and mortality. So just to set the ground for discussion later on. GloboCan worldwide in 2020, about more than 500,000 cases for the bladder cancer that accounts for about 3% of all the cancers worldwide, with more than 1/3 of death for those cases accounts for about 200,000 cases. Median age 69 in men and 71 years in women. In Saudi Arabia, according to the GloboCan, the new cases is estimated to be about 881. 3.2, it ranked the 10th, and the about 1/3 also, or 3% causes of death among all the cancer causes of mortality. This is the description of the bladder cancer. This is just to know exactly what are we talking about, but usually majority of the blood cancer are urothelial, and I will explain more into the second slide. But this is how we're talking about the muscle invasive. This is the transitional epithelium, and this is the papillary. This is the superficial, or we'll call them non-muscle invasive bladder cancer. When the tumor extends to have the muscle, or beyond that, we call them a muscle invasive bladder cancer. And bladder cancer classified as one of the highly immunogenic, and that's why the immunotherapy were tested in this cancer, and that was based into the previous evidences from the spontaneous regression of the tumor of the bladder cancer, also the responsiveness to the intravesical immunotherapy with the BCG, also evidence of the tumor T cell infiltration within the tumor. So the histology of the bladder cancer, 90%, those are the transitional cell carcinomas. That could be mainly a lower involvement, which is the bladder, or upper with the renal pelvis, which account to about 8%. The other non-urothelial histology, about 10%, and majority of them are squamous cell carcinoma, about 5%, and then adenocarcinoma and small cell carcinoma and non-epithelial. So majority are transitional cell carcinomas into originate primarily into the bladder, in the urinary bladder. This is the definition of the non-muscle invasive and muscle invasive resectable, or muscle invasive non-resectable, locally advanced or metastatic. So if we take the non-muscle invasive bladder cancer, those are the T1, which just only the mucosa extended to the mucosa and subepithelial. Those patients have a 5 years old survival rate more than 88%. While the muscle invasive bladder cancer, including the T2, T4, N0, or only minimally involved lymph node, and the overall survival 5 years is 50%. Those beyond the muscle invasive and resectable locally advanced, talking about a 15% overall survival at 5 years. This is the muscle invasive bladder cancer. So in all the comers with a urothelial cancer, we have a 20% of new cases with the muscle invasive. Those are the T2, which we are talking about, to the T4, including that's the tumor size with the sometimes in one or minimally involved lymph node. 50% is the risk of metastasis post local therapy, primarily radical cystectomy. So there is still a high chance of metastatic disease, and that's unmet need. That's why most of the evidence is about the immunotherapy or the chemotherapy, either were systemic to control the micrometastasis, is ongoing. Platinum-based, primarily with the cisplatin, is the only therapy demonstrating a survival benefit. And if we go to the new adjuvant cisplatin-based chemotherapy, we have many studies done in the past with the different sample sizes, with the different phase 3 and phase 2 studies. The 5-year and the 10-year overall survival were ranging from a 5 to 8% benefit, supporting the superiority of the platinum-based chemotherapy as a new adjuvant prior to the radical cystectomy or to the concurrent chemoradiotherapy. This is a new adjuvant meta-analysis, more than 3,000 patients included. The conclusion from that study with the platinum-based combination that the overall survival benefit at 5 years was 5%, from 45 to 50%, and the disease-free survival about 9%. So that set the platinum-based as a standard of care for the new adjuvant chemotherapy. For the adjuvant setting, that is now not a popular option, especially for those patients who received new adjuvant chemotherapy. However, because most of the studies are underpowered or incomplete, and there was no overall survival in majority of those studies, and this is one of the adjuvant also meta-analysis for those patients who received adjuvant. There is a trend 0.04 0.9. That was the p-value for that study. So there was no a clear benefit of the overall survival with the adjuvant, even platinum-based. And that's if you go to the European Association of the Urology Summary of Evidences and Guidelines for 2021, new adjuvant cisplatin-containing combination improved the overall survival from 5 to 8% at 5 years, and that have a major impact into the overall survival. However, adjuvant cisplatin-based chemotherapy just only can be considered for those patients with a T3, T4, or lymph node positive if no new adjuvant platinum-based chemotherapy was given. So that's the only group. And that takes us to the checkpoint inhibitors in a muscle invasive. If you go just to review the evidences, it's very confusing and very complicated. So I put them in 3 categories: new adjuvant, bladder preservation, or adjuvant. If you go to use the immunotherapy as a new adjuvant, then that's we have evidences from a single agent, which we're gonna see, or doublet immuno, or the checkpoint inhibitors combined with the platinum-based chemotherapy and followed by radical cystectomy. And this is one of the major areas in immunotherapy into the muscle invasive bladder cancer. Also, immunotherapy was tested as part of the bladder preservation strategies where checkpoint inhibitors were added to the concurrent chemoradiotherapy, and those patients who achieved a CR either had observation and no further local therapy, and if they did not achieve a CR, then they proceeded to have a salvage radical cystectomy. Our talk today will be also about the adjuvant post-new adjuvant chemotherapy or no new adjuvant chemotherapy for the immunotherapy as adjuvant strategy. So let us start with the new adjuvant checkpoint inhibitors. We have a single agent. We have the Pembro and Atezo in 2 phase 2 studies. For the immuno, we have the immunopreserve trial with the durvalumab plus tremelimumab, and for the chemo checkpoint inhibitors, we have the Gemcitabine plus Atezo, we have the Nivo plus Gemcitabine, we have a Pembro plus Gemcitabine and concurrent chemoradiation, or we have a Gemcitabine or Paclitaxel plus Avelumab, which was just presented in this ESMO. To take the 2 single agent immunotherapy were tested before the radical cystectomy. We have 2 studies. One of them, they call them Abacus, which is the Atezo, and the other is the Pure. Both were given for 2 to 3 doses prior to the radical cystectomy, and the primary endpoint was the pathological complete response. So if we take the Atezo study versus the Pembro, they have more or less the same eligibility criteria, T2 to T3. However, 2 to 3 cycles were given for the 2 immunotherapy in each study. The complete pathological response, just to make it memorable, is about 40% with the Pembro and 30% with the Atezo. We cannot also, cross comparing the 2 studies, but when you compare that pathological complete response with just only 2 to 3 doses of immunotherapy before the radical cystectomy, almost comparable to the dose-dense MVAC chemotherapy or Gemcitabine. So this is a chemotherapy-free protocol which can save a lot of toxicity as using a single agent. The second checkpoint inhibitors study was the durvalumab plus the tremelimumab, which is immuno, that was given at 2 weeks prior to the radiotherapy as a concurrent. And then later on, there was a TURB response assessment for those patients, was given for 3 cycles, that combination. And those who achieved the complete response, they had a bladder preservation, nothing done as a local therapy, while those no CR proceeded to have a salvage cystectomy or radical cystectomy. About 32 patients enrolled in that study. The complete pathological response achieved up to 80%. So that's a measure. I mean, we know it is still too early for those studies, but those are signals about the activity of the immuno as part of the systemic therapy and new adjuvant for those patients going for a local therapy. Overall survival and disease-free survival, about more than 87% overall survival and 76% disease-free survival at 12 months. The second study I'm presenting is the Pembro in a combination with the GEM, and that combined with the concurrent chemoradiation. So this is a bladder preservation technique. This is a phase 2 study. So the Pembro was given 2 to 3 weeks, and then a maximum TURBT, which is the tumor resection of the bladder cancer. And then after 3 to 4 weeks, the GEM was given as a chemosensitizer with the chemoradiation, and then a Pembro was given for 3 doses. And 12 weeks later on, there was assessment. So Pembro was given here 1 dose and here 3 doses. So a total of 4 cycles of Pembro plus a GEM and concurrent chemo radiation. The complete pathological response was about almost 60% in that study, and the 1 year estimated a bladder intact disease-free survival, which there was no bladder tumor, is about 88% in that group. The HCRN study is more or less the same design with the other studies. We have a GEM plus CIS plus Nivo. Here it was given for 4 cycles as the new adjuvant. The only intervention was the Nivo was added to the GEM CIS. And then a clinical assessment was done. If they achieved CR, no cystectomy. If no clinical CR, then radical cystectomy. They had a 76 patient in that group. Majority of them are T2 and T3. So if we take about the 76 patients, those who received the GEM CIS plus Nivo for 4 cycles, about 64 patients, 50% of them, they had no radical cystectomy. So the complete pathological response was about 48, and that is a very impressive results, which you can save about 50% if you're patient from going to a local radical cystectomy. You can see those patients with the red in color. There is no evidence of recurrence, while those with the black arrow are still alive. So those are for the 31 who achieved a clinical CR. Atezo also was tested with the GEM and cisplatin, more or less the same as the Nivo study. It was given initially as a cycle, 1 cycle Atezo, then combined with the GEM CIS, the usual doses that we used into the new adjuvant, plus Atezo for 4 cycles, then another Atezo. So a total of 6 Atezo, like a sandwich, Atezo, and between them Atezo plus GEM and CIS. Also pathological response about 69% in those patients received the immunotherapy as part of the new adjuvant protocol. This is a study presented in the last ESMO, just a few weeks, avelumab as the new adjuvant, and again with the platinum, either eligible or ineligible. So they have a 2 cohort, cohort 1 and 2. Cohort 1 is those who are eligible to receive a cisplatin plus GEM or the dose-dense MVAC. The avelumab was added in those patients, and it was given for the total of 4 cycles at the usual. Those patients who were not eligible for the cisplatin, they received either paclitaxel plus GEM plus avelumab or just only avelumab. That's a cohort 2, and then followed by radical cystectomy. This is to indicate the clinical stage. But the overall response rate, pathological response, achieved a 60% in all the cohort, and this is especially that the cisplatin eligible with the dose MVAC was higher compared to the GEM CIS. So those are the new adjuvant immunocheckpoint inhibitors. As well as the outcome, we have seen that the primary endpoint, majority overall response rate with the pathological response rate, and we have a very impressive and promising signals that those patients who might receive the immunotherapy as part of their new adjuvant protocol will have a major impact into the local therapy. The last part is the adjuvant checkpoint inhibitors. We have 3 studies. The first is the InVigor 01. 010, and the primary endpoint was the disease-free survival. We have the Checkmate 274. Also, the endpoint was disease-free survival in those expressed a PD-L1 more than 1%, and still waiting for the result from the Ambassador study. The first study, which was the InVigor, those included the patient. This is adjuvant setting. So those patients already had a radical cystectomy and received also new adjuvant chemotherapy, or maybe did not receive the new adjuvant chemotherapy, but they have a higher risk at the radical cystectomy, which is T3 or T4, randomized either to atezo as a maintenance here for a 1 year, or adjuvant given every 3 weeks, versus the observation, and the primary endpoint was the disease-free survival. This is the baseline characteristics. This is a phase 3. We have more than 400 in each patient, in each group. You can see here the bladder, which is the lower, was a 93, and they included also about less than 10% of the upper tract with the TCC. Majority of those patients are T3 or T4, primarily T3, and those who are less than T2, about 52. So majority less than T2 for this is maybe important later on when you compare it with the Nivo. The study was completely negative, so it didn't show any disease-free survival by giving the atezo as adjuvant in those patients. No also disease-free survival benefit into the PD-L1 status, and no also a subgroup benefit was found in that study. Overall survival also was negative. The nivolumab, which is the Checkmate 274 trial of adjuvant nivo versus placebo, and those patients underwent a radical surgical or high muscle invasive, and you know that's the mechanism of the nivo. It blocks the PD receptor both into the bonding the T cell to the dendritic or to the tumor cell. The study design included, this is a phase 3, it was a double-blind study, multi-center, adjuvant nivo versus placebo. They included a patient with the T2 to T4 muscle invasive who had new adjuvant cisplatin, or those patients with a T3 to T4 or node positive without a prior new adjuvant cisplatin, or were not eligible or refused adjuvant cisplatin chemotherapy, radical surgery within the past 3 months, and the disease-free survival of 4 weeks of dosing. It was randomized to the Nivo, the usual dose, 240 every 2 weeks for a 1 year, or placebo, and the primary endpoint was the disease-free survival into the intention to treat, or disease-free survival in all the randomized patients with a PDL more than 1%. The study included here, if you compare that to the baby InVigor, more of the upper tract, also they included about 20% compared to 7 or 8% into the InVigor, and also the urinary bladder about 80%. The PD-L1 expression was about in 40% of those group, and the new adjuvant cisplatin was given in about 43% compared maybe to the 48 into the InVigor. So disease-free survival was clearly superior with the 1 year of Nivo with the hazard ratio of 0.7, so a 30% reduction into the risk of relapse when Nivo was given as adjuvant, and that was more evident with about 47% reduction when those with the PD-L1 expression more than 1%. The disease-free survival was evident also in majority of the subgroup analysis, including the patient who had also new adjuvant, or those with the PD-L1 expression, or those who were randomized days after the radical cystectomy. So non-urethral tract recurrence, this is one of the primary endpoints usually we see with the muscle invasive. Also the hazard ratio about 28% reduction into the risk of non-urothelial tract, and was a more about 46% in those expressed the PDL more than 1%. Distant metastasis was also reduced by adding the Nivo as adjuvant for 1 year with the hazard ratio of 0.74, and about 40% also reduction in those with the PD-L1 more than 1%. The health-related quality was not affected by giving the Nivo, and there was no deterioration compared to the placebo. So the summary that adjuvant Nivo significantly improved the disease-free survival, also improved the secondary endpoint, which is the disease or the distant metastatic-free survival. The safety was very well tolerated and no deterioration into the quality of life. And that results support that the Nivo monotherapy as a new standard in the adjuvant setting for those patients with a high-risk muscle invasive after radical cystectomy, regardless of the PD-L1 status. Those are the ongoing immunotherapy. We can see how complicated is this area. We still see in the new adjuvant into the bladder sparing and to the adjuvant still waiting for the ambassador study. So with that, I will conclude my talk that the benefit for the adjuvant therapy alone remains controversial. The IMvigor is negative while the Checkmate is positive. So waiting for another study with the ambassador to see where are we going with this new strategy in the management of muscle invasive and encouraging data into the new adjuvant setting. So waiting for more of the randomized clinical trials. We sure need a longer follow-up on biomarkers to predict the outcome recurrence. And with that, thank you for staying till this time. And I hope I didn't take long time, and I will be happy to take any question. This is the risk minimization for the Nivo and how to report the side effects. Thank you so much.
Thank you. Thank you, Dr. Mubarak. Any question? Actually, I have a question. You know, now still we are using the new adjuvant chemotherapy followed by surgery. Do you think the strategy of using new adjuvant chemotherapy followed by cystectomy better, or saving the chemotherapy and giving those patients high risk a Nivo at adjuvant setting?
That's, I think we have to wait for this. So what I am expecting is, as we said, we're still waiting for this PIMPRO trial to say where are we in the term of the adjuvant. For the time being, the standard of care is the new adjuvant cisplatin followed by the radical cystectomy or a concurrent chemoradiation preceded by the new adjuvant. So we don't have evidence at this time to say we can omit the new adjuvant chemotherapy and then go directly to radical cystectomy and give adjuvant, while that was as part of the inclusion criteria. But I think at the time being, if those patients did not receive new adjuvant chemo and after radical cystectomy they are at a higher risk, I will still consider adjuvant chemo at the time being, and I wouldn't change my practice until we have more evidences for the immunotherapy.
Thank you. So still we are using the adjuvant chemo and the new adjuvant chemotherapy. I have one question actually. You know, there is a small study around, I think, 50 patients. They looked for the type of bladder cancer, new described the Cowden law versus the basal luminal, it's like the breast cancer. Any data in the adjuvant setting, immunotherapy, looking for those subtypes, or we don't have data? Because we know the Cowden law type, they are immunogenic tumor. And actually in this small new adjuvant Nivo study, they found the best patient responding for new adjuvant immunotherapy, those Cowden law type. Do we have data in the immunotherapy, even the new adjuvant or adjuvant, looking for those subgroups?
This is an excellent question. I think biomarkers will be as one part now for all the studies with the immunotherapy. And we know the biomarkers into the era of immunotherapy was not very consistent from one side to another, and even within the same site. So we know in other tumor we are treating without a biomarkers, and other like a lung cancer we have to use the also biomarkers. One of the things is the maybe the genomic alteration into one of the studies with the pure study with the PIMPRO. the response rate was higher with the patient with the DDR or the retinoblastoma genes. And it was also higher with the atezo with the PDL1. However, that genomic, I think it's still very complex and very difficult to understand and very difficult to have it as very consistent into the practice. We've seen that paper and the study, and they divided to the luminal and the Claudin and all these things, but still you cannot use it as a predictive biomarkers to guide therapy in the future at this time.
Thank you. Any further question? I think it's clear. Thank you, Dr. Mubarak. Thank you very much for the nice presentation and fruitful information. By this, we finished our last session. Dr. Sharif Sammani, for closing remarks, please.
Thank you very much, Dr. Faisal, Dr. Mubarak Al-Mansour, for the very nice GU session and then the satellite symposium. And I think it's time to conclude this year. It was the fourth year in row for Debates on Oncology Conference. I would like to thank all the speakers and moderators who joined this conference, and it was actually very fruitful sessions and discussion. I would like to thank my dear colleague, Dr. Hafiz Ghanim, the head of the organizing committee, for his continuous support to this conference each year. And of course, I would like to thank our colleagues for pharma companies who supported this event. Thank you very much for your kind support for the event, actually. And of course, our dear colleagues from Event to Truth, they make great efforts for the success of this conference, as usual. My friend Mustafa, Rami, and all colleagues, thank you very much. And of course, our collaborators as Saudi Society of Internal Medicine. Next year, I hope, inshallah, we'll meet face-to-face all speakers and moderators after the pandemic is over. See you, inshallah, next year, inshallah. And thank you very much all. Thank you.